I can't hear you. Pavan, I can't hear anything. Manit, you can hear me? Yeah, I think it just came. Just a moment. Mhm. Yes. Okay, I think I can go ahead and make my. Is it my turn to make? You can't hear me. I'm getting a very faint audio, but I can barely hear you. Can you hear me? Yeah, yeah, sure. Hello, can you hear me? You can hear me? Okay, I barely hear anything from your end, but anyway, I'll go ahead and make the presentation, but I can't hear you. I can't really hear from the auditorium. I'm not hearing. I can't hear, but I can just go ahead and make my presentation if they say it's okay, but I can't hear. Acha, theek hai. I hope you can hear me. Somebody needs to. Can you hear me? Just raise your hand. I can see the chairpersons. Okay, I'll go ahead and make the presentation. I can't really hear anything from your end. If you can see my slides and hear me, just raise your hand. Dr. Kim, can you? Okay, right. Thank you so much. Okay. I must thank the organizers and the North Zone for giving me an opportunity to speak today. And the mandate which I have been given is to speak on low urinary tract symptoms in young men. Now, why is this subject important? It's important because lower tract symptoms affect about 50% of the general population of young men. You can see here that in a large population-based study, storage symptoms were noted by over one-third of men and voiding by about one-fifth. And about half the men in the general population reported lower tract symptoms. And this is in the age group of up to 39 years. However, a recent review which examined lower tract symptoms in young men had 32 references, and not a single reference actually was specific to a study which addressed this cohort. So, although we all the time come across young men presenting to us in the OPD, it's astonishing that there's such a large information gap that we do not have any data which specifically examines this patient group. So many overlapping morbidities remain unstudied in terms of the association of lower tract symptoms with sexual symptoms, bowel symptoms, pain, bladder, or otherwise. What are the patient's perceptions of bother with their bladder problems, and how does it impact their quality of life? Now, for this reason, the functional urology section designed a study to address this knowledge gap. And this was a prospective study conducted across 16 centers. Many of the participants and authors of this study are actually sitting in your room there, and I acknowledge all their seminal contributions to this work. We had 448 men from 16 centers between the age groups at 18 and 40. And you can see here that there's a small proportion were hypertensive and diabetic, and a history of urinary tract infection reported by 1 in 6, and hydronephrosis by about 6%. So, what symptoms are common in young men who present with lower tract symptoms? And you can see here the two commonest symptoms are nocturia, when you define nocturia as getting up at least once in the night, and a feeling that the bladder has not emptied completely. So the two commonest lower tract symptoms with which men presented were nocturia more than one every night and a sense of incomplete evacuation. But which symptoms bother men the most? And you can see here the two most bothersome symptoms, and these are defined by the median score of the ICIQ LUTS. And I must just elaborate a little bit how we did this. We used the ICIQ male LUTS questionnaire, which is a validated questionnaire and has 13 questions. Each question has two parts. There is the first part as to whether this how common the symptom is, and a second part as to how bothersome the symptom is. And you can see here that daytime and nighttime frequency were the most bothersome symptoms, with a median score of 5, with a maximum possible score of 10. And you can see here that severe bother also was reported by about 1/4 of men related to daytime and nighttime frequency. So the most bothersome lower tract symptoms in young men are daytime frequency and nocturia. Then what about associated symptoms? Sexual function. And you can see here that erectile dysfunction and premature ejaculation were both fairly common. And remember, to enter this study, patients needed to have a primary symptom of lower urinary tract symptoms. So if their primary problem was erectile problems or premature ejaculation, and they also happened to complain of lower tract symptoms, they were not included in this study. So these were men who primarily reported LUTS, and you can see here fairly common to get problems related to sexual intercourse. Abnormal erections were reported in by about half the men, and abnormal control over ejaculation by about 3/4 of men who presented with lower tract symptoms. How much was the impact on the quality of life? And you can see here in terms of patient perception of their bladder condition, a significant proportion, almost 1/4 of patients actually reported severe or very severe problems with their bladder. But in terms of the impact on general well-being, the impact on general well-being was not that severe. So you can see here that patients did report severe and many severe problems, almost a fairly large proportion of patients. But in terms of their not feeling good all the time, which is what this WHO well-being question 1 reported, these are all validated questionnaires. You can see here the general well-being was not that severely impacted. So there was moderate to severe problems associated with the bladder in about 1/4, and the impact on general well-being was less pronounced. What about pain? And this is something that is less well explored in young men. And you can see here we use two questions, both from the interstitial cystitis symptom index and problem index. So these are the original O'Leary-Sant questionnaire, and we use question 4 from each of these two, which reflects pain and the bother with pain. And again, you can see here fairly common to get both pain as well as fairly common to get bothersome pain. We also used one non-validated questionnaire, and this was non-bladder myofascial pain, and we gave a visual analog scale of 1 to 10 for these patients, which we clubbed into mild, moderate, and severe. And you can again see here that moderate to severe pain was fairly common, 1 in 6 men. So what we can see here is that pain, both bladder and non-bladder, is common in men who present with lower tract symptoms. What about some of the other findings? So there are a lot of other findings from this study, and I'm only going to summarize a few of them here. Bowel symptoms were common, constipation in about 1/4. But more importantly, loose stools in about 13%. And although I have not presented the data here for it, a lot of the severe problems which are associated or which were noted by young men with lower tract symptoms seem to be more closely associated with loose stools rather than with constipation. And this is something that we don't often recognize. However, the stools classified, these were classified by the Bristol stool chart. And those who reported 5, 6, and 7 on the Bristol stool chart were categorized as loose stools. In terms of the median flow rate and the residual urine, you can see here that the median flow rate was a 15, which is normal, and the median PVR was 35. As you would expect, all the voiding symptoms were associated with slow flow, but there was also an association of urgency, a leakage on straining, and enuresis with low flow rates. We did analyze the impact of a long duration of symptoms on the various symptoms, and long duration here was defined as more than 12 months, and this increased the odds of urgency incontinence by 27, enuresis by 19, and so on. This might imply that patients who have urgency incontinence and enuresis are more likely to be refractory and hence are having longer duration of symptoms rather than these patients neglecting their symptoms for a longer period of time. Because when we say that the duration was more than 12 months, this is the duration at which they presented to us for the study and doesn't necessarily imply that they didn't try treatments elsewhere before they came. So, to summarize some key points with regard to lower tract symptoms in young men, frequency, both day and night time, is the most bothersome lower unit tract symptoms in young men who present to the urology OPD. Associated symptoms pertaining to sexual function, bowel symptoms, and pain are quite common in these young men. The odds of finding urgency urinary incontinence and enuresis are particularly high in young men who present with long-standing lower tract symptoms defined as more than 12 months of symptoms. Our current EAU guidelines fails to include pain, bladder or non-bladder, in the algorithm for lower tract symptoms for men. And I must note at this point that we do not have a USI guideline that addresses this subject. With that, I will stop my screen share and I would again apologize because I'm not getting an audio, but I can put in a call to maybe Pawan perhaps. And in case there are any questions from the audience, you can perhaps route it through him. Hey, Pawan.
Questions for Dr. Sanjay Sinha?
Oh, I can hear you now. Kim, go ahead.
Yes, I'm just waiting for some questions.
Oh, okay, right.
Hi, sir. Any association of irritable bowel or inflammatory bowel disease with these lower urinary tract symptoms?
Okay.
And whether treatment of bowel disease improves these symptoms?
So with regard to the first part of your question, when we say loose stools in the Bristol stool chart, it was 5, 6, and 7, but this does not really tell you whether it's IBS or what's the underlying diagnosis. All it tells you is that they have an increased frequency of stools and the stool consistency is loose. So really, there was an association with loose stools that might imply an association with IBS or IBS-like symptoms. But as such, these were not defined. We did not have a stool-related diagnosis for these patients. With regard to your question as to whether management of stools improved symptoms, that was not something that we studied because this was a cross-sectional study. And we really don't know whether there's a causal association between the loose stools and the lower tract symptoms or not.
Sanjay, why is there an increased association with diarrhea, low stools in young people, whereas you don't find that correlation in elderly?
Right. I mean, the first step, Professor Kim, is understanding what we find. So this is a kind of, you can say, an exploratory cross-sectional survey. And then comes the question to address what we have found. So far, there is no real large study from anywhere in the world on lower tract symptoms in young men. So now that we have a study, hopefully from this point, we would need to try and analyze causal relationships and try and see why these things happen. So really, this study can't address why.
Is there any role of bladder retraining in the younger population?
So again, from our experience with bladder training in terms of storage symptoms seems to suggest from the general data that bladder training helps patients who have storage symptoms. And I see no reason why young men would be different from the others. But as I said, this study didn't address therapy, and hence we can't really answer your question based on the study that we did. But since this lecture is not just on my study, so let me answer the question differently. That the data seems to suggest that storage symptoms improve with bladder training, and I would say that having a bladder diary and a bladder diary related bladder training is a useful component of both management of especially storage, but also voiding. Because some patients who have, let's say, for instance, detrusor dysfunction, etc., overloading with fluid can be an important association or a contributory factor to voiding symptoms as well.
So one question from Dr. Kamal from Jalandhar Patel Hospital. How frequently, sir, you add anti-anxiety medications to a patient who is anxious and in young male, I mean, how frequently you encounter those patients?
Right. So there are a lot of questions built into your question, Kamal. So the first is, how do we screen for anxiety? So we don't have good, let's say, guidelines to recommend what we should do. So there are certain simple questionnaires. So there's a two-question GHQ, I'm forgetting the exact abbreviation, two-part questionnaire for looking for affective symptoms along with the LUTS. That seems to be the simplest method to do it. But we have no guidelines as to should we screen patients for affective disorders, including anxiety? Who should do the screening? If we do find something, are we supposed to send them to a mental health specialist or treat them ourselves? How would patients react to the screening for mental health conditions when they come to you with lower tract symptoms? There are a lot of issues in terms of this. But if somebody does have a component of anxiety, the best would be, if it's a well declared upfront thing, it would be to actually discuss whether they want to consult a mental health professional. Because giving a medicine for anxiety is not the first step in treating somebody who has anxiety. But if it's something that is not, let's say, out in the open, and you sense that there's anxiety, and many of these patients might have a component of overactive pelvic floor or pelvic dysfunction, pain, and so on, it's reasonable to add, say, amitriptyline, and that is a drug that is commonly used now by urologists. But as I said, pain is not there figuring in the guideline algorithms right now, and I think it needs to, because pain seems to be common, and one of the medicines we use to treat pain is actually anti-anxiety medications like triptamine.
I think it's excellent, Dr. Sanjay Anil Varshne here.
Hi, Dr. Anil.
And the question which has been raised, that what is the major difference between a younger man and elderly, and why it is being noticed now more. So it all, I think, is dependent upon the sympathetic overactivity. The expectation from younger people are so much, and the sympathetic overlay, and as somebody has already highlighted, the anxiety component. So the personality traits and the stimulation of the personality traits ultimately translates into all these three activities: the bowel function, the bladder function, and the sexual function. So I think the research will have to go in the direction of what is different in a younger person compared to the large BPH we see in the elderly, where there is no sympathetic overlay. So
Absolutely.
let us see how the research is going to conclude on this.
I must add that I was registered for the conference, had my tickets booked, everything. I'm really sorry I had to cancel at the last minute
Sorry
for
that we missed you. We would have loved you to be here.
I'm actually in the registered list for the meeting. Right.
Sir, one last question before we close. We found that frequency and nocturia are quite the most common symptoms in your study. So did we also take into account the fluid intake in the study? Did we also record that? Because somehow in practice, we find that a lot of patients are taking fluids in the night. They get up to void, they drink, then they sleep, then they get up to void again. So this habit is seen a lot in patients.
It's an excellent question. And I was personally surprised when I saw the data. But then when I went back and checked, when I looked at the data, the commonest population-based LUTS in the young male is actually nocturia. It affects a little over 1/3 of men in that study published in 2006 in the BJU. It is affected about 1/3. In terms of your question, we did have one component of this study as a bladder diary. The response rate with the bladder diary was fairly low. It was not required as an entry into the study. And we still haven't, to be honest, I still haven't analyzed that data. I think we have about 75 or 80 patients whose diary records are there out of 448, which is not a great record. But I think we still might get something out of it. And hopefully at some point we'll be able to publish that.
Thank you, sir.
Thank you so much.
Thank you so much, sir, for your talk. I think we'll move on to the next talk, which is cerebral diseases, BPH and LUTs, by Dr. Pawan Vasudev.
Good morning, everyone, and thank you to North Zone USI and the organizers for this opportunity. Slides, please. So, slides. Yeah. So I will be speaking on men who have LUTs and who also have a cerebral lesion. So first we will look at how the cerebrum is involved in normal micturition, then go on to see the urological manifestations of some common cerebral diseases, and then the implications in the management insofar as non-invasive and the surgical management is concerned. So cerebral diseases essentially refers to suprapontine lesions. And as we all know, the pontine micturition center is the center which is responsible for coordinated voiding. Now, during the filling phase, this is under inhibitory control of the cerebral cortex. So if this inhibitory control will go, then you have a bladder which is overactive, or what you would get detrusor overactivity in the filling phase. For the voiding phase, the pontine micturition center is working. It was anyways not supposed to give inhibitory impulses down. So for the voiding phase, nothing much happens in these patients. They have coordinated voiding. The voiding is right, but the timing may be wrong because of the detrusor overactivity. So essentially, these patients come in with storage symptoms, and their PVRUs are usually not a problem. So it's essentially a storage issues which come in. If you look at the common suprapontine lesion, Parkinson's is probably the one that we see most frequently. Amongst Parkinson patients who have LUTs, irritative symptoms, either alone storage or storage and voiding, comprise for more than 90% of these patients. Symptom-wise, nocturia is the commonest. And within this Parkinson's subset, nocturia is a mess because it's not only the detrusor overactivity which is responsible for nocturia. 50% of these patients also develop nocturnal polyuria, and of course, then the motor disturbances which bring in the convenience voids. So whenever you're evaluating nocturia in a Parkinsonism patients, there are 6-7 aspects that you will need to look to essentially figure out what is the cause of that nocturia. Stroke, again, amongst patients who have LUTs, irritative comprise of nearly half, and irritative and obstructive for about 90%. So it's again essentially a storage problem. Again, nocturia commonest. Urodynamics, along with neurogenic detrusor overactivity, stroke patients tend to have what is called as uninhibited sphincter relaxation. So during the filling phase, suddenly their sphincter will relax and lead to a episode of incontinence. On what kind? And if you're looking at two-body they have the classical OAB, urinary incontinence scenario. So what are the implications for this primarily storage symptoms which are coming in from these cerebral diseases? The basic stuff becomes even more important because the drugs are a problem here, and we will come to that. So a lot of things that we don't discuss with the normal BP patient, from patient education to fluid intake to caffeine to constipation to weight loss to pelvic floor therapy to urgency coping strategies. All of these become important in this subset. Bladder retraining, again, very important. If your patient is cognitively normal, then time voiding is what you're looking at. And if your patient is institutionalized or dement or has cognitive issues, then you're looking at prompted voiding. Functional issues, again, very important. A lot of these patients do not have mobility on their side. So you need to look at their toilet access and also work on that component. So before you think of drugs in this population, your basic stuff becomes very relevant. So how safe are drugs in this population? Are alpha blockers safe? So in the normal BP patient, alpha blockers would cause a fall or a fracture in about 14 to 16. So the relative risk is about 14 to 16%. Most of these falls happen within the first week. What happens in this population? Parkinsonism, 3 times, they are anyways at more risk than an age-matched population for a fall. So you need to know this before you prescribe an alpha blocker to this subset. How safe are antimuscarinics? So it is known that if you look at the short-term cognitive effects, oxybutynin has been known to impair memory and attention. The other antimuscarinics that we are using have not been implicated for the short-term cognitive effect. But the long-term cognitive effect, which is dementia, observational studies have shown that all antimuscarinics that we are using have been implicated in dementia. And if you look at the risk, you will be surprised. If you use antimuscarinics for more than 90 days, the relative risk of dementia increases by 22%. And if you use it for more than 365 days, which more than a year, the relative risk increases by 50%. So the population that we are looking at, they anyways may be having existing cognitive issues, or they may be at risk of cognitive issues. Along with that, there is something called as the anticholinergic burden, which is the drugs that they are taking already. So all of these patients are anyways taking a lot of drugs which have anticholinergic side effects, and you would be only adding to that. And thirdly, when you prescribe these drugs, you may possibly interfere with their therapy, because there are some diseases for which the neurologist is actually giving a cholinergic drug for treatment. For example, in dementia, they want a higher cholinergic load in the brain, and you're giving a antimuscarinic. So if you really have to give antimuscarinic, you should either be looking at derifenacin, or you should be looking at trospium. I will not go into the details why, because of time. But if you're looking at, if you still want to give an antimuscarinic in this population, it should be one of these two. What about mirabegron? There are enough studies now to show that in the cerebral disease population, mirabegron has been found safe. We in fact published one study in the stroke population and looked at the MoCA scores. So mirabegron so far has been found to be safe in this population. So while prescribing alpha blockers, you should be aware that some cerebral disease patients may be at increased risk of falls. It is advisable to prefer mirabegron, or if you have to use anticholinergics, then use those with favorable physiochemical and pharmacokinetic properties. One thing, do you need to do a urodynamic before you prescribe drugs? The answer is no. Cerebral diseases are low-risk neurogenic bladders, and if you don't have any red flags, if they are spontaneous voiders, the PVRU is low, you don't have stones, infections, upper tracts are normal, then you do not need to do urodynamics before starting the initial therapy. But before surgical therapy, urodynamics is imperative. You must do urodynamics before surgical intervention. How does surgery change in these patients? Let's say we have a standard male who has both irritative and obstructive LUTs, and has a poor flow, and also um, uh, do- um, obstruction documented on urodynamic. If he has Parkinsonism, then what happens? There are two issues. One, most of these patients are actually bothered by their irritative symptoms and not by their obstructive symptoms, even though they are obstructive. So the success rate in these patients is about 70%. And what is the chance that their irritative symptoms will improve post surgery? So this was looked at in a recent very nice article, where they found that if the patient has severe symptoms, if the patient has low bladder capacity, if the DOs that were coming were at low volumes, or if they were high amplitude, all these factors will lead to persistence of irritative LUTs in the post-op period. So you will need to look, you will need to counsel accordingly if you get these things, even in a patient who's obstructed on urodynamics. So this patient did well and required mirabegron. Just two more slides. The other thing is, before you operate these patients, you need to be sure that they do not have MSA. MSA, multiple system atrophy, is something that is confused with Parkinsonism. 50% of MSAs are actually diagnosed as Parkinsonism. So if you get any of this, if the urinary symptoms are coming with the neurological disease, if erectile dysfunction is coming with the neurological disease, if they have large PVRUs, or if when you do a urodynamic, the bladder neck is already open without a DO, which suggests internal sphincter denervation. If you get any of this, you must refer your patient back to the neurologist, let him confirm it is Parkinson's, and then you operate, because doing a TOR in a MSA is a disaster. Last slide. So if your patient has, if the same patient had only irritative LUTs, and on the filling phase you had only neurogenic retrocessor overactivity, how safe is botulinum toxin if your antimuscarinics or your mirabegron doesn't work? So botulinum toxin has been mainly studied in the spinal cord population and the multiple sclerosis population. There are very few studies which have looked at the Parkinson patients. So 100 units is what you have to give and not 200. 30% there will be complete resolution of incontinence, 80% will improve. The problem is 12%, which is much larger than your average population in which you give Botox. A larger population will need CIC. And if you are going to inject botulinum toxin, you must look at their hand dexterity before, because there is a real risk that he may need CIC and he may not be capable of CIC. A higher preoperative PVR is the strongest predictor of treatment failure and retention in these populations. Thank you.
Any questions from the audience? Yeah. Sudhir.
That clearly said that we have to differentiate it from multiple system atrophy also. Sometimes
Yes.
both can be overlapping. So
No, both are different diseases.
both are different
It may
diseases,
be
but the presentation-
misdiagnosed as Parkinson's.
So in such a given patient, if you are contemplating surgical management,
Yes.
so how to differentiate and then decide?
So first you look at your data. So in Parkinson's, the urinary and the erectile issues come a little later, after a couple of years. So if they're coming together, that is the first red flag. If you have if you have a large PVR, then that's another red flag. And if in your urodynamic, when you start filling, you don't have a DO, but the bladder neck is opened. So internal sphincter denervation doesn't happen in Parkinsonism. It's a feature of MSA. If you get any of these red flags and you're thinking of surgery, you first send it back to the neurologist. Let him confirm. Let him redo. They would do sphincteric EMG. They have their ways to thrash between the two. And if they say it is Parkinson's, then you operate.
But if it is
In which the patient will be dead in 8 to 9 years. So there is no surgical intervention which is recommended. Most people will not void, and majority will become incontinent after your TRP.
but
So if
to
it's MSA,
consider-
then you shouldn't
consider
be.
CIC in them then.
Yes,
And how
either if they're so most of them will land up on a if it is MSA. Yes, sir.
Sir, in a patient with a cerebral lesion, if we are planning a surgery, TURP, what findings on urodynamics will guide us towards a surgery?
So if the patient is obstructed, then the surgery is likely to help. If you don't get bladder, if the BOI is less than 40 on urodynamic, then you should not operate, because he's not obstructed and his irritative symptoms are primarily from the Parkinson's portion. If you find him obstructed, you operate, the obstructive symptoms will settle down, and there are some parameters which will tell you how much the irritative symptoms are likely to improve. But having said that, after surgery, irritative symptoms which were not being managed earlier with Mira background become more manageable after a TUR. But if they are not obstructed, that is a red flag, and the symptoms are not likely to benefit if you do not if your obstruction is not documented on the urodynamic.
So this was one of my anxieties. If a patient is having too much detrusor overactivity, and we do a TURP, is he likely to get incontinence? More likely to get incontinence?
No, so if he was obstructed, part of the detrusor activity has two folds. One is happening because of the obstruction, and one is happening from the Parkinsonism patient, from the neurogenic portion. So many times we operate regular TURP patients who have irritative symptoms who improve. So the same. It's not him getting incontinent. It is about which of the two symptoms will improve and how much.
Thank you, sir.
Is Rajesh Taneja coming online?
Sir?
No.
No, he's He is online, but he is sick. His throat is paining. He will not be able to speak, so he will not
Okay.
be able to join.
That's the end
But
of the.
he is listening to us. Okay. Thank you, chairpersons, for conducting the session here. We move on to the next session. We are almost ready with the theater also, but we should do the rest of the session in time. Thank you, sir. For the next session, may I invite Dr. H.S. Bhutani, sir, Dr. Nitin Srivastav, and Dr. Keshav Murthy, if you can please join us on the dais. The first speaker is Dr. Sudhir Divana talking about the alpha blockers, which, when, and how.
Good morning. Can we call upon Dr. Sudhir Divana to give his talk on alpha blockers, which, when, and how?
Good morning, everyone. Can I get my slides, please? Yeah. So, respected chairpersons, dear delegates, at the outset, I want to thank NZ USI Council, Dr. Rishi Nair, sir, and Dr. Swapan Sood for giving me an opportunity to be a part of this academic event. So, without waiting much of time, my job is to discuss about the most commonly used drug for BPH, the alpha blockers. So, I don't have any conflicts of interest. So we all know there are a lot of indications for BPH, for alpha blockers other than BPH as well, like in the medical expulsion therapy of stones, in chronic prostatitis. And once in a while, we get even patients prescribing the alpha blockers for as a prophylaxis for preventing post-operative retention as well, and relieving degestant related symptoms, nocturia management, and even following brachytherapy if the patients have LUTs. These are the drugs which can be prescribed. So before going into the when and how to prescribe these drugs, we should have a basic understanding of where these drugs are going to act and what is the selectivity that they have as far as receptors are concerned. So we all know that the alpha blockers are predominantly significantly concentrated at the alpha receptors are significantly concentrated at the bladder neck, prostate, and also the prostate capsule. That is specifically the alpha 1A receptors, whereas alpha 1B other than this area, they are more in the smooth muscles in the vessels, and alpha D is in the stroma of the prostate and also in the detrusor muscle as well. So all these drugs that which we have, which are available for us, they act based on the differences in their selectivity and also on the elimination half-life. So if you see the commonly prescribed drug, initially we started with non-selective drugs, and then subsequently over a period of decades, the newer generation alpha blockers came up, and the most commonly used drugs are the alpha-zocin, tamsulosin, and salidocin. So these are the common preparations, and the advantage of the latest these newer generation drugs are they are highly selective, can be given on a once-a-day basis, and they don't have any first dose effect. That's why they have a very less chance of postural hypotension, and they doesn't need any titration as well. And as usual, of course, since they are highly selective, they have less side effects. So this table actually summarizes the most commonly used drugs in terms of their pharmacokinetic profile. And if you see, the highest selectivity is for silidocin. So you can clearly see that it is 162 times having higher affinity on alpha 1A when you compare with alpha 1B. That itself is the reason why the onset of action is also rapid, and at the same time the side effects are far lesser in terms of postural hypotension because of less activity on alpha 1B. Now let's go into the discussion where when to take what drug. So commonly prescribed drug, many a times this drug has an interaction with the food. As you know that tamsulosin, when it is taken with food, it delays the peak concentration levels. So that's why the levels of the drug will not increase suddenly immediately after consumption. So there will be less chance of postural hypertension immediately, and also the effect will be sustained. Similarly, it goes for silodosin as well. And even in alfuzosin also, if you see, the fasting actually decreases the absorption. So overall, if you see, always we should tell our patients that you have to take these alpha blockers with food, preferably at a fixed time of the day. And what we generally give the advice is just after you take food, within half an hour, you have to consume the medicine. Now, which to choose? That's a difficult question. If you go into the literature, this was a meta-analysis where I was also one of the co-author. Basically, this was published recently, where we analyzed all the published data on alpha blocker monotherapy. And of all, the main thing is that the problem is all alpha blockers are effective, that every one of us know. And the same is the thing, and they are safe enough. But if you see the published data, it was shown in our analysis that the tamsulosin has the highest probability of ranking in terms of network meta-analysis, that it is showing the highest chance in terms of improving the IPSS and also Qmax. And silodosin has shown to be in the, when the side effects are assessed, silodosin has the highest chance of side effects, more of the retrograde ejaculation. So if you go with the say that which alpha blocker to choose, generally they are all equally efficacious if you see a lot of the randomized trials. And of course, you have to select them according to case by case basis. Like let us say you have a patient with hepatic or renal dysfunction, whatever. So in such cases, you have to select your drug. Like coming back to the same discussion, like here in this table, you can see the tamsulosin is predominantly excreted in urine, whereas alfuzosin is predominantly excreted via bile. So that's why when you have a patient who is having hepatic dysfunction, better to avoid alfuzosin because it is predominantly excreted and even the metabolism is predominantly dependent on the liver. So that's why we have to avoid it. But if you take tamsulosin, it can even be given in mild hepatic dysfunction, it can be considered. However, in renal dysfunction, in severe renal dysfunction and hepatic dysfunction, you have to avoid it anyway. Even the same goes for silodosin as well. It is also similar to tamsulosin, but in renal dysfunction, you can reduce the dose to half by giving 4 milligrams per day. Now, sometimes you get patients on multiple drugs because you need to understand the drug interactions. Since all these alpha blockers are predominantly metabolized by the cytochrome P450 enzyme hepatic system, so drugs which inhibit the CYP3A4 or whatever, these in those drugs, you have to be cautious while writing these drugs. So always in the history, we have to ask whether they are on these ketoconazole, erythromycin, or paroxetine, SSRIs, and diltiazem. These are the drugs which affect the hepatic metabolism. So you have to be cautious in those situations. The same goes for silodosin as well. One additional point which you have to remember is alfuzosin. Sometimes cardiac patients with QT prolongation, they come to you. So in those patients, it is shown that alfuzosin causes dose-dependent QT prolongation, leading to the increased risk of arrhythmia. So you have to avoid alfuzosin in such patients. You can go for silodosin in such. Like if a patient with BPH with retention comes, so when you are planning trial without catheter, which alpha blocker is to be considered? So if you want a faster acting drug based on the available literature, since the Tmax of silodosin is very less, that is within 1.5 hours, the drug attains peak concentration. So for a prompt relief, you want to remove the catheter, you can consider silodosin. So at least you have to wait for 3 days based on the guidelines which are available that before you give a trial of catheterization. Sexually active patients, I think everybody of us know, all of you know that silodosin is associated, just I will be finishing in a minute, that silodosin is associated with significant retrograde ejaculation. So it has to be avoided, and alfuzosin will be better in patients who are sexually active. And naftobidil, of course, nowadays most of the people doesn't use this drug, but this is also shown to have less chances of sexual dysfunction because it is predominantly acting on, the alpha-1D receptors. Now, final patients with risk of postural hypertension, I think based on the mechanism of action, silodosin should be the preferred drug because it has less chance of hypertension even in cardiac patients. Elderly patients, one point to listen to here is the alfuzosin. Alfuzosin beyond 75 years, actually the drug concentration levels increase because of delayed metabolism. So better to avoid. Co-administration with other antihypertensives, you can safely give because it is shown that it's not going to have a rebound hypertension. Doesn't going to cause that. So in floppy iris syndrome, the final point, that whenever patient is planned for a cataract surgery, better to stop the drug, alpha blocker, at least a week prior to surgery. You inform the ophthalmologist, maybe you can delay the surgery, and preferably if the patient can be, if the patient comes first time, you can start the drug after the surgery rather than before. Now, final issue is if you are not having a response to alpha blocker, how to go about it. So there are papers which suggest that you can switch the drug. Like if you go from one drug to other drug, there are in 20 to 25% of the patient, they respond to a different drug. So you can try that. That is what's shown in this paper. And even dose, doubling the dose also can
Dr.
be done.
Sudhir,
Like
can
most
you
of the times, tamsulosin can help.
Conclude, time is up.
Thank you, sir.
Thank you, Dr. Sudhir. We don't have time for discussion. We move on to the next paper by Dr. Manoj Kumar. Anticholinergics, which, when, and how.
Very good morning to all of you. I thank your organizer for giving me this opportunity. I will be speaking on the anticholinergics, which, when, and how. Slides are not moving. We know that BPH is occurring up to 70% of a man more than 60 years of age. Bladder outlet obstruction leads to storage symptoms and the voiding symptoms. Voiding symptoms includes frequency, urgency, nocturia, and urge incontinence. And it is the storage symptoms which stimulates man to seek help for their problems. In patients with BPH, detrusor overactivity has been identified in up to 50% of the man. In the large population-based survey, also show the prevalence of storage symptoms increases with the age without any differences between the man and a woman. And there are several urodynamic studies which reported that detrusor overactivity was more frequent in the aging man, regardless of the presence of bladder outlets obstruction. So there is one theory which says storage symptoms may be primarily age-related rather than the prostate-centered. We know that sympathetic systems helps in bladder filling and facilitate the storage of urine, and the parasympathetic helps in emptying. So the antimuscarinics acts on the muscarinic receptors on the bladder, and beta-3 agonist acts on the sympathetic systems. So we know that there are 5 muscarinic receptors in the bladder, M1 to M5. Of this, M3 is the most important, which mediates most of the smooth muscle contraction. Otherwise, majority is of the M2 types. They are present in the urothelial cells, detrusor muscles, and the suburothelial structures like interstitial cells. So M3 receptors mediates the contractions of human bladder. It depends on the entry of extracellular calcium through the L-type calcium channels and the activation of the Rho kinase. So there is no role of M2 muscarinic receptors in direct contractile response. We know that antimuscarinics has lots of side effects. It's because of that it shares the receptors in the other parts of the body like brain, salivary glands, heart, and gastrointestinal, which is responsible for the side effects like dry mouth, constipations. These are the various pathophysiology which leads to the overactivity in the bladder outlet obstruction, like afferent signal dysfunction. There can be a myogenic dysfunction, neurogenic myogenic dysfunction, or altered brain response. So what should be the ideal antimuscarinic drugs? It should be efficacious, organ selective, and tolerable. So these are the various antimuscarinic drugs which are available in the market. So I will cover one each by each. So oxybutynin was the first antimuscarinic drug. It is not selective. It is M1 and M3 selectives. And with the high dose, it causes muscle relaxant as well as the local anesthetics effects. It's available in the market in the form of Tropan. Dose is 2.5 and the 5 milligram. So we can increase the dose up to 10 milligrams. So various preparations are available like immediate release, but it causes high side effects. So to avoid this, extended release are available, patches are also available, and the gel form is also there. So coming to the next is tolterodine. It is a it's again the non-selective. Dose is 2 and 4 milligram. It's available. Trade name is Rolitan and the Tirol. Coming to the next, it's derifenacin. It's a highly selective M3 receptor antagonist. It has 59-fold higher affinity for the M3 receptors, which results in the less side effects in the form of dry mouth and constipations. So it's available, doses is 7.5 and 15 milligram. So we can start with a low dose, and after 2 weeks of starting therapy, we can reassess and then increase the dose if required. This is solifenacin. It is a potent M3 receptor antagonist. The commonest side effect is again the dry mouth, like the other antimuscarinics. So the recommended starting dose is 5 milligram, can be increased up to 10 milligram. Fesoterodin, it is rapidly and extensively hydrolyzed by the non-specific plasma esterase to the 5-hydroxymethyl derivative, which is the primary active metabolite. It's available in the two forms, for 4 mg and 8 mg. Trospium chloride, it's a quaternary amine derivative. It has an affinity for both all the three receptors. So the dose is 60 milligram. This can be safely used in the elderly with the cognitive dysfunctions. Coming to the small word about the MIRA background, it is a beta-3 agonist. The recommended dose is 25 milligram and 50 milligram. It can be combined with solifenacin. So we have seen solifenacin is a highly M3 selective, but otherwise the tolterodine and other oxybutynin, they are the non-selective drugs. So coming to the, in cases of renal and the hepatic dysfunction, there is no need to titrate the dose of oxybutynin, but in cases of other antimuscarinics like solifenacin, trospium, we have to reduce the dose. So trospium is affected by the food also. So we have to advise the patient has to take empty stomach. So dry mouth is the commonest side effects in all the antimuscarinics. So what is the long-term tolerability and the compliance? We would know that antimuscarinics improves the quality of life, but the persistent rates is only 12 to 25% with the antimuscarinics and 30 to 38% with the MIRA background. So the median time of discontinuation was less than 5 to 6 months. So what are the factors behind this? There is unmet efficacy expectations, side effects, inconvenient dosage schedule, inconvenient mode of delivery, inadequate support, culture attitude, and the cost. So what can be done to improve compliance? We have to educate the patients about the nature of the condition. We have to give more realistic expectation, encourage the patients about the behavioral modifications, and advise the sustained release formulations. So coming to the combination, can we combine alpha blocker with the anticholinergics? We know that 50% of the patients with BPH has the overactivity symptoms. So regardless of the prostate size, alpha blockers are the first line drugs. Antimuscarinics can be the add-on therapy if the patient has overactivity. So how long we can continue? All the studies on alpha blocker combination therapy has only short follow-ups, which is less than 12 weeks. So no study says the outcome of this combination for more than 4 months. So we don't know how in the long term it's safe. So coming to the guidelines, all the guidelines says we can use the combinations. AUL guidelines says we can combine alpha blocker with the antimuscarinics. Same, the USA also recommends strongly we can use the combination of alpha blockers with antimuscarinics. Again, the Canadian guidelines and the NICE guidelines also suggest the same. So there are a few things which we have to keep in mind. There is incidence of urinary retention after antimuscarinics. The normal incidence is 0.2 to 0.7%, and which remains low despite starting antimuscarinics. So there is no increased incidence of urinary retention despite starting antimuscarinics if the PVR is low. So incidence of the change in bladder strength like Qmax, various serodynamic studies have shown there is no change in the Qmax. So coming to the practical approach, we can use sequential therapy. Patients with BPH, we can start with the alpha blocker. If the patient has overactivity symptoms, then we can add on the antimuscarinics. So the practical consideration, like there should be shared decision making between the patient and the physician. We have to reassess the response after 4 to 8 weeks and discontinue medications in case if there is a worsening of the low tract symptoms. We have to educate the patients and give the treatment of the like constipation. We can ask the patient to take ASAP goals and regular exercise, normal bowel habits. So the take-home message is 50% of the patients with BPH have overactivity. Alpha blockers are again the first line, but they often fails to improve the storage symptoms. So we have to add antimuscarinics or beta-3 receptor agonist. So combination therapies is recommended by all the guidelines. Thank you.
Thank you, Dr. Manoj. We don't have time for questions, sorry.
Thanks.
We'll move on to the next paper, PDE5 inhibitors, which, when, and how, by Dr. Kawaljit Singh Kaura.
Good morning, everyone. Thank you so much for the organizers to provide this opportunity to be on the dais. I'll be talking on role of PDE5 inhibitors in BPH. Slides, please. It's quite an interesting topic. We all are using tadalafil these days in patients presenting with BPH LUTs in the OPD. Yeah, thank you. I'll be covering this topic under a few headings, like first of all, the pathophysiology. We all know, I'll be just refreshing it up. Introduction to the main PD5 inhibitors and the one that we are using routinely, indications to use, level of evidence and conclusion, and what the guidelines say. We all know BPH is caused by proliferation of epithelial and stromal cells in transition zone. And LUTs associated with BPH, they include both storage, voiding, and post-maturation LUTs. My esteemed previous speakers have already told everything about this. And more than 50% men above 50 and 80% men above 80 experience the LUTs. For a long time, patients were getting managed with alpha blockers and for ED with the tadalafil. But in early 2000, there were the studies when epidemiological studies, they showed the incidence of BPH LUTs associated with ED. Just for the reference, we all know PD5 inhibitors, apart from corpora cavernosa in penis, they are present in male bladder, urethra, as well as the prostate. So, it came into limelight when early studies in 2004, they showed the incidence of LUTs, ED in LUTs to be about 70%. In men with moderate to severe LUTs, the prevalence of sexual dysfunction, including ED, was increased compared to the general population. There was a survey which showed that LUTs is an independent risk factor for the development of ED with an odds ratio 2.1. And tadalafil is the only approved drug PD5 inhibitor by FDA for the treatment of LUTs BPH in 2011. Just to refresh the mechanism of action, the mechanism of action is guanylate cyclase. It converts GTP to cyclic GMP, and cyclic GMP by various pathways resulted in due to calcium as well as potassium, it resulted in the smooth muscle relaxation. So PDE5 inhibitors, we all know, they block the conversion of cyclic GMP to 5-GMP. Thus, the active component cyclic GMP that cause the increase in this calcium channel and potassium channel pathways, including Rho kinase pathways, resulting in ultimately smooth muscle relaxation. This is the same mechanism that is there. I'll take to this slide. So there are 3-4 pathways that have been highlighted in the literature. One are the nitric oxide pathway, atherosclerotic pathway, autonomic hyperactivity pathway, and Rho kinase pathway. Just to make the things very simple, what PDE5 blockers they are causing is, they are causing smooth muscle relaxation of the bladder neck, urethra, resulting in the increase in symptoms, that is IPSS scoring. They are causing increased vasodilation due to smooth muscle, endothelial muscle relaxation, smooth muscle relaxation in blood vessels. And due to this blood flow, there is decreased inflammation. They are inhibiting the afferent pathways, afferent neurogenic pathways. And as a result of this, they are causing the symptomatic improvement. And downregulating the Rho kinase and atherosclerotic pathway again is resulting in the decreased proliferation and symptomatic improvement. After the mechanism, let's have a look at the commonly, this is a slide we all know about the PDE5 inhibitors available, and the only indicated in BPH LUTs is the tadalafil. It is the only longer acting and with a half-life of 17.5 hours. And elimination, it is 61% eliminated in feces and 36% in urine. Apart from this PDE5, it is also associated with blockage of PDE11, but no clinical significance of that. Just to highlight that there is no effect of food absorption on tadalafil, and the incidence of backache and myalgia are higher with tadalafil. We all know this slide from Campbell Urology that contraindications are MI and stroke within last 6 months, and unstable angina, resting hypertension, as well as the non-retinal disorders, and liver and end-stage renal failure. What the guidelines say, this slide I will again quote at the last. The use of PDE5 inhibitors in moderate to severe LUTs with or without ED is a strong recommendation from European Association of Urology. Let's talk to the evidence, literature. What the literature say? I have tried to incorporate 3-4 studies, one with the monotherapy and a few one with the combination therapy. This is a good study which highlighted the efficacy and safety of tadalafil monotherapy 5 mg. And as you can, this was a review which clearly stated that 5 mg tadalafil, it significantly caused the improvement in IPSS scoring, in quality of life scoring, in quality of life. This is a clear-cut forest plot, clearly detecting the favorable components in IPSS. There was not, all these studies have one crux. There is not much improvement in the urodynamic features. Flow rate is not much improved. Another review that was published in Therapeutic Advances in Urology, it also clearly depicted that it improves the IPSS and quality of life. And the efficacy was irrespective to the patient, whether it is having erectile dysfunction or not. The symptomatic improvement was there overall in all the patients, irrespective of the ED. So as clearly the diagram, the graphics are saying, the IPSS is improving irrespective of ED present in the patient or not. Another review clearly stating that there is improvement in IPSS.
इसमें वाईफाई नहीं है चलिए 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 हाँ बोल उसको बेंच कर we can add a in that. It is definitely majority can patient come to us, it's already taking the current combination. Then the majority go back. It does not possible to go back. Like, so how many patients in your view ask to stop this drug on this side?
कम टैक्स में काम बताया बता मैडम ये तो वस्तु डाला बोला
behind, and many of them have come up and kept up with the technology. So with that, I request.
I think you have really summarized it well. Urology and urologists are taking a lead as far as the technology acquisition is concerned. And amongst all branches, I still feel, I think we are adopting the technology fastest, be it robot, laser, or other special techniques. So I think now we have the expert who are going to demonstrate their skills. What is Dr. Tanuj doing?
Hello.
Hello.
Good
Hello,
morning,
good
sir.
morning. Am I audible?
Hello.
Hello, am I audible?
Yes, sir, you're audible.
Yeah, very good morning. Sending you warm regards from the theaters of Patel Hospital. Just introduction of the first case. Our first case is a 73-year-old gentleman. He has been having LUTs since last 2 years, not responding to alpha blockers. He's a known case of coronary artery disease post PTCA. He has IPSS of 21. He has a grade 3 firm prostate on digital rectal examination. His truss and abdominal ultrasound images can be seen on your screen. He has a prostate of 39 grams and a PSA of 3.2. In urodynamics, you can see the urodynamics graphs on the screen. He has a AGI of 42. The patient will be taken up for Urolift by Dr. Tanuj Paul Bhatia. We all know Dr. Tanuj Paul very well. He needs no introduction. He's the head of department and senior consultant at ILL Hospital, Faridabad. I'll shift over to Dr. Tanuj Paul Bhatia as you take over, have a look at the cystoscopy of the patient. Thank you. Over to Dr. Tanuj Paul, please.
Hello. Good morning, sir. Am I audible? Hello.
Yes, sir, you're audible.
Am I audible in the auditorium?
Yes, yes.
Hello, Tanuj, you are on.
Yes.
Audible, Dr. Tanuj.
Good morning, sir. First of all, thank you, Sarpan sir and North Zone for this opportunity and array of cases ranging from missed to robotic surgeries are arranged today. And we'll be starting with one of the missed therapies in the morning, which is Urolift. So I will first just, I think the case has already been presented. I will just start by presenting about the instruments that we use for a Urolift procedure. And then we go ahead with the cystoscopy, the planning, and then the procedure. So this is a special cystoscope. Can you see it on the screen, sir?
Yes. What make is this?
So this is, I think he is making it for the Teleflex guy. So it has a Urolift signage here on the scope. French cystoscope, which is about 36 centimeter in length. It's a little longer scope, and they use a thinner telescope with this, which is a 2.9 French 0-degree telescope. And our usual camera can be used, and the light cable and everything. And then
Cystoscopes seems to be the same, but it is a bridge which is the different.
you can say that, sir. You can say that, yes. The bridge is different. That is what gives the extra length, and the telescope is much longer than the usual telescopes what we use, and it's a thinner telescope. It is a 2.9 French telescope compared to a 2.9 mm telescope compared to a 4 mm telescope, what we usually use with a 20 French sheath. And when we come to the device, can you show the camera here? Dr. Harleen will show the device. Can you see the device, sir?
Yes, we can see.
This is the device which is connected to the cystoscope and the telescope. I mean the cystoscope sheath and the telescope. And this is what is used to fire the implant. So once we are inside the bladder, of course, we do some planning where the implant has to be placed. And then when we are at the site of placing the implant, first of all, we have to unlock the device. There is a lock and unlock button, if you can see here, what she has pressed. So it should be very safe before we start the deployment. That's why they have this unlock button. Once we are sure about the site, first we press the unlock button, then we press the blue button. When we press the blue button, a needle goes and pierces the capsule. It goes through the prostate gland, pierces the capsule. And then when we press these both buttons together, that is when the capsular tab or the implant that stays outside the capsule is deployed and the needle retracts back. So after that, we press it twice to confirm the deployment of the implant. And then with the device, we move towards the bladder neck. As we move towards the bladder neck, the PET suture, it gets stretched. and there is something called a white line on the suture. When that white line is reached, we press a button, which is here, this blue button, which cuts the implant, and the urethral implant is fired. So that's how a Urolift implant device works, and it is fired, and we will further see it in use during the procedure. Should I proceed with the cystoscopy, sir?
Tarun, how do you decide that, how you choose your patient? Which patient requires Urolift?
Sir, in my opinion, there are three categories of patients. One, who are very high risk patients, like this case, who are very high risk for any major surgery, like a patient has CVA, CAD, very poor ejection fraction, not fit for anesthesia or any other surgery. So those cases we can plan Urolift under local anesthesia. This is a procedure which can be done very easily under local anesthesia. Second is those younger patients who have lower urinary tract symptoms, which are refractory to medical treatment. So we have now these 45, 50, 55-year-old patients who are coming in with BPH and LUTs, and they are not responding to the medical treatment, and they have typical obstructive symptoms. And they want to, of course, preserve their ejaculation and sexual function. So that is the second category. Third category is those patients who don't want to take medications. I mean, they have effect of medicines, but they don't like the side effects of medicines, or they don't want to take the medicines. And they say, I don't want medicine, I don't want a major surgery. Is there something in between? So earlier, all the patients used to ask that, and we had never had an answer. We had either medication for lifetime or a major ablative surgery. So now we have something in between, which is the mist therapies, which is a bridge between the medication and the major ablative surgery without major side effects. So if the patient can understand the implications and the benefits and is willing to go for it, we can now offer it to the patient.
Is there any restriction on the size which one can operate, or
Sir,
the median lobe size?
Yeah, so especially in the initial cases, one should refrain to do very large prostates or the cases with median lobe. There are techniques to treat median lobe also with Urolift, but ideally in the initial cases, it is better to refrain from those cases. And this has to be discussed in detail with patient. Only if the patient insists, no doc, I want Urolift only, then you go ahead with with Urolift in those cases. Still, in very large prostates, I would still refrain, because sometimes the length of the suture may fall short. It is a 33 millimeter diameter that needle is there. So that is about the length that comes out. So anything more than 4 centimeters is difficult, width is difficult to treat with Urolift. So anything more than 80 to 100 cc is difficult to treat with Urolift. And as of now, even I avoid to treat.
Any major complication did you come across in your journey of this procedure?
So no, not very major complications. Once I've had a capsular pull through in a very large median lobe. That patient was very highly motivated for Urolift and did not want any other therapy. But then we could still treat him, and he's doing fine with the Urolift implants. And he's a young guy, he's an athlete. Even now, every day.
How do you counsel the patient and about the cost of the procedure, and how you counseling about the success or failure of the procedure?
Sir, we always be very realistic to the patient what to expect. Obviously, if I talk about Uroflows, the flow is better with ablative surgery compared to mist therapies. So they have to know what to expect. The results, the Uroflows that you get with any of the mist therapies are in the range of 14, 15, 16 ml per second, which is equivalent to what a medication would give. So they have to accept that, but it has been seen that the quality of life improvement is same. So that is what we tell them. Your flow improvement will be moderate, but your quality of life will improve marginally, especially with the preservation of the sexual part in a younger patient. And of course, in a patient who's very high risk, I have had patients who have been on catheter since 5 years, going from here to there because they are not fit for anesthesia. So we could offer them Urolift under local anesthesia. Of course, it comes at a cost, but at least it makes them catheter free.
Anuj, hello.
Sir. Yes, sir.
Anuj SP Yadav here.
Good morning, sir.
I have a different opinion in the sense that you said there is no major complication. One major complication is failure. Second major failure of the procedure.
Yes, sir.
Means after 3 months he comes back to you. At least I have seen 2 patients with this technology, and they had detention again within 2-3 months. So this is again a major complication after spending 3-4 lakh rupees and then again going for second surgery. 2, chances of prostatitis is much more in this group than the other groups, than the HOLAP or bipolar or enucleation. And three, you're choosing, you may choose sometimes a not suitable patient for this and land up into the other things. Thank you.
Yes, sir. Definitely means any patient with recurrent prostatitis or a positive culture, we have to avoid urolift. Even in recurrent acute prostatitis, I have been avoiding urolift procedure, sir. We have to be careful about the case selection, as you mentioned. Failure rate, yes, it is there. If we talk about 5 years, about 13% failure rate or re-intervention rate is there. But good thing is that even in these patients, a TORP or HOLEP can be done. And same has to be counseled to the patient that if there is a failure, we do have a therapy which can be offered later. So first of all, the patient has to select it. The onus of selection of procedure has to be patient. Only then he will understand the benefits and he will go for it. And we should not be pressurizing any patient that you should undergo this. We give him choices. He does his research on the internet. He discusses. We give him some leaflets to go about the literature. Then he comes back with a decision with his family, and then only then we go ahead with it. I think that is the reason, even though we are doing it, but still we don't have that large number of patients like the US where they're doing, for every patient. So I think case selection is important, and that's what.
Tarun, you can start the procedure. We keep on discussing while you're doing the procedure.
Jelly, please. So we'll start with the cystoscopy. So one thing which is required in urolift is preoperative planning, and we prefer to do a preoperative cystoscopy in all the patients.
Tanu's length of this scope
Yes, sir.
is bigger than the routine scope.
Yes, sir. This is 36 centimeter scope, sir. The bridge adds to the length. This bridge, it adds to the length.
Seat may be same, but the length
yes.
of the scope and the bridge is more.
Yes, sir. And the telescope is thinner, sir. It is a 2.9 mm telescope.
Yeah.
So we can see this is a lateral lobe, essentially lateral lobe enlargement in this case. This is not a very large median lobe, and such cases are ideal for urolift placement because yes, management of median lobe is a little bit challenging and should be done after a certain level of expertise only with urolift. Going in, we can see the orifices, the bladder is moderately trabeculated. Now what we need to see is the length of the prostatic urethra. So I come back to the bladder neck and there are markings on the scope. I just keep my hand here. And when I come back to the veru, it is only about 2 centimeter length. So when I have a prostatic urethral length of about 2 centimeter and for placing the implant, I need to come back about 1.5 centimeter. So there is a chance in this case, we might have to place only 2 implants, one on either side. The placement of implant should be above the 3 o'clock level. So best is to place at 2 and 10 o'clock. And I think that's what we are going to do. So I think I'm going to take the implant now. So we keep the sheath inside only. After doing the cystoscopy, we leave the sheath inside. We take out the bridge and the telescope. We let the bladder to empty. And we connect the implant. Ye lijiye, brother.
Yeah, okay.
So
Tarun, this is the question.
Sir.
You decide, take the decision of doing a urolift after doing a cystoscopy, or you decide on the basis of other investigations?
No, after doing a cystoscopy, sir.
Cystoscopy.
Because the decision can change after the cystoscopy.
Stage the thing. First you do cystoscopy, then come out.
Yes, sir.
Train the patient, take the consent, and then go again.
Yes, sir. Yes, sir.
First cystoscopy do under local anesthesia or anything?
Under local anesthesia with flexible cystoscope, sir.
Okay. That's local.
So I am passing the telescope through the device, sir. You can see. And there is a lock here. This blue thing, we rotate it and the telescope is locked inside the device. Now we pass the device through the sheath which is already placed.
Can we see the device from outside also while you're doing it?
I thought
Like
I'll show.
we were getting 2 pictures.
I will
now
show
you're
again,
getting
sir.
only the endo view.
I will show again, sir.
Yeah.
So I will show the connection again. This is the device.
No, you are not seeing. Now it's fine. Now it's fine.
This is the telescope. I'm passing the telescope through the device. There is a blue lock here. We rotate it and we lock it. This one.
Okay. Now you have removed the bridge. So you are going to put whole of this in the
Yes.
sheet.
The
which you have
whole
already done.
one device contains one implant, sir. So every time we have to place an implant, we come out, we change the device and we go in again. The sheath stays inside. Yahan dikhaiye. So now I'm passing the device through the sheath. And we lock this. Now, whatever.
Anuj,
Sir.
this telescope is made only for Eurolift?
Yes, sir. Only for
So-
Eurolift.
So they give this telescope along with this
Yes,
device?
Sir. Yes. No, you need to buy it, sir. You need to buy the whole assembly if you want to start Eurolift program. So any rotation of the device has to be inside the bladder. Right now we are inside the bladder. We rotate the device how we want it to be. So this is roughly 9 o'clock and we rotate it to 10 o'clock. And then we come inside the prosthetic urethra. The diameter of the needle is 1.5 centimeter. So we have to come inside at least 1.5 centimeter inside the prosthetic urethra so that when we are passing the device, when the implant is placed, it does not enter the bladder. So I've come to the bladder neck and I'm coming back 1.5 centimeter. That would be about 3 lengths of this extension that you can see. So 1, 2, and 3. If I look down, it is roughly at the level of Veru only. Here. So now I am at 10 o'clock position. This is the position I decide to place the first implant. Okay. So first adjust a little 10 to 15 degree compression. Then we unlock the device. Can you see? I'm unlocking, sir. The device is unlocked.
Yeah. If somebody can just increase the size of PIP.
Can you see, sir? Now I'll press the blue button. When I press the blue button with little bit compression only, the needle has pierced. And it would have gone outside the capsule. Then we compress little bit more, about 10 degrees more. And then we press both gray and the blue buttons. Now the capsular tab is deployed and we press it twice to double confirm. We start walking towards the bladder neck at the same angle. As we do that, we see, can you see that white line?
Yes, we can see.
Yeah, that is just at the half level. That is the right place to fire. And then I press this blue button behind and the implant is deployed. Then we go back to the midline and we take the second implant. So every rotation has to be inside the bladder. Otherwise, it causes erosion inside the prosthetic urethra and causes bleeding, which decreases our vision. So now we'll take the second implant. The whole purpose is to create a channel anteriorly. All this while whenever we were doing prostate surgeries, we used to try and make a channel posteriorly by doing the median lobe and the floor and everything. But with this device, the aim is to make a channel anteriorly. So I'm taking the second implant. You can see the locking procedure again. The telescope is gone, locked. Now I'm passing it through the sheath. Okay. Now we'll go for the left side of the patient. We go rotate it to 2 o'clock position. We come back. This is the bladder neck. So 0.5, 0.5, and 0.5. There is a bulge here, so I'll do a little bit of sweeping motion here, wherein I'll try to take this bulge. Can you see this? And I come a
Yes.
little more back because I don't want the implant to be intravesical. Okay. Now with little bit compression, I unlock the device. I press the blue button, the needle is gone. I press little more 10 degrees and I press both the buttons. Once, twice compression. Now I go towards the bladder neck. Towards the bladder neck. I should not go too much inside, otherwise it will be, yeah, I can see the white line. Can you see, sir? And I will deploy. So now we go back into the bladder, we go to midline. Now we'll do a cystoscopy and see how the channel looks. So we take out the device. Telescope, वो दीजिए. Bridge.
Are you going to leave a catheter after this or no?
Sir, in today's case, yes, because he is under spinal anesthesia. In most of my routine cases, I'm not leaving catheters anymore.
And the patient is going back home on the same day?
Yes, sir, they can go back home on the same day. So we come back. This is the bladder neck. This is the veru. And if you look, there is a nice anterior channel, sir. Can you see, sir?
Yeah, we can see it now.
Now, if we want, we can place one more implant here on left side. Right side, it's not required. Actually, for left side also, I feel it is not required. We have a channel. This is the goal of the surgery, sir. When we come back to Veru, we should see a nice anterior channel. And if I place any more implants, I don't think it is going to serve any purpose. So what is the opinion of the house on same, sir?
No, we can definitely appreciate the open bladder neck when you are at the Veru.
Yes, sir.
Only thing is, normally we were taught all this through that the obstruction is more posteriorly, resect the base first.
Yes, sir.
Even if you leave it anteriorly, it won't matter.
Yes, sir.
Whereas the whole principle, now you are putting the implant at 2 and 10 o'clock.
Yes, sir. It
So
is.
what is your comment about that?
Yes, sir. No.
Dr. Tanuj, I have a question.
Yes, sir.
This is Dr. Sudhir from PGI.
Hi, Dr. Sudhir. Good morning.
Is there anything like based on the size of the prostate, you decide the number of implants you want to place?
You can get a rough idea about it, but cystoscopy is what tells you the best. So you can say about 40 cc, 45 cc implants. Generally, 45 cc prostate. Generally, I would counsel for 4 implants, 4 to 5, because the financials are involved. You have to tell the patient that it is going to be this much cost. But like in today's case, sometimes you might be able to go away with two implants only.
Because seeing the endoscopic picture, I mean, the
Yes.
lower part of the gland is still like the lobes are slightly coming inside. Why
So
not
that's
another
why-
two?
No. See, the goal should be very clear. We are making an anterior channel here.
Yeah, Dr. Tanuj, I think the job is over.
Yes, sir.
To Anshuman.
Yes, sir.
Thank you.
I'm
Good
just.
job.
Thank you, sir. Thank you, sir.
Dr. Anshuman, can you hear?
If you can see the flow, we have a good flow on table, although it is not always representative.
Anshuman.
Yeah.
Just shift to OTD.
Sir.
Anshuman.
Police staff. Jelly.
Hello.
We'll take a picture.
Let's move to the OTD.
What device देना? Device कहाँ गए? Use किया हुआ device कहाँ गए? वो दो.
Anybody who can connect to OTD?
हैं? नहीं 3-way की जरूरत नहीं है.
Hello.
Hello.
Good morning, everyone. Live from OTD, we are going to start our second case. This is a 74-year-old gentleman with recurrent AUR with Foley's
We'll take a
catheter
picture
indwelling since the past 28 days. On ultrasound, he was found to have 60 grams of prostate. His blood parameters were normal. He's been planned to undergo vapo-bipolar enucleation by Dr. Anshuman Kapoor. Dr. Anshuman Kapoor is a dynamic urologist with more than 27 years of experience. He is currently the consultant urologist and director of the Kidney and Urostone Center in Chandigarh. He has been awarded Himachal Gaurav in the field of medicine, faculty of eminence by the Indian School of Urology. And he has demonstrated his technique of vapo-enucleation, RIRS and MPI access in 32 national and international workshops. He's also a consultant to Alengis Private Limited. To you, Dr. Anshuman, sir.
Hello. Good morning, sir.
Thank you, sir.
Good morning, Anshuman.
Dr. PP, good morning. Dr. Vidur, good morning. Can you hear me?
Good morning, good morning.
Can you hear me?
Anshuman, we are waiting for you.
Yeah. So, sir, before I start on with the case, I will just concentrate on this particular loop which I'm holding in my hand. We'd be working on Autocon Karl Stoll's machine, which is with this device, the only true bipolar in my knowledge. See, in this particular loop, you can see there are two parts of these yellow tubes coming. So this is where the active current comes from, and that is where the negative growth it goes from. So the loop carries the arc from where the current goes in, goes out, unlike the other systems in which the current goes out through the sheath in sometimes, which can be potentially dangerous in certain cases. So, and you look at this pellet, which is made of titanium and iridium, and it has got a particular shape. It's got sharp edges to take the cuts. It's got a concave figure where the surface at the base, which goes with the concavity of the prostatic fossa, and it is a stout, it's a stout pellet. So it doesn't give way when we do some mechanical enucleation along with this. So this particular technique of vapor nucleation is where we combine the best of the bipolar system, which includes the bipolar vaporization. It includes the cutting of with bipolar, which has got penetration only of 0.5. And of course, with that, it's got a stout pellet in which we can actually, mean the normal Freyr's prostatectomy, what we used to do. Once you're in the right anatomical plane, you can dissect. So with this, I will start the initial cystoscopy of the patient with the visual obturator. Because this patient has been catheterized, I will not be doing any dilatation or otis in this case. So there was a beautiful saying which I came across reading another book called Joy of Compounding. And that saying says that the principles are important and it is not the method. If the principles are stout, you have hardly any chance of going wrong. If you
Anshuman,
follow
your
the
seat
methods.
is very big.
Pardon me?
That Anshuman,
Yeah.
the seat is what size? 26, 28. Very big.
The sheath?
Yeah.
Sheath is 26, sir. Normally what you use for TURP. Focus करेंगे थोड़ा. Okay. So we see a flattish, this thing, Veru here. Yeah, focus नहीं दिख रहा है. And as we go ahead, it's an enlarged prostate. We have a median lobe, which is from the lateral lobe only. It's emerging with that.
Do you still do monopolar TURP or you have abandoned that?
No, sir, I actually don't do it now. Yeah, I do only bipolar TURP or I do enucleation, sir.
That's fine.
And
not-
bladder neck incisions.
And monopolar TURP is out from your OT?
It is there. It is as my standby because I have only one bipolar machine. By chance it gives way.
Only standby in case of operative failures. No elective.
No, in the sense if I'm caught in a situation and my bipolar is not working by any reason.
And it is enucleation mostly.
Enucleation, no. Depending on the size, anything around about 40, 45 grams, I might just do a bipolar resection. While in cases of about 50 grams, 60 gram onwards, I do enucleation right till about 200, 250 grams.
And what make you are using? Your equipment is of what make? Olympus?
Carl stores, it's purely Carl stores, yeah. So now you can see that pellet better. You see the sulcus here at 6 o'clock. And the median lobe is somehow amalgamating into the lateral lobe. So the lateral lobe somewhere down here gets amalgamated here. So this will be the 7 o'clock. Because the teaching session, I will be going ahead and showing you doing the median lobe also slightly, what we can in this case, right? And you keep the bladder partially full up in this case like this. And we will start with the initial cut of this plasma. When the plasma cups, a yellow light will appear on this. Can you see the yellow light appearing? The yellow light is the plasma formation of inside the fluid, which itself coagulates. So you got to remember in bipolar, you can't be making very fast movements as you do in your monopolar. So you got to, as I say, I'll be talking about the principle side by side. First principle by doing any enucleation is keep your vision very clear. You always move in the sulcus first because the tissue will be least there. Yeah, you see this sulcus, I'm just forming that completely. Off late, we started doing ejaculation sparing. The results are about 40 to 50% in this. I have not been able to get 100% success with the technique yet. As you come towards the bladder neck, you will see the blood vessels start appearing. Can you see this blood vessel? It is running like this. That means you are nearer to the bladder neck. As you come towards the bladder neck, you will see the size of the blood vessels increasing in size. That's one sign which helps you while you're doing enucleation in the bigger lobes, because at times you are lost. Can you see the capsule now? Can you see that? Hello, am I audible?
Yes, we can see that. This is 7 o'clock.
We started with this is the 7 o'clock incision. Can you see that blood vessel look there? It's beautifully seen.
Yeah.
That's because of the camera, and that shows that we are at the bladder neck, we are at the fibrous capsule there. We need not go at any more depth. And the other sign is you will see corpora elmilsi appearing.
Okay.
At the bladder neck, that's how you recognize the bladder neck. So the principle for any enucleation stays the same as for your HOLEP or anything is concerned. All are energy sources, while enucleation stays enucleation. Just to demonstrate the median lobe, I'll be doing this. Otherwise, this could have been taken as one lobe. It still can be. No, I'll take it. So now coming the other incision at 5 o'clock. I did the 7 o'clock first because it was just too evident there. There's some fogging happening. So I will remember, because I could not see a clean sulcus here, my depth will be much more here before I strike the fibrous capsule. Fogging हो रही है. आपने इसको बहुत आगे दिया हुआ, इसके कारण हो रही है. इसको पीछे रखना था.
Anshuman?
Yeah.
Yeah, we are watching you.
Yeah, sir.
We will request Swapan to shift to the other OTB and
Yeah.
just see what case is being.
Yeah, so I will need you only after I finish this incision.
Yeah.
When I start my median lobe enucleation.
Very right. But please do wait for the important step to be
Yeah.
explained.
बीच में एक देख लो पर.
Please shift to OTB, please.
Hello, good morning, everybody. Can you hear me? Am I audible?
Yeah, you are very well audible.
So this is a case. I hope the case is presented to you. There is a 53-gram prostate.
No, we don't know anything about the case. Please let us know what are you doing and what is the clinical picture of the patient.
Yeah, I'm waiting for them to give the case demonstrations.
Right.
Case history and everything will be given shortly.
In camera.
Okay. So before that, while we are waiting, I'll just tell you what instruments I'll be using for this case. I'll be using a 90.
Hello. Good morning, everyone. This is regarding the case in OTB, which is being done by Dr. Dheeraj, the thulium fiber enucleation of the prostate. This patient, he is a 64-year-old gentleman, and he has a 53-gram prostate. All his routine blood works are normal, and he has significant obstructive lower urinary tract symptoms. And the case is thulium fiber enucleation. And Dr. Dheeraj Kumar from Vijayawada, he'll be doing the case. Dr. Dheeraj is normally doing thulium fiber enucleations using 35-watt thulium fiber laser, and he uses 22 French sheath for the same, irrespective of the size of the prostate. Next, over to Dr. Dheeraj.
Yeah, first of all, at the outset, I thank Dr. Swapan Sood and his team, and also the North Zone USA Council for giving me this opportunity and calling me all the way from Vijayawada. Thank you. So today's case, I'll be using the instrument, this mini resectoscope by RZ. The inner sheet is 19 French, the outer sheet is 22 French, and they have a 2.9 mm lens, unlike the standard 4 mm lens which we use. This I've been using since the last 4 years, and I feel the stricture rate has really come down, and it enabled me
to perform enucleation better, especially to enter the narrow spaces very easily. And this is the resectoscope which I'll use, and I'm using a Quanta fiber dust. It is a 60-watt machine, but I'll be demonstrating the enucleation using the 30-watt because I'm used to do the enucleation, all my enucleations with the 30-watt setting. And I'll also be using a morcellator, which is the Simai morcellator, which is a Chinese make. And it is similar to the Wolf morcellator, which I use, and it has a rotating kind of a morcellator blade.
So, Dr. Dheeraj, you have been using Quanta regularly?
I use an IPG machine, sir, but in this case, I'm doing with using the fiber dust from the Quanta. I've used it prior in one of the workshops, where I demonstrated enucleation case in the last occasion. Should I start with the case, sir?
Just to ask you,
Yes.
Do you have any choice or whichever laser machine of thulium you get, you proceed with it?
Right now in the market, there are 3 laser machines which are available of the thulium fiber. One is this IPG laser, which I've been using since the last 5 years. And I'm also happy when I used the other 2 lasers, which is the Quanta fiber dust and also the Biorad's Quantino laser, which they have launched recently. And I'm comfortable with all the 3 lasers. So the other thing is I use a 365 fiber, not the 600 fiber, which I used to use prior. I feel the efficiency which is delivered by this 365 fiber is much better in doing the enucleation. And the dissection property, I feel is much better with the smaller laser fiber.
Any reason you're using 35 watt today?
No, sir, that is a machine which I have back home and which is the laser which I've been using since the last 5 years. And I feel very comfortable with it. I see no reason why we need higher power machines when we can do a good job with the 35-watt laser as well. Yeah, should we buy the 35-watt laser is a different question altogether because if you have a 60-watt machine, it will help you cut down the learning curve, definitely. But if you have a 35-watt machine, I don't see any reason why you should not start doing enucleations with the 35-watt.
With 35 watt, you will like to keep a limit on the size of the prostate or of any size you will like to continue?
No, the largest I've done is 280 gram prostate, and all my prostates I use the
with 35.
35 itself. Yes, sir.
Dr. Dheeraj, we are watching you. We are just going to Dr. Anshuman for a minute. He wants to demonstrate something.
Sure.
Yeah. Please shift to OTD.
Am I audible?
Dr. Anshuman?
Yeah. So what I'll do is just now I'm just showing you what we've done. We've taken the both incisions on the side. I'm exposed the capsule here, right? So this both has to be connected. Whenever you take a cut, you take with the lateral side of the loop like that. And that's your mucosal cut, just to complete the depth of it. And then you start teasing it with the loop. Can you see the prostatic fossa, your fibrous capsule appearing now?
Yes, we can see.
So this is the capsule, and all you do is nudge it in. Wherever there's a tissue, you take a cut on the lateral side. And your capsule is available. Can you see the capsule there with the blood vessels running down there? Yeah.
Yes, we can see.
So
the
that's
place.
all I wanted to
Still
show.
not sure whether this is the capsule or not.
Yeah. No, that's a capsule, sir. The capsule looks like that. It's just that when you do it with other lasers and all, it gets hazy and you're not able to see it. Otherwise, where it will go. Now, I want you to look at the movement of my hand. It is like kicking a football on the below it. So as you're going, the concavity of the capsule is appearing. And you see the fibrous capsule very beautifully
Yes, we
appearing
can
there.
see it well.
Yeah. And as the blood vessels keep on coming, you activate and there's a lip there of the tissue, which I dissected so that I'm able to reach my median lobe.
So it is mainly the mechanical force which
Of
you're
course.
using at an
No,
angle.
very gentle mechanicals, what we've been
Yes.
using it throughout. And here I'm able to enucleate your median lobe like that. Wherever there's a restriction, you activate the current.
Right.
So you save the loop. As far as the number of cases are going, they'll keep on going higher with that. Can you see the median lobe off now?
Yes, we can see you're
Yeah.
there almost. at
Now,
the
when you
bladder
see the bladder neck there, all you have to do is activate it like that, and you are inside the bladder neck, and while cut on the side, so that you are able to just enucleate it properly in the proper plane. मैं पोल खोल दूंगा. Can you see that, sir?
Yes, we can see it.
Yeah, from my side, you can. So next incision which I'll be taking is 12 o'clock. Just remembering that the tissue there is less, so you reach the fibrous capsule much faster. And then you connect the 12 o'clock to 5 and 7 anti-clockwise at the mucosal level, so that the stress on the urethra becomes less and the chance of incontinence go down.
So in your experience, the incidence of incontinence, is it similar to the gold standard URP or is it more?
It is less.
It is less.
Yeah. I'll show you the technique for
Anshuman,
that. Yes,
sorry.
sir. Why? Because I stick to the level of,
Chances-
I don't go chasing my lateral lobe, sir.
Anshuman,
Yes, sir.
chances of stress incontinence is more in enucleation.
Agreed.
You
but
agree
not
or
by this
disagree?
method. No,
But
not
this
by
is
this
the fact
method.
is
It's a
chances
technique.
of-
No, I deny that, sir. I think it's a technique. I would have agreed with you 6 years ago when I started doing it. I do not agree with you now.
No. We have been using Olympus. Enucleation as well.
Olympus enucleation is very different, sir.
Enucleation technology is same.
Oh, no.
But
No,
what
no,
is
technology is same. You know what happens in that is, because you're using a thin loop, you are, I'll show you. No, I'll tell you what my
No, no, I'll
lateral
show
cut,
you
no, one
almost
lateral,
same.
no, sir, Yadav sir, just look at that. When I take my cut from here, I will be staying at this level. I am not going here and enucleating it. So the more mucosa you leave in this area is the chances that you will damage the sphincter less. So when I'm sticking to this level and leaving a huge
Anshuman,
lip
the
there.
stress is because of the mechanical force. It is
Sir, the
not because
mechanical,
of
no,
the
no,
clot.
the mechanical force is reduced as soon as you take a good mucosal cut, sir.
Yes.
I will show you that.
So as we understand, the trick is to stay little more towards the bladder.
Absolutely, sir. And the
Rather
other is taking a good mucosal cut so that the stress at the sphincter is less.
It is not because of the current. It is not because of the bipolar.
No, it is not, because bipolar has
because of
penetration
the-
only of 0.5, sir.
It is because of the mechanical force which a surgeon uses near the.
Well, let's see. Next time we have a debate on that, sir.
Yes, you will not believe, but I am using the Olympus bipolar technology plasma
Yeah.
since 2010.
I
Almost 14 years.
Yeah, I have been using bipolar since 2006, sir, Gyrus. I started with Gyrus and I started with
with the
nucleation
Gyrus.
also with Gyrus.
I started with the Olympus.
Yeah, I started with Gyrus
Recently,
in 2006.
You can do plasma vaporization, you can do enucleation, you can do resection.
Yeah, you change the loops in this, sir. In
Yes.
this, you need not change the loop.
Yes.
You need not change the loop. एक मिनट इसको पास लाएंगे थोड़ा मेरे कटेंगे. So I'm starting with the mucosal cut, sir, which I'll show you what I'm saying. You start at this level itself. I am not bothered about the tissue being cut. I am just taking a deep, nice mucosal cut.
Yes.
At the level of mucosa, at the level of Veru, seeing where I'm going. I have taken my incision till here. And as you're saying, I'm going anteriorly, I'm actually moving towards the bladder neck.
Yeah.
So that's the technique for avoiding your anterior mucosal slip which you leave higher, which Thomas Herman has been talking about, on who's actually designed this loop. A very good friend. So we've taken the mucosal cut. Now look at my outside. I wanted to focus. I have kept my scope on the right leg and I'm working on the left. I keep my loop here, which is a stout loop, and I give a gentle touch.
The lifting is very good at this side.
Yeah. So,
Very
and the
nice.
other is you find your mucosa very easily, your plane. All you have to do is tease it out. And as you get any blood vessels will come, of course they will come. And you just keep on, you create a plane here as you do in your enucleation with the laser. So my point when I said the principles should be intact, it doesn't make a difference what the technique, what the method is this. So principle is exposing your mucosa, principle 1 is cutting the mucosa well, and the principle 2 is making an anatomical plane. And as you keep on doing that, your job keeps on getting easy. You can see corpora amelia here. So I am at the base, okay? You activate your current and you go into the depth. At the same time, you tease. You got to remember in the lateral part of the lobes, you will get this lateral prostatic ligaments, which are the ones which hold the prostate back in the lateral side. You got to be slightly patient there. And if you leave a small lobule behind, don't panic. You can always come back and vaporize it, or if required, even resect it as Malik does.
If you are in the right plane, there is no problem. You go on lifting, the prostate will lift up and the vessel will come, you just aggregate them and reach the neck. And at the neck, you may morcellate or you may dissect without morcellation. Can we go to Dheeraj?
Yes, please, sir.
I have a question. Anshuman, you have HOLUP, you have bipolar.
Yes.
Where you feel more comfortable? You want for a patient?
I use my bipolar a lot.
You use this. And you use mechanical force here, but in laser, everything is with the energy only.
Why use energy so much? Energy is energy.
Mechanical.
Yeah, mechanical as well as energy. Both, it's a combination.
Okay, now shift to, we're going to other.
Yes, please, please. I wanted to show what I've shown. Thank you.
Can we go to Dr. Dheeraj in OTB now?
Audible?
Yeah.
Yeah,
Dheeraj, you're audible.
Yes, sir.
We were seeing you all this through.
Yes, sir.
Yeah.
So I just
Could
want
you
to show
please
what I have
explain?
done till now, sir. This is a verumontanum. So I'm going to demonstrate an unblock enucleation today. All my enucleations would generally be unblock unless if the prostate is too big, or if there is a lot of prostatitis where I need to give a single incision and do a complete, do an unblock technique. This gland also, there is a lateral lobe, not much of median lobe, but a narrow bladder neck. So I am planning an unblock enucleation in this case as well. So this is the verumontanum, and I'm going to demonstrate the ventral mucosa sparing technique here. So this is the ventral mucosa, if you can see here, which is the vital thing, which is overlying the external striated sphincter complex, which is very essential in preventing the stress incontinence, which is commonly seen after enucleation. So before starting the procedure, what I've done was I've marked the initial 12 o'clock region just above the verumontanum. You can see here, that is the initial marking which I have done. And then what I've done was I've actually developed this posterior surgical plane. If you can see here, the capsule here, and you can see that the blood vessels running parallel here. And I've done the enucleation in such a way using a little bit of mechanical energy and also using laser energy whenever required for hemostasis and breaking any adhesions. I also believe that a little bit of mechanical energy would be required to develop good planes. And if you can see, I've developed the posterior plane here and also a little bit of lateral plane till the 9 o'clock position on the right side. And also this posterior surgical plane along with a little bit of lateral dissection on towards the left side as well till the 3 o'clock position. So after that, what I'm going to do is I'm going to stop at this point of time. I'm going to come back and try to preserve the ventral mucosa, which is overlying the sphincter. This is the 12 o'clock incision which I've given. This is the mucosal wing which I have raised, and this is the apical part of the prostate, which comes beyond the verumontanum. See, this is the verumontanum, unlike the TRP where we limit the dissection here. This dissection goes beyond the verumontanum like this. This is all the prostate which are dissected here. And the most important part of this, any enucleation, one would agree, is going into this anterior plane. We have gone into this posterior plane and we have developed this lateral plane very easily. And the most important part here is to go into the anterior plane at the same time, preserving this ventral mucosa, which is overlying the striated sphincter complex, and which is very essential. We have to do because we don't want any stretch on the sphincter, which might cause any stress incontinence after the procedure. So these are the mucosal wings which I have raised by developing this posterior plane. This is a 12 o'clock incision. And now I give an inverted V-shape incision. This is how I give an inverted V from above. And this is all the ventral mucosa which gets preserved. So how do we get into the anterior plane? This is the plane which we have developed till the 3 o'clock until the 9 o'clock position here. I'll stop at that. Since I have given an incision here, I'll deepen the incision a little bit.
Dr. Dheeraj, you have made the anterior markings and you have made the markings near the viru. Do you make some markings near the bladder neck at 7 or 5 o'clock, or
No,
that
sir.
is to be avoided?
No, sir. I do a completely unblocked technique. So I don't need to go near the bladder neck, sir. So I start everything from the verumontanum, release.
Anterior markings and virumen.
Yes. So I do the early apical release. This technique, we do the early apical release with the ventral mucosa sparing. That's what we call it.
And you are doing everything with energy, no mechanical force?
No, sir. I use mechanical laser energy, more of laser energy in this part of the procedure where I need to be very careful separating this mucosa, which is overlying the sphincter complex, and also near the bladder neck where mechanical dissection may not be possible. Rest of the areas, whenever possible, I do mechanical dissection. But this is not a very big gland, if everybody would agree. And doing mechanical enucleation here is not so easy. The ideal glands where we can do a mechanical enucleation are the prostates where it is between 60 to 80 grams, and this one of the smaller prostates. And we can't get the planes very easily. We need to use more of laser energy rather than mechanical, especially in these cases.
In your OT, you are doing mostly the lasers, or you still have some scope for the bipolar or monopolar TRP?
We have the scope, sir, but I haven't used those in the last 5 years, maybe, sir.
No, not used means not done even a single case with
No.
TRP, bipolar or monopolar.
No, sir, no.
Thank you.
Dr.
So-
Dheeraj, given a choice, what would you prefer, POLAP or THOLAP?
Sir, I
Given a
prefer thulium fiber, sir, not the thulium YAG or not the holmium YAG. I have my own reasons for that because I started my enucleations with the thulium YAG laser where I was doing little bit of mechanical energy, using mechanical force and using the continuous mode of energy to cut through the gland and find my way out of getting through the surgery. But after this TFL has come, if you can see here, I'll demonstrate maybe a little bit later on. I'm not using the contact mode. If you can see, I'm using the laser energy, which is in a non-contact mode, unlike the thulium YAG laser. And if you can also notice, there is not much of charring also, just like the holmium cases which you see. You can see that the capsule is being demonstrated nicely. There's not much of charring when I'm not touching the tissue. So I'm getting a good dissecting property with this laser, just like the holmium laser does. And also the hemostasis I feel is little better than holmium also, because the absorption of the thulium fiber laser is much better than holmium in water. And the energy efficiency also is much better than in the holmium lasers. So this is, I just wanted to emphasize here, the anatomical enucleation of prostate. This is the sphincter here. This is the most important step in the enucleation. Enucleation is all about landmarks. See, initially I started off with the 12 o'clock landmark. Then I developed this nice surgical capsule, if you can see here. And I gave a incision, that V-shape incision. And you don't need to progress blindly. If you can see it, this is the capsule. If you can appreciate towards my right side. And this is all the prostate lobe, which is on my left side. So based on that, I'm going to use this energy to go into this anterior plane as well. There is a fine line of error, because if we want to avoid more the sphincter complex, which is about here. This is the sphincter complex, if you can see. This is a sphincter complex. This is the prostate. This is the prostate, and this is the capsule. This is the capsule. This is the prostate. And if you come back, this is the sphincter complex. You see this mucosa, which I'm preserving, comes and lies over this sphincter complex after the procedure, and it will help to reduce the stress incontinence, early stress incontinence. So similar thing I'm going to repeat on the patient's right lobe. The incision which I have given, I'm going to deepen it. At the same time, I'm going to utilize this capsule as a landmark so as to see at what level anteriorly I need to join both the planes. So if you want to be more careful, you can leave a little bit of tissue at this point of time, but you might not be able to find the perfect capsular plane. At the same time, if you want to go into the right capsular plane, then you might cause a little bit of, you might have to sacrifice a little bit of mucosa, and there'll be a little bit of stress incontinence after the procedure as well. So it's a fine line of error we can make at this part of the surgery. And as we do more cases, we'll be more.
This is a request that now this is.
Yes, sir.
When will you like to change the chairpersons?
So thank you, Chairperson, sir, for moderating the session.
Shuman, thank you. Thank you, Dheeraj.
Thank you, sir.
The cases will go on, but we have a new set of chairpersons for this session. May I invite Dr. Atul Khullar, Dr. Harban Singh, Dr. Sunil Mittal, and Dr. Ayush Ketarpal. So while these cases will go on, we have next three cases which are lined up. Dr. Dheeraj is already doing tooth flap. Robotic prostatectomy is going to be demonstrated semi-live by Dr. Sudhir Raval. And then holmium enucleation is ready with Dr. Tanuj Bhatia. Over to you, sir.
Connected to Dr. Dheeraj. Yes, sir. You can hear me? Am I audible? Yes, sir. Can you speak a little louder, sir? I'm not able to hear you properly. Sound. Yes, sir. Yeah. I can hear you, sir. I heard that planes which are developed are looking good. That's what you're saying. So there is a lot of debate about this thulium. When we use the thulium laser, there'll be a lot of charring. So that's what everybody complains. But it's how we use the laser is more important rather than blaming the laser. That's what I feel. So if we see here, this is the final part of the mucosa which I am releasing. I'll use a little bit of contact mode so that the mucosa is completely spared. You can see if I'm using the contact mode, then the tissue is getting charred here. This is the final bit of mucosa which I have to separate from the apical part of the gland. But if you're not touching the prostate with the laser, if you are using the non-contact mode, we'll just get that effect of this of the holmium laser, where everything, all the dissection is produced by the photomechanical effect, and there's hardly no charring, and you'll develop planes very easily.
Do you change the energy at any point, or you use 35 watts all throughout?
I use 35 watts and one frequency of energy, and I use the same frequency for my hemostasis as well.
Hemostasis is just by defocusing.
The good part about this laser is you don't need to defocus also. The reason for that is the that in a holmium laser, all the waves are very scattered. All the wave pulses which are generated are very scattered. One might be long pulse, one might be short pulse, but in thulium fiber laser, all the pulses which are generated from the laser, they're uniform. So you're not going to, the pulses are very uniform and they're going to be focused at a particular area. You can just defocus the laser or use the laser energy by touching the part where it needs to be coagulated and burn it. It's a very good hemostatic laser. I think all the whole of surgeons also would agree with that. So this is the final part of the mucosa which is released. If you can appreciate here, this is the ventral mucosa which I have preserved, which will overlay the sphincter complex. This is a sphincter complex here, and this mucosa will come and fall here. And this is the other part of the other side of the mucosa which will come and fall here. This is a sphincter complex, and the complete apical part of this prostate has been completely resected out. Am I audible, sir?
Yeah, you are audible.
Yeah.
So you always move from the apex to the bladder neck?
Yes, sir. And until this point of time, my dissection, if you can notice, has been from below above. If you can see, from the posterior to the lateral. So once I have completely detached this mucosa, which is overlying the sphincter complex, I'm not going to the posterior aspect again. I'm just staying at the anterior plane, which are connected on both the sides. And I'm going to go till the bladder neck in the anterior aspect only.
Do you use any different technique or strategy if you are dealing with a very large gland or in a small gland with prostatitis where you don't find such plane what right now you are looking?
Yeah, I agree, sir. In very small glands, I believe this is one of the smaller glands also, and I'm having a little difficulty. If at all I'm not getting a good plane, then what I usually do is I go till the bladder neck here, give an incision. From the bladder neck, I develop a plane and I'll do a unblock technique, but with a single incision. So in this case, that is not required. And I was able to enter the anterior plane on both the sides. If you can see both the lobes, the anterior plane has been connected. So yeah, I can essentially say that the posterior, the prostate all round, I was able to dissect out from the sphincter complex. So whatever I do is the early apical release, which I have done with the sphincter saving technique. I mean, ventral mucosal sparing technique. So if I do a little bit of mechanical enucleation as well at this point of time, there won't be any stretch on the sphincter. And it is quite safe to do mechanical dissection as well at this particular juncture.
When you are doing retrograde approach,
Maybe.
and you are not.
Hello.
Yeah.
Hello. Am I audible? Hello. Chetarpal, am I audible?
Hello.
Can you hear me?
Yes.
Can you shift on this? As we are coming towards the bladder neck, you can see blood vessels are increasing in size, and we are at the lobe is in front of me, and behind me is the fibrous capsule. I believe the way you see fibrous capsule might be amiss because this is the way you see it here, not in the enucleations with the laser where the cutting is, the energy source is more. And you can see how easily it is just going through. I can see it here when you are at the bladder neck, all you do is activate your loop and you are going inside the bladder neck and you are just enucleating the lobe now. This is what I wanted to show you, and at the bladder neck, how will it look?
Dr. Anshuman, this is Dr. Harbans here.
Hi, Harbans. Yeah, tell me.
Yes, we can see that.
And there's a leash which is holding it here. That can be just cut with the lateral side of the loop. Yeah, you were saying something, Harbans?
Anshuman, I was just saying that we are seeing that plane, we are seeing the capsule, you are dissecting at the level of bladder neck.
Yes.
And, have you done, now you are joining with the incision you have made at the 12 o'clock.
Right? Yes. So at times there's some leash holding him back also, but you can see this is the tissue which is holding back. So there goes my one lateral lobe. My one lateral lobe is done. I can see the capsule here. All I want you to show is the capsule, the way it looks after the bipolar enucleation is done. It is pretty avascular and there is no charring. If there's a tissue like this, you can just at the same loop, you don't have to change the loop. एक मिनट ये पास करिए प्लीज, पास करिए फुट, उसके पीछे कुछ सपोर्ट रखो. So you can just vaporize what you want to, like this tissue here. That's it. Now I'll be going ahead with the other loop, other lobe. This lobe, as soon as the one lobe is fallen down and gone into the bladder, will fall into the lumen of the prostatic fossa. So the cut becomes much easier.
How long post-operatively you keep the catheter in these patients? What is?
Yeah, 48 hours, sir. They are standard.
Is there any pink urine like we have in the laser with this technique after that?
At times, yes, depending on the gland size. So there are times when I don't use traction at all. Irrigation I always use. Being a private practitioner, I don't want to be in a situation. So when we are here, make it sure you have cut all the attachments to the mucosa well before you try and create a plane, because I do use some mechanical force for my plane creation, which is very simple. I keep it here. You're seeing the prostatic fossa, fibrous capsule there, and you just try and juggle out a plane here.
Anshuman,
Yes.
as in Holland,
Yes.
we cut the mucosa at the level of verumontanum.
Yeah.
With the just waves of the shock waves of laser,
Yeah.
they create a plane.
Yeah.
And you see the adenoma, apex of adenoma nicely
Yes.
separating from the
This-
from the sphincter. But in this tube, the incision which you make with the loop,
Yeah.
it is just a presumption that it is the plane. We are just
Okay,
presuming
you're
that
no, you're not present. Excuse me. You see the fibrous capsule here?
talking about right now at this level.
Okay. No. So, the initial cut which I take at 5 o'clock and 7 o'clock is the time I define my capsule. You will see it with corpora amylisa, you will see it with the blood vessels, and that is the sign of my fibrous capsule appearing.
I'm just asking that.
Yeah.
Sometimes you go into a wrong plane at that point because you are just pushing the loop there. And
Yeah.
this is it is a line at the level of where you are.
No, you got to understand.
Do you find any type of injury to either the sphincter or you find that you have entered into the lobe?
No, I'll come to that answer of yours. You got to understand that there, as Devendra was saying, there are principles to enucleation, right? The energy source is changed. It is nothing else. The technique almost stays the same. And you define your bladder neck at the level of Veru, because the mucosa is very thin between that and the fibrous capsule. When you take your initial cuts, there's a time when you define your depth of your where the fibrous capsule will appear, and you see it very clearly. I am not sure whether you're seeing the initial part when I started. You first defined the capsule before you even take a mucosal cut on the 5 or 7. When you join this anti-clockwise and clockwise to the 12 o'clock, before that my incision is taken and the bladder capsule is defined at the median lobe at all, immediately. In cases where the median lobe is not there, of course, as it is, the mucosa is very near to the area which is lying at 6 o'clock. So as far as the question is concerned, no, we do define it before we go. It is not a blind procedure. And the learning curve for bipolar has been proven to be lesser than your homeom YAG. So in certain cases, you will find such lobules which will be penetrating your capsule. In that case, you can just go through them. And if required later on, cauterize them, vaporize them. Look, I'm going through it because it was hindering my capsule flow.
What are the energy settings you use for this technique?
It's got a fixed factory setting for vapor nucleation. On auto con 400.
Do you change settings during the dissection at near the sphincter level, or you keep the same setting on?
No, I say keep the same setting on it. My incidence of incontinence is actually very low. And I preserve that to the preservation of the ventral lip, which has come out as a concept now. I've been following it for a long time. I used to cut at the level of Veru, and that is what has preserved me.
What do you feel your technique of leaving a tissue at the apex?
Yes.
And that makes a difference in the incontinence.
Yes, it does, sir. I haven't found a difference in the flow post-operatively. We get peaks of 45, 50 after this procedure.
Do you find the need of any Kegel exercises or drugs?
In very large cases, which I deal with 150 plus, I put them on Kegel exercises prior, and anything more than 150, I actually put in a catheter also week prior.
A week prior.
Yeah.
Okay.
For big glands, I do because that just dilates my urethra. You know, you do any energy source of 200 grams or 300 grams, you'll spend 2 hours inside, whether it's a homeom YAG or it's a thulium or it's a bipolar. The idea is not to roger the urethra rather than anything else.
Can we shift to other OT?
Yeah, please. Thank you.
Very nice job, Anshul.
Thank you.
Sir, am I audible?
Dr. Dheeraj?
Yes, sir.
Yeah. Dr. Dheeraj, I was asking a question that when you are going retrograde, dissecting from the bladder neck, finding a correct plane at the bladder neck, it is sometimes difficult.
Yes, sir.
If you are developed the plane in the beginning at neck and then joining the from the apex side, like you are going into a correct plane. But sometimes in retrograde way, you find you go deeper in the bladder. How do you avoid that?
Yes, sir. When we start this enucleation process, definitely directly attempting an en bloc enucleation, that is the hardest part of the surgery. I would agree to that. One is releasing this sphincter. If you can see here, this ventral mucosa, which I have released, that is a difficult part. And the other part is where do you enter the bladder neck is more important. That is also very difficult. So people start off with doing the 3-lobe technique, then switch over to 2-lobe. And if you're very comfortable with the anatomy, you do this en bloc. And my principle is that once we detach this apical part of the gland from the mucosa, all the dissection has to be done between the 11 o'clock and the 1 o'clock region, not below. Because the capsule near the trigonal region is very thick. But the capsule at the anterior region between the 11 o'clock and the 12 o'clock region, it is very thin. That's where you can find the bladder neck fibers easily and you can enter the bladder through that area. So what I've done was I've gone anteriorly, and there's a little bit of prosthetic tissue which I'll be removing. But that is the part of the bladder neck where you will be able to find the bladder neck fibers very easily because the root is more straight from the apex towards the bladder neck and at the anterior region between the 11 o'clock and the 1 o'clock region. So that is where I have entered the bladder neck. And once you cut the bladder neck, I'll go all round. I'll cut the bladder neck all round. If you can see, the entire bladder neck has been stripped away. See, this is the prostatic mucosa, which you can see, and this entirely has been exposed, both on the right side and also on the left side. So my entire dissection after opening the bladder neck will be from above downwards like this and from lateral to medial. So one of the most common thing which you will encounter during your enucleation process is the perforation of the glands. I believe the perforation happens especially if you're lifting the prostate from below when you give that 5 o'clock and the 7 o'clock incision where the perforation tends to happen here. But when you're carrying this dissection from above below, you'll have complete control. You don't need to lift mechanically and everything falls into place. If you can see, there's hardly any perforation. The capsule is seen nicely. And because I use the non-contact mode, there's hardly any charring. And also you have to remember that I've done the entire procedure with a 30-watt laser itself. So this is the lateral dissection and the anterior dissection, which has been completely done. And the only part of the prostate which is remaining is the one which is near the trigone from the mid region towards the bladder neck. So my dissection here would be completely from above, below, and lateral to medial. And to prevent this going into the subtrigonal area, what we have to do is you progress the dissection from lateral to medial here. If you can see, the bladder neck has been completely exposed. And based on this, we can assess to what kind of depth we need to take out the gland off its capsule. So that's important to expose this bladder neck very early in the procedure when we are doing this posterior dissection so that we have landmarks. Enucleation is about landmarks, unlike TRP. Unless you see a landmark, you can't progress. If I didn't have that landmark earlier, I don't know where to go, whether I have to go deep or whether I have to go into the gland or what. So the most key here is to have a landmark here, the bladder neck, and based on that, I can always dissect to what level of enucleation I'll have to go. So once you know your landmarks, then you can do whatever, you can use some mechanical energy, use a laser energy if you're comfortable. The question is not which is better, how comfortable you are using, you are with using the mechanical effect or the laser effect. The good thing about this thulium laser is that you can use the non-contact mode, or you can cut through the prostate sometimes, or you can use a gentle mechanical effect as well and do a good hemostasis with this laser as well. It's a versatile laser. See, this dissection comes from above downwards and from lateral medial. You can see the bladder neck is nicely exposed here. And so that which will guide me to what level of dissection I have to do. Once when somebody is starting an enucleation procedure, this is not the ideal gland. Maybe a little bigger gland would be helpful because the planes would be much easier than what I'm getting right now. Because that gland tends to stick more. If you are doing a 60-gram or 80-gram prostate, all this can be done mechanically as well. Unlike my routine, I'm having to use a lot of laser energy in this case actually.
Dr. Dheeraj, Dr. Atul Puller, the whole audience has appreciated your case. You demonstrated very nicely the planes and the technique and all the finer points.
Thank you,
sir. From the house, we are going to give you a lot of applause. You can hear that.
Thank you, sir. Thank you. Means a lot to me.
Thank you very much for demonstrating a very nice laser technique.
Thank you, sir.
We'll be shifting to the next OT.
Yes.
Thank you so much.
Thank you. Thank you.
OTD now.
Good morning, Dr. Rawal. Can you hear me?
Morning. Can you hear? I can hear you. Can you hear me?
This is Dr. Harbans here.
Ah, Dr. Evans. How are you?
Morning, Dr. Rawal. Dr. Atul.
Morning. Yeah, Atul.
So nice
So,
to see you again, sir.
thank you. Sorry, I could not come because my two guys will be there in afternoon. They are starting from here at 1:30. So I thought I will stay back for otherwise I would have loved to come. So shall I share my video?
Yeah, sure, sir. Go ahead.
Okay, I'm going to speak on yeah, rather show. You need to enable me for participating the screen. Somebody that IT guys. Robotic simple prostatectomy. Nowadays, the shift of benign prostate is also going on robot. The reason is that laser, if you have to be in urethra for 3 hours or 4 hours, so you can imagine what will happen to urethra. And rather, robotic prostatectomy itself is evolving into completely urethra sparing surgery. What I'm going to show is where I have done from transfer cycle, but people are doing it without even going to urethra at all, which is Medgin a simple prostatectomy where they go through the retropubic space and they do retropubic prostatectomy as we used to do in open surgery, but they do not touch urethra and the catheter is removed next day. But here I will show the classical simple prostatectomy. The docking is same as you do for radical prostatectomy, and then you start using the bipolar and monopolar. You have to open the bladder. I'm going to open the bladder here, but I think in future we will be shifting to completely retropubic radical prostatectomy, which is where we will not be opening the urethra. I'm just waiting for a suitable case. Classically, it was started like this. A lot of reports are in the literature from every, robotic center, and they showed that how beautifully you can see the adenoma, which we used to remove when I was doing MS by putting a finger into the urethra and breaking the plane between adenoma and the prostate and doing blind dissection. It's great to see the same thing in robot that what we were doing at that time blindly. That just shows how the things they have changed. So if you have everything, there is no need of doing open prostatectomy. Here you can see the adenoma, median lobe projecting into the bladder. We do see a lot of big prostate because benign prostate is first treated by the medication. So that is why a lot of people, they don't come for operation early when they have the symptom. They'll end up with the medical treatment and prostate keeps growing, and they can have the 300, 400 gram of the prostate. So you make an incision of the 12 o'clock, 6 o'clock rather, to dissect between the bladder fiber, there's the bladder neck, and the adenoma. Once this gets defined, then you proceed the dissection and you make sure that you are dissecting, you are enucleating adenoma rather than not going into this, into the adenoma or into the prostate tissue, which is the posterior part, peripheral part of the prostate tissue. You can see the bladder neck fiber by blunt and sharp dissection. Since the planes are very clear and there is some mild struggle can occur when the adenoma is out into the bladder. At that time, you can take even suture with using 2-0 Vicryl. But in this case, it was not required because prostate was not very big. So in the interest of time saving, I'll be doing some, skipping some steps. That was the posterior. Then you go to the lateral. This is full video which is recorded. I have not edited. So I'll be showing you the two clips. You can see the ureteric orifice right here. I'll be sharing another clip after once this clip finishes. and Rishi has given me 20 minutes, out of which all the minutes I spent in logging in, it was probably a bit safety features which did not allow me to log in at 10:30. So you keep dissecting, making sure that adenoma is coming. There's a beautiful plane between adenoma and the bladder neck fiber and the rest of the prostatic tissue, which we have seen when we were doing the blind dissection. You go all around from posterior to lateral to anterior. Here, suction and assistance is very important because a lot of dissection is oozy, since we do not take the 5 and 7 o'clock sutures. Though those vessels are still there, so the bleeding will definitely be there. But it's not any of trouble because not major vessel comes here when you do the dissection, or even if you have the DVC come in the field. But the robotic has made even DVC tackling the very easy, which used to be a huge problem when we were doing open radical prostatectomies or any open prostatic surgery, which we have seen in past when that what was happening. So you can see very easily you can dissect the plane with blunt and sharp dissection. And I'm sure once you have start using this from the retropubic space, there may be sometimes small hole in the urethra, but most of the time you can come out of without making any hole in urethra, and finally you remove the prostate. So in that case, the patient's recovery is great, and there are hardly any urethral related complication like any stricture or anything. So you go all around, keep dissecting till you find that you have dissected the adenoma completely. Then you take it out and at apex actually, then you can see the apex also, but the planes are always nice in adenoma big gland. And this surgery finishes in most of the time in 1 hour, 15 minutes or 1 hour, 30 minutes. One thing is that this gives the freedom of removing whole of the prostate. You need not to worry that if there is any, like in TURP, you feel that there will be a, any syndrome related to glycine and all. Those things you don't need not to bother. For any overhydration or anything, nothing will happen to the patient.
Sir, is it easy to identify the apex with this technique?
Yeah. It comes on its own. There is hardly any problem. When you reach to the apex, I'll be showing in this. Sometime like now, this is at this point of time, I generally use a 2-0 vicryl and pull the prostate. But here it's not that big prostate, so I think without taking that suture, one can definitely do this. And Vince, everybody, I think younger guys, everybody knows the anatomy of DVC, and also with the robot, that's not a big problem or anything. See, you are going from lateral and then you go anteriorly, the apex will come here. It comes easily. You can see here that we are going towards the apex, so it is dipping down. I'm not going to edit to make any fast forward here because it's almost being done. So you can see all the steps easily so that you guys can do. People actually started doing with laparoscope. If anybody, many of you will remember that when the laparoscopy came, especially in America, Dr. Indigal and all, they were doing laparoscopic simple prostatectomy at that time. But with the robot things, they changed completely, and now it is in the hands of everyone. We have all sorts of robotic version. Also, we have other companies. So naturally, this is going to change the game in all the surgeries at all the places in country. So this is the apex which is coming, and once this is done, there 2-3 minutes. Once it is done, I'll share another clip. After I'm sharing this, I'll share another clip, which will be removing this. You can see the apex catheter here. The posterior section and then anteriorly and just keep it. So I will stop share this. I will share another clip which will be showing that how the things. And this one. So I'll just share another one. This one. Okay. Again, I'll just make 2x playback speed 2 and this is the adenoma which is out. I have removed bigger than this, and it's very easily to do. There is hardly any problem when you operate these guys. Then you put a catheter and will be suturing the apex to the bladder neck by using the V-lock suture, 30 V-lock suture. This you can do anyway. There is hardly any problem. It's better to suture because if this patient can have some time the CA prostate in future, then doing radical prostatectomy will be easier because anatomy is maintained. Otherwise, it may cause some problem. But it's not a big deal. Even if you leave it like this, inflate catheter in this, is everything is going to stop. You can see there is hardly any bleed.
Yeah, so Dr.
It's
Rawal,
just,
hello.
patients are living. Yeah, yes.
Sir, in HOLEP, we are relatively blind at the bladder neck, but in this procedure, we are much more blinder for the apex, which is perhaps more important issue in any enucleation of prostate. So how do you actually define that you have reached the prostate apex in this kind of a procedure?
Yeah, actually, at apex, it was going down. It's already the adenoma anatomy already, it takes you to the apex when you are dissecting from posterior and laterally. So you cannot go in DVC when you are doing a radical. This is thing that we may enter into DVC if apex is not defined. That's what you worry.
Yeah, so with the pull being directed upwards, it may pull the sphincter also, and with the use of cautery and cutting, there actually a perceived risk of injuring the sphincter.
No. Yeah, well, actually, no. Well, okay, go ahead. You finish. Yeah. No, this sphincteric injury will not occur. We are quite away from sphincter. And looking at, if you see that right now, sphincter actually is morely on the dorsal side. At the when you do the radical prostatectomy, that anatomy is different. So in patients of benign enlargement, when you do transfer cycle, or maybe when we do the retropubic, I doubt that we are going to injure prostate sphincter at all. So that's probably will not happen with this. And you can see that there is hardly any bleed. When you are having adenoma, the apex actually takes you down towards the urethra easily when you saw in this, but you have to come from posterior, lateral, and then towards the anterior. Dorsal venous complexes and sphincter is way away from this area. They are outside, rather, the outside the prostate. The peripheral rim of the prostate is still intact. So these patients will not land up with the incontinence, as sometimes can happen with TURP and other endoscopic procedure.
Connect to OTD.
So if I'll just fast forward, this is a simple suturing of the raw area which is there, and the bleeding stops on its own. We put catheter and a drain, though it is not required, but drain is also put. You can see that now the bladder neck is opposed to the urethra.
Are you keeping catheter?
2-3 days, just on.
Can we shift to OTD, Dr. Dr. Rawal, thanks a lot.
Yeah, thank you. So we'll be just closing the bladder, and thanks a lot for giving this opportunity, and I think best wishes for your conference. Sorry, I'm not there, but next time I'll be coming. Thank you.
Thank you, Dr. Rawal, and a big applause from the house.
Thank you.
And we can, master it. It will be very easy, very nice.
Yes. Thank you. Yeah. Easily you can master it. You guys are young. I learned it very late.
Otherwise,
thank you.
We are struggling with the suction part of it. You change the morcellator otherwise.
Dr. Anshuman, we are with you now.
Hi, sir. I am on to my morcellation. The only 2 points I want to make is I use double irrigation while doing my morcellation, just to escape the mucosa. We are struggling with the morcellation suction here. So there's nothing much to show at the moment except for the morcellation. So I think I'll just wait for them to figure out the morcellator before I go in again.
Thank you so much for
Thank
very
you.
nice demonstration.
Thank you, sir.
And we really enjoyed.
Thank you,
showed
sir.
Very nice planes and very nice hemostasis as well. So congratulations from our side.
Thank you,
We'll
sir.
shift to HOLEP. Thank you so much.
Thank you.
So can we connect to the HOLEP OT?
नहीं पहले इसको सेट करो पूरा. हाँ.
Hello.
So on the side A, we have a resume ready, being done by Dr. Dharmender. Hello, OT, can someone please tell us about the case? Dr.
Good
Sayam?
morning.
Hello.
I'll just introduce and shift. Good morning. We are now going to start our new case in OT number C. This is a 75-year-old gentleman with acute urinary retention and PUC in C2, which was inserted 10 days back. And after that, his current urine output per day is around 2 to 2.5 liters. So this is a high-risk anesthesia case because he's a known case of coronary artery disease and his blood thinners have been withheld. He's also a known case of epilepsy. He's on treatment since 2006. Ultrasound showed a 44 grams prostate with back pressure changes in both the kidneys. Before catheterization, his creatinine was around 2.2, and now after catheterization, his creatinine has now decreased to 0.8. Now to Tanuj Paul, sir.
Okay, so this patient is planned for HOLEB in OTC. On the left-hand side of the screen, we are ready with the resume. Once he starts, we'll go to the other patient also.
Am I audible, sir?
Dr. Tanuj, you are on.
Hello. Am I audible?
Hello. Yeah.
Am I audible, sir, to the auditorium?
Yes, you
A
are.
little late on, KG. So, sir, this is a very high-risk patient with a 44 cc prostate, and he was on antiplatelets. It's an ideal case for laser prostatectomy. Also, he had obstructed uropathy, which has creatinine is now normal after catheterization. So again, for patients like this who have chronic retention and obstructive uropathy, and also he has a EF of 25%, HOLEP works very well. So we'll be doing HOLEP. As you can see on cystoscopy, it's not a very large gland. And when the gland is not very big, I generally prefer to do a en-bloc technique, also because it is very fast technique. And the laser we'll be using today is Jenna surgical laser, 100 watt. This is the same machine. I have a 150 watt machine at my center, which I am using since almost 1 year. And it has worked very well. Till date, I have not had to change my blast shield. And it is the second fiber we are using. And I operate at 140 watt with that machine. But today with this machine, we'll be operating at 87 watts with a setting of 1.75 joules and 50 hertz. Ye dikha dijiye, camera. One more thing you can appreciate in this machine, the settings are customizable. So just like in the robot, you click on the name and the settings are changed. In this machine also, based on surgeon's name, you can save the settings and you can use accordingly. To save the time, is a high-risk patient. I will start with the procedure, sir. I'll do an en-bloc technique wherein my first incision will be here, just proximal to the veru. I will reach the capsule.
Can you show the endoscopic vision? We are seeing only the surface view.
Okay. Ready, go. Can you see now, sir?
Yeah, it's visible
Yeah.
now.
So this is we can see it's mainly a lateral lobe with a little high bladder neck. I'll be doing a en-bloc technique. First incision will be here, near the veru, extending to either side. Then I will be marking my distal limit here anteriorly. Then I'll be going all around on the capsule and enucleating the lobe. Little bit I have modified this technique wherein I extend the veru incision laterally, wherein I develop sort of wings. So I develop a wing posteriorly, I develop a wing anteriorly, I connect them at the level of veru or at the level of sphincter, and then I enucleate all around. So with your permission, I will start with the procedure, sir.
Yeah, Dr. Tanuj, this looks like to be a very small gland, grade 1 probably.
Yes, sir.
Do you find any difficulty in finding planes with very small glands? Because they are usually having, chronic prostatitis if they are severely obstructed.
Yes, sir. The small glands are more tricky. The capsule is not very well defined at places. They are more sticky, I would say, and there will be small adenomas, which are little difficult to enucleate or dissect from the capsule. So I'm using a camera from Univ Labs today, sir. It is a CMOS camera. The vision is pretty good. Little bit problem what we have with CMOS cameras with laser is this lines that you can see when we are using the laser. But still we are able to do it most of the time. With the earlier 3-chip HD cameras, we were not having this problem. I mean, with the CCD technology. So gradually, this is the best place to find the capsule. These are the fibers standing up, and they are the ones we are supposed to divide. We go on dividing these fibers, and very soon we see the capsule. So whatever is this shiny, glistening white is the capsule, and whatever is the fluffy, cotton wool-like is the adenoma. So that is the differentiating part. And same thing, we go on extending towards the bladder neck as much as we can. And then I make those wings which I mentioned on either side. I dissect between the sphincter and the adenoma. Same thing on the other side. And we create these wings.
Tanuj, you said that you can customize the setting. Do you use some specific?
Sir, I can't. Sorry, I'm not able to hear properly. Can you?
Dr. Tanuj?
Yes, sir.
You said that you can customize the setting of this laser.
Yes,
Do
sir.
you use any specific width, pulse width?
Any specific, sir?
Width, pulse width. You can modify the width.
Yes.
also, I
So
think,
in
of the-
this, you can modify it to long width, short width, and there's something called LRE. So for enucleation, we prefer the short pulse width, sir. And for hemostasis, we prefer the long pulse width. So you can change that. And also in lithotripsy, it's very helpful, especially when you are doing a upper ureteric stone and you just change the pulse width to LRE, which is a low retropulsion mode, then the stone hardly moves when you are fragmenting. So one of our wings is created, sir. This is the Veru. I have dissected till this point. Now I come back to Veru. I turn the scope 180 degrees. And just little proximal to Veru, I mark my distal limit. This is the place where the bulk of the sphincter is. That's why we have to preserve some hair, and we go deep till the capsule. We go deep till the capsule. I hope you can appreciate the capsule here, sir. And when I'm doing on block, I try to go as much till the bladder neck as I can. Sometimes we are able to reach the bladder neck and enter the bladder also. I will see if I can do that, but I have to make sure I don't cause too much stress on my adenoma. So as I'm walking towards the bladder neck, you can see this is the mucosa and some pink fibers of bladder neck. We go close to that. These are the fibers of the bladder neck. And there, mucosa, and we have opened the bladder neck here anteriorly. So now we have a channel for the fluid to come in. We have a channel for the fluid to go out. Can you see here, sir? This is our prostatic urethra. This is the anterior channel which I have created for my en bloc. Now I will create some lateral wings here at the level of verumontanum. Little bit. So en bloc is all about reaching the correct plane and then going in the right plane all around. So wherever we get the plane, we enucleate immediately. So now I will do what is called as apical release. This is the sphincter, sir. Can you make out? And this is the adenoma. So we have to release the adenoma from the sphincter all around. Partially, I have already done it. And now I will complete this incision. Can you make out, sir?
Yes, yes.
I hope I am connected to the body.
Yes, you are, and you are showing a very nice planes.
Yes, sir. Thank you,
Perfect
sir.
hemostasis.
Now on the other side, same thing.
Dr. Tanuj will move to the next OT. You carry on with this. We'll
Sir,
join you back.
Sorry, sir, I can't hear somehow.
We'll shift to the other OT. They are ready with the resume there.
Sure, sir.
So we'll
Sure, sir.
join you in shortly.
Sure, sir. Sure, sir. Thank you, sir.
So can we connect to OTA now, Dr. Dharminder? Dr. Dharminder, we are connected with you.
Sir, good afternoon, sir.
Good afternoon. Can
Uh,
you tell us about the case?
Can someone update about the case, please? Okay, so we have this 86-year-old gentleman who is in acute urinary retention. He was on catheter for last 2 months, and his prostate size is 48 cc. Before retention, his Qmax in uroflowmetry was 5 ml per second, and now we have planned for doing this RESM procedure for him. So he, as I was told, he was not very much willing for a resective procedure. So we opted for the RESM. And he was taking Ecosprin, which was stopped yesterday, and he's not on any other anticoagulants. So before we start the procedure, I would like to show you the machine. So this is the RESM setup here, and we have assembled everything about the RESM here. And before we start the procedure, we usually do a priming and we do a pre-treatment cycle of the RESM. In the pre-treatment cycle, we open up we press the button and we employ the needle out of the RESM machine. And once we do that, we start doing the pre-treatment cycle with the water vapor. And as you can see with the machine, there's some irrigation continuously going on and the steam is being injected out from this needle. Once that is done, we retract the needle back, and that's the part of the RESM cycle. So this is the setup which comes with the RESM setup, and it has about 15 cycles, 15 injections per machine, per setup, and it can be attached to any 30-degree cystoscope, 30-degree scope, and before we start the procedure, I would like to do a normal cystoscopy for this patient. So I have assembled a 20 French sheath with a bridge and 30-degree scope. And we are going to show you on the screen the normal cystoscopy of this patient.
Shift to the endo view.
So this is the endo view.
We are not seeing the endo view. Yeah.
Can we please show the endo view, please? Charlie? So are you able to see now?
Yes, we are.
So I've reached to the prostatic urethra. We can see the verumentinum and bilateral lateral lobes are enlarged. I'm slowly going up. And this is a slightly high bladder neck, but not actually a proper median lobe. There is some turgid urine because of the catheterization, I assume. We have already given prophylactic antibiotics for this gentleman, and the culture has been negative. So since I have seen this length of the prostatic urethra, I can assume, I can assess the full length of prostatic urethra is almost 4 field of the cystoscope, which is equivalent to almost 2 centimeter. And by seeing this length and by seeing the bulk of the prostate tissue on both sides, I think I would be planning 1 injection on each side of the lobe. So I will come out with the cystoscope now.
This planning of the number of injection is on the length of the prostate or the volume?
So this is actually based on the length of the prostatic urethra, because we prefer to start our injections from the bladder neck. We at least leave 1 centimeter distance from the bladder neck, and then we give our first injection on one side of the lateral lobe. And the theory is that we should give 1 injection for every 1 centimeter of the prostatic urethra length. So that is for the one side. So if the length is about 2 centimeter or 1.5 to 2 centimeter, I would prefer to give only 1 injection on one side. Same on the opposite side. Sometimes we may give extra injection for the median lobe, but I don't think this patient will require that. So now, as we can see, this is the final setup. I've taken the camera out from the cystoscope and I've put that camera into this RESM setup. We can see there is a button for the water vapor, which is this blue colored button. There is a white button for deployment of needle, and then there is a button, safety button, for retracting the needle back. So we will start with the Endoview again, please.
You said this patient was in retention.
Yeah.
Do you feel there is any difficulty in dealing a patient who is under retention, there's prostatic inflammation, than a normal person? Is there any difference?
Sorry, sir, I didn't get the question. So you can see that there is some redness, some bleeding from the prostatic urethra. And I'm trying to do the turbo flush in the urethra to clear the view. Flow is going.
There may be some oozing from the bladder as well because he was on retention.
Yes. So in that case, when there is a poor vision, what we try to do is we give some turbo flush in the urethra. There is a button which इसको बंद कर. So we can see there is some ooze from the bladder neck part actually. Which is getting a bit clear now. So how do we assess the injection site and how do we assess the number of treatment is we start from the bladder neck area. And from the bladder neck area, we go at least so one cystoscopic field is about 5 mm, half centimeter. So we leave at least 2 cystoscopic field before we plan our injection. So this is the one. And this is the second. And at the same time, I try to see whether I have not crossed the verumentinum in this case. So we are very much on proximal to the verumentinum here. Once we have decided the site of injection, we deploy the needle. And this is, we can also see that this is on the bulk of the prostate tissue. So the needle is inserted, deployed, and we start the water vapor treatment now.
Do you select the depth or it is pre-selected?
Nah, so the depth is pre-selected actually.
Start with modulation. Start with modulation.
And the water vapor is done. So we retract the needle now.
Yeah, if possible.
And I will again travel another 1 centimeter before I inject another needle on another treatment on the right side of this lobe.
Hello. So
Yes, sir.
Tanuj wants to take the screen for a few minutes. Please, chairpersons, please help him.
Yeah.
Hello.
Yeah, we are with you, Dr. Tanuj.
Sir, I'm done with the enucleation.
Yeah.
Yes, sir. You
So
can see
very-
the capsule all around.
Yes.
I had gone deep in these few places, but generally still I've not gone very deep. So even if there is a perforation with the whole it's not very deep. In this area, you need to be very careful. If you go on going deeper, then you can do undermining of the bladder neck, which can lead to bladder neck stenosis. So that should be avoided. We should know immediately when we have gone a little deeper. So we come back and we become little superficial. After that, in every small prostate, what I do is I give additional bladder neck incisions. Just like a TORP for small prostate, this relaxes the bladder neck. It has been proven. There are papers on it that the incidence of bladder neck stenosis decreases. Now this is the verumontanum, this is the sphincter on both sides, and we are done with the enucleation, sir. I hope you are happy with the result. And this is the adenoma that we have enucleated en bloc as one piece. And we'll be morcellating it using the Jena morcellator. It is an inbuilt morcellator within this machine. So another advantage of this machine is that we don't have to buy a separate morcellator. That saves cost. So I'll be going ahead with morcellation, sir. Sorry to disturb you in between. Resume. I think you can finish the procedure there.
Thank you, Dr. Anuj, for
Thank
a
you,
very
sir.
nice job and very clean enucleation.
Thank you, sir.
Applauds from the house, from our side. So we shift to OTA back to Dr. Dharminder. We are with you now.
Are we back?
Yeah, you are back, sir.
So,
So
sir,
you
we
can
have
do it.
given the injection on the right side, and now I'm going to assess on the left side. Again, I will go back on the bladder neck, and on the bladder neck, I will leave two cystoscopic field that is equivalent to 1 centimeter. So this is 1, this is 2, and then I will come back here and I will target my needle over here, and then I will deploy the needle. After deploying the needle, I'm going to inject the water vapor, and you can see there's some blanching happening into the prostatic bulk, which started when I started doing the water vapor treatment. Vapor is injected, and then
How are you aware if the injection is complete?
so so we have the machine, and we'll show the setup, which will show that there is a timer on the machine, and it goes for about 8 to 9 seconds. And as soon as that on the screen shows us that the injection is complete, we finish, we retract our needle back.
How deep needle goes?
Sorry, sir?
The depth of needle, how deep it goes?
So it's less than 1 centimeter, but there's no way we decide the depth of the needle in this case. It is pre set at a specific setting.
So do you have to introduce the setting of the patient, the volume of the gland, the length in the machine so that it selects it?
No, there's no option to select the length, the depth of the needle. However, we select the number of injections and the length of the prostatic urethra.
So the injection is usually given at 3 and 9 o'clock as you have given?
So I am doing it on 3 and 9 o'clock, sir, and that is what is being taught for these kind of cases. For the median lobe, we prefer that we don't give it vertical down. We don't give it perpendicular to the rectum. We give it about an angle of 45 degree to avoid any injury to the rectum directly. So that is the teaching. For the median lobe, definitely we go 45 degree, but otherwise for the lateral lobes, I go at 3 and 9 o'clock. Otherwise, if I see a very big bulk of the tissue, very big mass of the adenoma, then I may give an additional injection over in that tissue, in that bulk. We can see on the right side, there is some blanching of the tissue where the needle was injected.
Yes, we can see that.
So there is some ooze from the bladder neck area, but I have given 3 injections for this patient, and I am assuming that is enough for this gentleman. You can see some blanching on the left side also. And now I'm going to put the catheter in.
So how long would the catheter stay, sir?
So, sir, however, the team claims that for the small prostate like 48 or 50 cc, the catheter can be removed after 3 or 4 days. But in my personal feeling, I don't remove the catheter before 10 days. So that is what I am trying to follow for now. But maybe in future with a more number of experience, more number of cases, we may reduce the catheter time. But at the moment, whether the patient was in retention or not, I am keeping it for at least 10 days.
And do you add alpha blockers also along with that?
Sir, always. So I always give an alpha blocker after continue the alpha blocker at least for a month. So the patient continues alpha blocker while on the catheter, and they continue it at least for 20-25 days after the catheter is removed.
Dr. Dharmender, have you done cystoscopy after the procedure after 10 or few days? And if you have done, so what do you find in that?
I'm really sorry for that, sir, because I haven't done cystoscopy after the procedures myself. But the studies, they do say that there is a decrease in the prostate size, there is increase in the IPSS and uroflow. But maybe something to see after a few months of using this procedure. If a cystoscopy is to be done, I think we should at least wait for 3 months before doing that check cystoscopy, because they claim that the maximum benefit, the maximum symptom benefit comes at 3 months of time after this procedure.
Dr. Dharmender, Sunil Mittal here.
Yes, sir.
So what exactly would be the cost for the patient?
So, so the setup is this device which has about 15 treatment per setup. It's cost around two. It counts around 2 lakhs, sir. But what we are doing is we are trying to bank up the patients. We try to put 3 or 4 cases all together so that all 15 treatment cycles can be used in 2-3 patients. So not one patient takes the bear of for a whole of the cost. So I think the cost to the patient comes somewhere around 1 lakhs or something between 1 to 1.5 lakhs.
And have we got any time the ultrasound of these patients done after 3 months to see the size of the prostate?
Sir, my personal exposure to the RESM has been less than 3 months. I will be honest in that. But yes, there has been trials. A center where I was working back in London, we used to do ultrasound. We used to do uroflowmetry also, and we used to do the proper IPSS scoring also. And most of the patients, they did saw a decrease in the size of the prostate as well as improvement in the IPSS.
So in your view, what is the final indication of using a resume? Whether it is patient on medical management or who are a candidate for surgery?
So, sir, RESM is definitely something for which my consultant, my teacher used to taught me that you has to be very selective in your patient selection. It is not a replacement of resection, as I understand till now. Of course, people claim that it is a replacement of resection, but I still feel it in between for those patients who are either not medically fit to undergo an anesthesia procedure, because this procedure can be done completely under local anesthesia. Patient hardly feels any pain. Most of the times they feel some vibration in the prostatic area, nothing except that. And young patients who are very much keen to preserve their ejaculation, that is something to be thought for these patients who don't want to take medical therapy for very long, who are quite young or who are quite old and who don't want to, and they don't feel they are fit enough to go for a anesthesia procedure. So right now I'm banking on those patients. But yes, according to the new studies which are coming in, even the larger size of prostates are being treated with the RESM, and people are starting to claim that it is going to show us an equal opportunity, equal option as compared to the resection.
Sir, this is a disposable equipment they are using. They are doing 3 or 4 cases simultaneously. How do they sterilize it?
Yes.
So what we are doing is we are doing it. We are washing it. We are putting it into the autoclave, and then we are taking it out. So that is what we are using. But yes, according to the advice, it is a one-time use instrument. It is but honestly, if that is what I'm going to use, it is going to bring a huge burden of cost onto the patient.
You can autoclave it.
We can autoclave. We are doing ETO also, sir.
Dr. Dharmender, one just last question from my side. Because most of the procedures, endoscopy procedures.
Yes, sir.
Dr. Tanuj wants to show the end of the procedure before we finish off with his theater. So can the chairpersons please engage him?
Yeah, we can shift to Dr. Tanuj.
Sir, I'm done with the oscillation as well. You can see the fossa all around. And this particular machine has 2 pedals. With left pedal, we can suck, and with the right pedal does suction as well as oscillation. We go inside, we can see the orifice area. Both the orifices are fine. And I will just show you the advantage of just pressing suction. And this is what we use for large bladder clots as well. You just press suction, the left pedal. Ready kijiye, ready kijiye. and it will suck away all these clots. So they will not block your catheter, although again some clots will be found, but mainly it is advantageous in very large clots, which we are not able to take out with Toomey syringe and everything. But definitely this oscillator is good, it is fast, and it is safe. So this is our fossa. This is at the level of Veru, and that's the nice wide bladder neck and the bladder wall. So, and if any questions, I would be happy to answer, sir.
You mono block resection.
Yes, sir.
You reserve it for certain patients. Yeah, you do it routinely.
Sir, I personally do it routinely, but one should start doing on block only after a certain level of experience. I would say at least 100 HOLEPs you have to do before you jump onto on block, because you should know a way to come back to the normal urethra. So that is why making the incisions and coming back to prosthetic urethra helps, so that you can go back into the bladder. Because in HOLEP, you get lost many times, even in a 3-lobe technique. And in on-block, if you get lost and you're not able to find the right plane, you might either go very deep or very superficial, which will lead to more bleeding, lesser vision, poorer vision, and one can end up creating a mess. So on-block is to be attempted only after a certain level of expertise. I personally prefer on-block for most of my cases. Even in the cases where I've given incisions before, I end up going deeper doing a on-block because I stay right on the capsule and I go on separating the adenoma all around from the capsule, just like how we used to do with the open
What
flares
advantage
prostatectomy.
you get over the other procedure?
Sir, on-block is much faster. As we have seen in this case, I think my total enucleation time was hardly 15 minutes. So on-block is faster. Even 2-lobe technique is faster than a traditional 3-lobe technique, and on-block is definitely faster. Enucleation is also faster, and moscillation is also faster, because you don't have to chase those 3 different lobes. You just catch the adenoma once and you moscillate, and within, if it's not very big, then within minutes it is over. One of the concerns that has always been with the HOLEP is the inside urethra time, because that is what leads to stricture. So as we do more and more HOLEPs, we adopt to these faster techniques, wherein we go on decreasing the enucleation time. Even in a very large prostate, I have found the machine that I have now, I operated 140 watts. So even 350 cc prostate, we could finish within about 2 hours. So definitely the technology is there to advantage, and we have to develop our skill. We have to do more and more cases so that we can decrease the time inside the urethra, and so that strictures are not formed.
Dr.
So when you use 140 watt, what frequency you use?
Sir, I use 3.5 joules and 40 hertz. It's not to be used with all machines, only if the machine allows you. So the machine I have has a special EPS mode, which is enhanced performance setting. So that allows me to use that mode, and the enucleation is very fast, very fast with that. Actually, the mechanism of enucleation is creation of a bubble, and when the bubble bursts, the plane separates. So with a 140 watt, the bubble is much larger. So when the larger bubble bursts, the area separated is more. That is why it is faster with that setting.
Thank you, Tanuj.
Sir,
Dr. Tanuj.
Thank
So
you,
we
sir.
can move to Dr.
Excuse me, sir.
Dharminder for the final comments.
Sure.
Sir, can I just have a question? Can I get to Dr. Tanuj if possible?
I am connected, sir.
Yeah, Dr. Tanuj, Rohit here.
Hi, Dr. Rohit.
Suppose in such small prostates, because we are very likely that we can sometimes perforate, as happened in this case.
Yes.
So do you take any special precaution post-operatively, like a long-term catheterization or some higher antibiotics or whatsoever? Do you think anything will help that?
Antibiotics I don't change, but antibiotics I change only if I see pus pockets. If there is a small perforation, generally in HOLEP it's not of any consequence, and the only difference is if it's a large perforation, or if I have had some undermining, I'll keep the catheter for a little longer time, maybe 5 days. Generally, otherwise we can take out even in 1 to 3 days.
Okay.
One more thing, if there's a perforation, sometimes you can open the sinuses. So that is something you have to be careful about, because you will come to know just before moscillation that there is a lot of bleeding. And there is no shame in using a ball electrode and coagulating it before going for moscillation, because otherwise it becomes difficult to moscillate with a poorer vision. Sir,
we
you can
shift to OTA.
see the return of the urine. It is absolutely clear. So generally in my practice, I don't use any irrigation. Only when required, I still use a three-way catheter so that if irrigation is required, it can be used and no traction is required.
Can we switch to OTA?
Hello. Hello. Hello.
Yeah.
Yeah, you audible?
Yeah, this is OTB. The next case is HOLAB and it will be performed by Dr. Pankaj Maheshwari, sir. Dr. Pankaj Maheshwari, he's a consultant urologist at Fortis Hospital, Mulund, and he is also honorary treasurer of USI. The patient, he's a 67-year-old gentleman, and he has predominantly obstructive low urinary tract symptoms, no comorbidities, and he has 60-gram prostate with 10-gram median lobe. Over to Dr. Pankaj. Sir, आपका audio.
Dr. Pankaj?
Dr. Pankaj, can you hear us?
Welcome, Dr. Pankaj.
ऑडियो आ गया अंदर ऑडियो आ गया सर ऑडियो आ गया कर रहे हैं
Good morning.
So you can hear us?
Yes, I can hear you very clearly. So I have just done the preliminary cystoscopy. There was a submeatal stenosis which we have done Otis for. Then the generalized urethra was narrow, so I have dilated it to around 24 French. If we look at the cystoscopy, there are obstructing lateral lobes, and the lateral lobes are projecting inside the bladder in form of a IPP. Now, on cystoscopy, the decision I need to take is what form of enucleation I would be doing. Now, seeing this orientation of the adenoma, I would be doing a two-lobe technique. So there is a proper preform groove here, which will help me take a midline incision. And then I could have one roof incision and join the two lobes on each side. Now, my technique has been more based on what Professor Peter Gilling has described, which was a standard three-lobe technique. In Professor Peter Gilling's technique, what he would do is one incision at 5 o'clock, one incision at 7 o'clock, join the two incisions in front of verumontanum, then start undermining this median lobe and get one lobe at a time. What different we have found is that when you are taking a bladder neck incision and coming towards the verumontanum, many a times you will lose sight of the verumontanum and there is a theoretical possibility that you would overshoot. Instead, what we have started doing is we take the first incision just by the side of verumontanum. So that's the verumontanum, that's the lateral lobe. If you stretch here, you will see a glistening white mucosa here, which you should cut first. On both sides, we will take this incision here. Either you see a glistening white mucosa or you see small punctate openings there, which you just join those dots. The plus point would be you would identify the capsule immediately. And then once you identify the capsule, the rest of the procedure is trying to remain on the capsule. Now, one more important thing that we need to understand is that with laser energy, try not to touch the tissue. The only place where I would touch the laser to the tissue is when I'm working at the bladder neck. Rest of the places, my attempt would be to be slightly defocused. So now let's start. So I take the first incision just by the side of verumontanum. Now try and deepen that. You will find the adenoma very easily here. We can already see the contour of the adenoma there. That's the contour of the adenoma going on this side. Now, once you have taken this incision, remember, this is just a mucosal incision. So we are not going to cause any harm. Now, you see here, the adenoma is going on.
Dr. Pankaj?
Yes.
Just give us 2 minutes. We have a change of guard here
Sure,
in the hall.
sure.
Thank you, chairpersons. May I invite the next set of chairpersons for taking us through the next
Irrigation,
session.
ख्याल
Dr.
रखिए.
Sharad Agarwal, Dr. Tanmay Goval, Dr. Ajay Sharma, sir, and Dr. Sudhir Devana, you can please join. So we have aqua ablation also ready. This was supposed to be live, but because of some ethical issues because of the UK laws, this is going to be now a semi-live session from UK. Dr. Nikhil Vasudev has joined us already. He's on the right side of the screen. On the left side, we are continuing with the whole lab by Dr. Pankaj.
So before you join for aquablation, I would just want to show you here that it is very easily possible to see the prosthetic edges. You can see the adenoma very clearly. We can see the capsule below, the adenoma above. Now all I need to do is keep on elevating the adenoma by the resectoscope beak and keep on disconnecting the connections between the adenoma and the capsule. Go slow when you are near the verumontanum. This is the site where the advantages are: one, I want to identify the capsule; two, I want to get the apical dissection done first. And once I take similar incisions on both the sides and join these incisions, then whatever bladder neck incision I take, those incisions would not overshoot. So the risk of the procedure, the risk of incontinence dramatically reduces. Do you want to continue with the aquablation or should I keep on talking?
Hello.
Haji.
Sir, we would like to go to the other OT for some time and start with the aquablation.
Sure.
May I request Dr. Vasudev to please start with his presentation?
Hi, can you hear me? I hope you can hear me.
Hello. Hello.
Hi, can you hear me?
Yes, sir, we can hear you.
Perfect. I'm just going to share my slides. Just give me 1 second. I think there were some issues with the Zoom this morning. So I hope you can see my slides now.
Yes, sir, we can see.
All right. So thank you very much for the organizing committee at the North Zone ECI and Dr. Nair and the team for inviting me to speak on aqua ablation. So this is a relatively new technique in the UK, and I am just coming up to the north of 45 cases. And next week I have 7 cases booked. So I'll cross the 50 mark. So I just want to showcase to you over the next 20, 30 minutes on aqua ablation, what it is, what it does, and some of my initial experience associated with the technology. So I've been sort of involved with the development of the product to a degree, but certainly I've led the implementation of aqua ablation in North Hertfordshire, where I work, which is just north of London, which has a catchment population of about 7 million patients. Now, aqua ablation, as the name suggests, has been developed by a company called Procep Biorobotics. This is an American-based firm. And this technique is not so new. It's been around for many years now in the US, especially in California and that coast in the United States. But the advent of aqua ablation started in 2017, and now since 2020 onwards, there's been a huge jump in the number of centers which are doing aqua ablation. I'm going to showcase some breakthrough data to you with my presentation because we have crossed about 50,000 procedures worldwide, but the majority of these are from the United States, and in Europe and Japan, the growth is substantial. So the company's push right now is Europe, Japan, and China, and hopefully I'll bring this to India in the next few months. So the data that we have so far, which is available, which is quite promising, is because it's a new technique. The advantages of aqua ablation have led for it to be fast-tracked fairly quickly through the NICE approval process in the UK, based on certain run-through randomized control trial studies, where largely comparing aqua ablation with TURP, with the water studies, which again I'll be presenting at the SIU in Delhi. But I just want to showcase to you as to what it is, and because of ethics, I was not able to transmit live to a non-EU meeting. But I've recorded a case that I did on Tuesday last week on a 244 cc gland and what my experience was. So essentially, I don't need to tell you about BPH. This is a fantastic meeting. I've just seen the whole lab being demonstrated. And obviously you have a high skill set of surgeons in India. But there's a huge market for BPH worldwide. And I think a lot of technologies are available to patients. And as we speak, I'm sure there are more technologies being developed for benign prostatic treatment. The real advantage of aquablation is that the size really doesn't matter. The technology is such that you can ablate prostates ranging from 30 cc to 40 cc to 80 cc to 150 cc. But obviously the data that we have on the randomized controlled trials is predominantly between the first three cohorts of BPH tissue that is available. But certainly now we have larger prostates coming out. The main issue is that you cannot do this technique on patients who are anticoagulated. So you cannot do it on patients who are on warfarin, apixaban, edoxaban, and a large amount of patients in the elderly group, especially in the UK, who have ischemic heart disease, atrial fibrillation, will be on these drugs. So being on anticoagulation is a contraindication for aquablation therapy. And I'll show you why. Now, obviously, when we do BPH treatment, the main prerogative is to relieve the patient's symptoms. And I'll show you data on my first 45 patients with the IPS scores. But also sexual function and continence preservation is the key, because you don't want to do a big operation and patients end up having a lot of ejaculatory erectile dysfunction and incontinence per se. So this is what we tend to see. We have patients who come to our clinic. I'm a robotic cancer surgeon. I do prostate, bladder, kidney cancer, but certainly in my private work and also now in the NHS, I do aquablation. So the therapy overview is such that this uses the power of a water jet. So it doesn't use heat when you cut tissue. So this is a 40,000 FPS water jet, and the penetrability of the aquablation jet, and you can adjust this as you operate with the planning, is about 24.3 millimeters in depth. But I normally sort of stick around the 18 to 20 millimeter mark, and you can really control this. And I'll show you how we tend to control this during the operation. So the main impact of aquablation is threefold. Because you don't use heat during the ablation part of the program, it really causes disruption of collagen and destructive soft tissue. And it also leads to a large degree in the zones that you've not ablated with your 40,000 FPS water jet to allow preservation of the collagen in that particular area. So this is what it looks like in theater. And I'll show you a video shortly, which I've recorded on what the setup is. This is the aquablation machine. So you have a screen, you have a keyboard, and this is the water pump, which is all associated, and the suction device. So it's very slick. It doesn't require a lot of space to store. So normally at the end of 3 robotic prostates, I'll end up doing 2 aquablations at the end of my list. So, it's fairly easy to move in and out of theater. But the 4 main components which are important with aquablation is that it's real-time image guidance. It allows you to develop something called a personalized treatment plan. The youngest patient that I've done is 40, who really wanted their symptoms improving, but their ejaculatory function preserved and the erectile function preserved. And I'm going to show you how the robotic-assisted water jet resection works, obviously backed by long-term data. So let's look at the real-time image guidance. So this is a truss that is put and inserted inside the patient during the operation. So what you tend to see is that you can really map out the bladder, the median lobe, the lateral lobe, the veru, and the external sphincter during operation. So this is the sort of image you tend to get live during surgery. So the image is completely live, and I'll show you a video that I recorded on Tuesday on a 244 cc gland that I ablated. The real next expertise is personalized treatment plan. Obviously, this is applicable, in my opinion, to any benign treatment that you do. On the Starworth faculty of this meeting, you can really talk about personalized treatment plan with any type of benign treatment. So this is unique, but yes, you can probably stratify this because you can really protect key components during your aquablation, such as the bladder neck, the veru, and the external sphincter, and you can resect what's required. So you may not over-resect. You can really sort of confine your resection to the obstructive part of the prostate, which is the median and the lateral lobes. And this is all computer-assisted planning and AI, which is used intraoperatively to allow you to spare the bladder neck, the veru montanum, and external sphincter. And I'll show you how, when you have planned your treatment, what you think is correct, the AI, which is the computer-assisted planning, will help you maximize your resection safely based on the software that is present. Now, the water jet resection, so this is fairly unique. As you can see, what happens down here, so this is just an animated video, is the water jet will cut the prostate. So these are the sort of cavities. This is one of my cases on 150cc gland. You can see you can get a very, very patent big cavity. And there's no resection of chips. So there's no moscillation on ELIC required. You know, you basically, whatever you resect is sucked out from the aquablation machine itself. So you don't end up with a situation of resecting a very large prostate and then end up spending a lot of time to moscillate or excise the chips. This is all just collagenase tissue, which is sucked out. And at the end of the procedure, I'll show you what we tend to do is focal bladder neck cautery at the bladder neck. And I'll show you a video of that. Now, this is just a video which I'm about to play, and there's some audio associated with it. Good morning. This is my 45th aquablation that I'll be doing. We're just sort of in the process of getting set up in my theater. So this is the aquablation essential apparatus with the ultrasound machine and the kit. And so it's important that there is an ultrasound, which is a part of aquablation. And you obviously require a cystoscopy stack to be present in theater for the cystoscopic part of the resection. The patient that we'll be doing today has come to me about 100 miles from where we live and work in Hitchin in Hertfordshire. And this gentleman who has got a catheter in situ, he's had multiple unsuccessful talks. He's not anticoagulated. He's 71 years old, and he's got a indwelling catheter, which he's had for about a year now. And his prostate volume on evaluation is 244 cc. So you can see it's quite a big median lobe and a large gland. So I'll record and send this across. So Kim is my scrub nurse for the case. She's just setting up a normal cystoscope with a resectoscope, because at the end of the procedure, we'll be doing some focal bladder neck cautery. You've got a choice of using monopolar or bipolar. I use both, whichever is available. So during the aquablation process, you need to have a normal cystoscope. You need to ensure that you have a resectoscope, and I prefer using monopolar cautery per se. So this is the aquablation machine, and I'll just let the video keep playing. So this is exactly what it looks like. There's a subcord and send this across with the resectoscope, because at the end of the procedure, we'll be doing some focal bladder neck cautery. You've got a choice of using monopolar or bipolar. I use both, whichever is available. So once the patient is anesthetized, this is what the aquablation kit looks like. So you can see down here, you have the handpiece, which is introduced, which is essentially the handpiece which goes through the urethra. This is a 26 French handpiece. So sometimes you do need to calibrate the urethra, and it's got all the suction components within it, which includes your suction from the aquablation handpiece and also another irrigation channel. Once this is set up, so the nurses, I do about 3 to 4 on a morning list when I do an aquablation list per se, which is once a week on a Tuesday morning. And the other part is that we have a lot of support from the company. So we tend to have a few patients, a few people who come in to support us. There's a camera. This is a scope on the aquablation machine, which is put through. So this is a part of the visualization. But this is the handpiece which my nurse Kim is just connecting up. So you can see that he's put the scope through the aquablation handpiece, so you don't need to have an extra scope. Now, there's certain finicky bits, so I'm very particular with setting up. So this includes, setting up the handpiece per se, because these are very important parts. So the handpiece is connected. So this is what will be going inside the patient at the beginning of the procedure to map out the Veru. And once you do have the handpiece which is placed inside the patient, everything has to be connected up properly. So this is the suction apparatus which is being set up. We only use saline for the initial part, but obviously when we do the monopolar bladder neck cautery diathermy, we will place glycine on for about literally 15-20 minutes to the very maximum. So all this is the connection which is being connected. And what's quite nice is the company has a completely transparent drape. So what I'm doing now is I have to prime the machine before I start operating to basically clear all the channels from any water. And you can see where my foot control is. I'm just basically priming the scope before I go in and clear the water out. So this is the step. So this is my 45th patient that I'm just sort of about to demonstrate to you. So this is live. This is not sped up video. I did this particular patient who had a 244 cc prostate in 29 minutes was the entire procedure length of the procedure. So ergonomically, compared to my whole lab colleague surgeons, we have 4 whole lab surgeons in my unit. Even there, some of them are converting, or we are doing a combination of aquablation, and some patients having whole lips, of course. And there's a trial as we speak, which is comparing the two. So what's going on right now is I'm introducing the handpiece inside the prostate. And they're key components of the anatomy that you can see down here. So you can see it's quite a big prostate. And the handpiece is fixed using an external holder. So once you place the handpiece inside, you just fix it. These are some calibrations that we tend to do. So this is the system that will take you through it. So if you look on the left, the system will basically take you through some setup processes. So it needs to ensure that you have the patient in the right position. The truss ultrasound scan is absolutely in the midline. There is no evidence of any twisting of the truss. And also, this is the handpiece on the outside. Once this is all done and we've calibrated and placed the scope inside, you press the next button up here. So like I said, this is all live recording from the procedure. You place the component inside. And then once it really sort of reinforces that all these steps have been done, and the system with the AI is checking that you're continuously doing the correct setup per se. Once the scope is fixed, then we check for some water jets to make sure that the water jets are aligned. So you can see this patient has quite a large prostate. And then we come to the mapping of where I need to resect. So the scope is fixed now. You're not going to touch the scope. This is the planning component. And this is the mapping out that you can do. So you can see the maximum depth of the aquablation machine is 24.3 millimeters. Although we do 2 passes as a matter of standard, in this particular individual patient, I did 4 passes. So I did the front part of the prostate because it's quite a big, broad gland. And in 2 weeks from now, I'm doing a 350 cc gland. I may have to do 6 passes in that patient. So you can really map out what you need to do. Now, once this is set up, your truss is set up, then you have to identify the nozzle of where the water jet is coming from. The nozzle is where the ablation will take place from. So you have to be very particular to guide the computer system on this. So what I will do is I will hit the foot pedal, and you can see that's the water jet which is getting activated. I will place my first marker on the nozzle per se, and then drag the marker using the keyboard, which is present as a part of the aquablation machine, onto the trace probe. So this is I'm withdrawing the trace probe. You can see it down there. So that is the length. So it's a 70 millimeter length that I can ablate at one time. Now this is the next part, which is planning the treatment. So the treatment plan, as you can see, you need to identify key components with this. I'm just sort of reconfirming where to ablate from because the prostate is quite large. Normally, in prostates which are less than 150 cc, this process takes about 3 to 4 minutes, but there's a bit of a learning curve. Only after 20 cases did I gain a lot of confidence with this. And you can see I'm just sort of mapping out where I want the treatment to start, the bladder neck, or where I think the bladder neck is, the middle of the prostate, and certainly whether I want the treatment to end, because your handpiece and your scope is fixed at the level of the verumontanum. Now, what the aquablation machine is telling me is that this number 4, I can probably go a little bit deeper. I need to adjust this, and it's giving me a time. So in a prostate, which is a 240 cc gland, it is telling me that only 5 minutes, 51 seconds will be required to ablate the prostate accurately with the first pass. So this is 1 pass. A lot of the data in the first studies which came out was 1 pass, but as more data is maturing, you want to do 2 passes. And it goes on reinforcing that now you shouldn't move your truss or your handpiece. You basically are independent. You are only using your keyboard plus your foot pedal to adjust things if required. Then I'm happy. I give my anesthetist the go ahead. All my patients are under general anesthesia. I haven't done any under spinal anesthesia yet, but in Germany, my colleagues do a lot of this. And the foot pedal is where I start. So you can see you have something called the pump level. The pump level is the intensity of the aquablation jet, and you are completely controlling this with your foot pedal and your handpiece, so you can adjust. So the green line is where the aquablation is going, but you can see over here it's turned yellow because I have laid off on my pump level. I feel that the water jet is hitting the prostate too hard to reduce the risk of a problem of a perforation, which really doesn't happen. I've had one perforation in 45 patients at the bladder neck. You can actually component. So the first pass that I tend to do in all my patients having an aquablation will be a more gentle pass, probably at a lower energy. And you can see how the tissue starts interacting very quickly, per se, as time goes on. So I've had an alert come up about the aspiration chamber, which the nurses have fixed. And you can see how the ablation is going. It really ablates already in a completely occlusive prostate. I have got a 40 to 50% cavity established in less than 2 minutes of the aquablation taking place. So this is the first pass. I'll just sort of speed this on a little bit to show you how it ablates. And it does something called a butterfly cut at the apex of the prostate, especially in those patients who want to preserve. And you know, the butterfly cut has been highlighted and discussed in numerous techniques, including HOLEPs, etc. So this is the aquablation as it goes. I'm adjusting my pump level because I want to make sure that my water jet does not go beyond the rems of the line that's been made. You do have a couple of cystic areas in the prostate sometimes, especially in very big prostates. So you can see sometimes the water jet can overshoot a little bit. So I'm again laying off on my pump level per se. So this is the timing of the aquablation, which is ongoing. And I just sort of keep going at the apex. This is sort of the first part. This is the first pass that has finished in the next 2 to 3 seconds. Now I feel that there is still a bit of component of tissue left, so I will do one more pass of the aquablation. They'll do some checks such as the aspiration chamber, the irrigation saline, etc. Everything's fine. And then I will remap where I need to go. So this is my previous map. Sometimes the entire prostate can move a little bit, so you may want to adjust, but this looks pretty solid. Doesn't look like much has moved. And what I'm doing is I'm doing a prime to see really how much tissue is there, the interaction on the ultrasound, which takes place. And then it'll tell me that there's another 5 minutes, 31 of ablation that is required. And I'll sort of hit this again, take it through the entire ablation per se, adjust a few things, map a few things out with my aquablation, and I will start ablating. And you can see now the second pass is much more efficient. So you're cutting a lot more tissue out. You basically are clearing out a lot of the collagen that's been cut. And please just focus on the interaction of the water jet on the top of the prostate here as to how it's cutting the prostate. So you're getting a complete clearance of this occasion, much more efficient than the first. And what I've noticed is that in bigger prostates, more than 150 cc, you tend to get a much better clearance with the second pass. And again, I'm just basically laying off on my pump level at about 70%, not 100%. So I'm cutting at about 15 to 18 millimeters on my 40,000 FPS water jet. And it's really interacting really well with a big prostate. So this is what I will end up doing. At the end, once I finish the aquablation, I will do some focal neck hemostasis. And I want to show you a picture in recovery of how the patient's catheter looks when the patient comes out. So now in patients who have prostates of less than 100 cc, I do them as a day case. So they go home with the catheter in the evening and come back on day 3 to have it removed. So this is what it looks like. It doesn't really bleed that much because there's a lot of controversy whether aquablations bleed a lot. So I just wanted to show you this picture on this big gland that I did. Now, the concept of focal neck cautery is important because you want to control hemostasis, especially on the perforators of the bladder neck. And these are the key points where we control a little bit of hemostasis with a rolly ball. And again, you know, this takes less. So this is data on 30 patients on an audit of mine at 3 months. So I've had to transfuse none of my patients. These are even the larger prostates. I've had no incontinence at 3 months. In those patients who wanted an ejaculatory function, I have preserved it. My IPSS fall at 3 months is 17, and all patients who had a TWOC, who had a catheter in before in my series who were 20 have had a successful 12-allowed catheter so far. So, you know, pretty promising data, and I hadn't had to retreat anyone. And I'll sort of just show you 2 more slides on the long-term data, if I may, please, Rishi. This is the water study, which is 5-year follow-up data on 30 to 80 cc prostates, on 80 to 150 cc prostates in real-world data. And you can see it's superior to a TURP. It's durable. Retreatment rates are much lower. And again, you can honestly preserve a lot of function in these patients. So I'll stop with that. Thank you.
Professor Vasudev?
Morning. Yes, hello.
Yeah, I just had a question. I am Dr. Sudhir.
Hello, Dr. Sudhir.
Basically, one of the when you compare with a conventional techniques like TURP or HOLEP, where the blood supply to the gland, you know, you get bigger vessels when you reach the capsule of the prostate. So we tend to consciously coagulate them so that you have a very less amount of bleeding in the post-operative period. Now, how come when you are doing aquablation, how will it, the technology, the water jet, which is actually ablating the tissue, how is it going to affect on the blood vessels? I mean, does it prevent, coagulate these vessels as well to prevent post-operative hematuria or not?
Yes, it certainly does. It doesn't have a coagulation function per it, but because of the high pressure, the vessels are actually at the microscopic level pretty much ablated per se. The main bleeding that I tend to see, Dr. Sudhi, is actually at the bladder neck. As you rightly said, you know, the main concern is largely down to the perforating vessels that we tend to see with any degree of conventional TURP or HOLEP. So the initial studies which came out said, do the aquablation, put a catheter and go home. But, you know, patients did bleed a fair amount. So we have developed these techniques. And what I tend to do is, like you rightly said, I don't want a capsular perforation because I've had one, and it's very frightening because, you know, you've aquablated, you've got this big perforation and it's bleeding, but it's controllable. So I will probably take about 20 minutes to coagulate at the bladder neck. And sometimes if you have a slightly smaller prostate, you really do not want to perforate those vessels with the aquablation. So I will lay off on the water pump level, and then I'll focal coagulate with a rolly ball. So, you know, it is achievable. I always tell patients afterwards that not to overdo it, you know, not to go for a run or a jog for about 2 to 3 weeks, but patients may pass some of the aqua-ablated tissue from the urethra in lumps for up to 6 weeks afterwards. So this is what we need to see. So although the machine doesn't have a component of coagulation, certainly from the engineering standpoint, the ablation does work as a coagulant to seal these under high pressure.
What about the post-operative management in these patients? How long you are going to keep the catheter? When are you going to remove it?
So my catheters come out on day 2 because I get patients referred from all over the UK and Europe. But in my day case patients, I do them on a Tuesday and they come back on a Friday morning just because I have a clinic on a Friday morning to come out. So all of them have a standard TWOC that you would do. I don't leave it in for longer.
Yeah, Dr. Nikhil.
Morning.
Yeah. Can this procedure be taken over by interventional radiologist?
I doubt it very much. I I think unlike prostate artery embolization, which has been taken over, this is essentially a resection that you have. You see, this is not going to be taken over by IR because certainly from NICE in the UK, this is only to be done by urologists and surgeons because it's very much a surgical procedure per se. Your entire ablation is controlled by you. Your entire resection is controlled by you. So I think the interventional radiologists have enough work of their own. So I think we're fine as far as aquablation is concerned.
And anything you have experienced, anything gone wrong with this procedure?
Yes. So I've had 2 issues. One is the perforation, which I had. And this was in a patient who actually, you know, had a lot of infections, a lot of inflammations, 80 cc prostate. And the muscle relaxant did wear off and the patient coughed a little bit when I was doing the resection. And I was concerned, maybe, you know, I can't blame my anesthetist because I only want to work with 2 anesthetists for this. The second thing that I noticed was that I had a patient who had a 200 cc gland who came in with a bit of bleeding from the urethra. So not quite hematuria, but a constant bleed, which was taking place 6 weeks afterwards. And I took this patient back for a cystoscopy. And I felt that I had put the handpiece under a lot of traction, which had led to a little bit of an abrasion circumferentially in the penile urethra. So I had to coagulate that. So it was a lesson for me per se that, with the handpiece, because your handpiece is fixed and you have the handpiece with the aqua ablation going on. Now what I tend to do is I tend to drop it down. But except for these two complications, I haven't had any so far, touch wood. But, as I have about 55 patients booked on my list over the next 3 months. So I'm sure I'll have some challenges come through as time goes on.
At the end of the procedure, you will not get any tissue for histopathology, right?
Yeah, so you can. So this is a common questions which patients ask because inevitably these patients have got high PSAs, they've got big prostates, and there's a bit of concern associated. So what I tend to do sometimes is that I will take, when I put my resectoscope in, if there's some tissue at the bladder neck, I will take literally 2-3 swipes to send for histology. But per se, if you do a pure aqua ablation, you will not get any tissue. No.
Any questions from audience? Yeah. Okay.
Compared to a TUR or
who will be an ideal candidate or which patient will be an ideal candidate for performing this procedure, according to you?
So I think all comers, as long as the prostate is not more than 400 cc, and patients who are on anticoagulations can't have this done because the risk of bleeding is substantial. So I think all comers per se, and certainly those on anticoagulation is a contraindication. Otherwise, I don't say no to anyone else except for those.
How long does it take for the patient to recover fully post-operative symptoms, dysuria, hematuria, infections?
It takes approximately 2 to 3 weeks. So most of my patients go back to work in 2 weeks, but I certainly don't let them sort of drive for 2 weeks also. The long-term data on the Water 2 study said that the symptoms of passing a bit of debris can last up to 6 weeks, and patients may experience a degree of dysuria for up to 4 weeks afterwards. And this is largely down to the tissue. But as we speak, another generation of the aqua ablation handpiece is being developed, where we're trying to make the components a little bit bigger for more suction or more debris tissue out. So there's a lot of work in motion taking place. But I've had no patients who've sort of come back to me with UTIs at 3 months, etc. So most people settle pretty quickly. And at 3 months, the IPSS drop, as I presented to you from our data, is fairly substantial.
Dr. Nikhil, we are really thankful to you for a very lucid presentation and enlightening us on a relatively new technique. Thank you very much.
Thank you very much. Have a good morning.
Can we shift to Pankaj Maheshwari's OT? Are we connected to Dr. Pankaj Maheshwari's OT? Dr. Pankaj, can you listen us? Dr. Pankaj Maheshwari, please. Are we connected to Dr. Pankaj? Hello, Dr. Pankaj.
Hello.
Yeah, can you listen? Dr. Pankaj, we were going through a presentation online by Dr. Nikhil Vasdev.
I know.
So we missed some of your wise comments. Can you give us some tacit hints about a good enucleation of the prostate and something which you want to say, which you have already done?
Yes. You see, the problem of stopping the procedure in between is that some clots get collected. And I was absolutely not keen on stopping in between. Anyway, I understand that the interest in aquablation would be very high. Okay. So as we were discussing, the first and most important thing is to identify the capsule. And once we identify the capsule, then you need to look at the contour of the adenoma. Here we can see the contour of the adenoma all around. So below is the capsule, above is the adenoma. And what we have done is we have taken a midline incision. We have separated the adenoma from floor. So in essence, from maybe around 5 o'clock to 7 o'clock, the floor has been completely dissected. Now, similarly, what I did was I went on the roof, I took a single midline incision, and then I dropped the adenoma from both sides. So here now I have an adenoma which is separated from 2 o'clock to around 10 o'clock. So we have adenoma separated from here, we have brought it down to 2 o'clock. Here it has come to around 4 o'clock. All I need to do now is join these two incisions. So that is what we'll do. So we have capsule identified here. We have capsule identified here. All we do is join this incision. Now again, this incision, this mucosal cut that you take will have no significance as far as your incontinence is concerned. Once you take a cut, with every swipe, I would be moving forward. So with every cut, my scope moves maybe a couple of millimeters forward. So I'm moving steadily away from the sphincteric zone. Now, here.
Sir, one question here, sir.
Yes.
Like you said that you have given incision anteriorly from 12 o'clock side.
Yes.
Did you release the apical area first at the start of the
Yes, that was the first thing I had done. So the first step here, we can see the capsule so beautifully seen all along. There's some small amount of tissue that remains behind can be very easily ablated. Okay, so now we have a adenoma till here. We have adenoma there. I need to join the two incisions at this place. Once I join the two incisions, find the apical, find the capsular area. And you see, one of the principles of HOLEP is that I want to try and convert the lobe into a mushroom. Now I'll explain you what I mean by that. We know how the mushroom looks like. It has a narrow stalk and a broad top. So that is what we have done. This adenoma has been say dropped from above. This adenoma has been elevated from below. And all I do now is this is the narrow stalk of the mushroom that is there, which I keep on disconnecting by the laser energy. Now here, the resectoscope plays a small role. The resectoscope would be continuously pushing the adenoma forward when I'm stretching. So by the resectoscope, I stretch the attachments of the adenoma to the capsule and keep on disconnecting them. Don't push. You see, we have a brilliant dissection technology. We have brilliant lasers today. And when we have a good dissection technology, try and not do blunt dissection at all. The problem with blunt dissection would be, one, in our patients a lot of patients also have significant chronic prostatitis, there is a possibility that you will rupture the capsule. Second is that you will open up blood vessels, which will unnecessarily give you trouble. Now, when I'm working with a defocused beam, my laser beam is not only causing this dissection, it also is causing simultaneous hemostasis. So very, very unusual that you will find major bleeders in your way.
You will be slightly giving traction or not at this stage?
There is absolutely no pressure applied here. You can see my hands are absolutely free.
Sir, one more thing, when you are proceeding in this step right now.
Yes.
Like suppose if you compare a 60-gram prostate with a 120 or 140-gram prostate.
Yes.
Sometimes in larger glands, you know, the extent of the lobes in the region of the apex are beyond the veru. So when the initial part, when you give incision just around the veru and when you are lifting the gland, so any tips in such glands, how to proceed like if they are beyond the veru?
The thing with HOLEP is that you simply don't look at the verumontanum once the initial apical incision is taken. And beyond that, everything that you do is along the contour of the gland. So I have taken this incision, and beyond that, I have stopped looking at the verumontanum, which I would do when I'm doing a TURP. You see, now we have just this much attachment remaining. It is separated from below, it is separated here. Now my telescope will gradually keep on pushing it in very, very lightly, so that just the aim of pushing is that I stretch these attachments. Okay.
Sir, we are just going to quickly introduce our next case in OTD. He's a 61-year-old gentleman with obstructive lower urinary tract symptoms, not responding to alpha blockers. He has had a previous history of pulmonary tuberculosis 20 years back. His IPSS score is 22. On DRE, found to have grade 2 firm prostatomegaly. His blood reports were normal, and on ultrasound found to have 45 grams prostate. Now the plan for this patient is bipolar resection by Dr. S.P. Yadav sir. S.P. Yadav sir is a senior urologist currently working in Pushpanjali Hospital in Gurgaon, and he has got a vast experience in bipolar resection as well as in bipolar enucleation. To you, S.P. Yadav sir.
Hello.
Hi, Dr. Yadav, Dr. Sharma.
Hello,
Yes.
good afternoon.
Good afternoon. Can you hear us, Dr. Yadav?
Hello.
Hello. Can you hear?
Good afternoon, Ji.
Good afternoon. Can you see?
May I know who is speaking?
Can you hear me,
आवाज
Dr.
नहीं आ रही।
Ajay Sharma here?
मेरे
Hello, Dr. Yadav. This is Dr. Ajay
आवाज नहीं आ
Sharma.
रही। See, hello,
OTD.
hello, yeah.
Yeah. Dr. Ajay Sharma here, Dr. Yadav.
Ajay,
Yes.
good afternoon.
Good afternoon.
See, you are seeing and everybody sitting here seeing different varieties of the prostate surgery. The main thing which I feel after 40 years of doing resection is the patient should be happy at the end of the day, whatever procedure you choose. And most of the time your surgery is very good, but after 15 days, after 2 months or after 3 months, he has a submeatal stenosis in 5 to 10% of the cases and a bulbar stricture in good number of the patients. And then he says, no, sir, I'm not enjoying passing the urine. So first thing which I want to say to the younger generation is, please do not do TURP if his urethra is not roomy. If it is not admitting your resectoscope comfortably and resectoscope is not going freely, do not start it. Either he should be on catheter or do a good dilatation or do a good otis urethrotomy so that your 26 or 24 or 28, whatever seat you are using, should be freely moving into the urethra. This is one. Otherwise, he is likely to have submeatal stenosis and bulbar stricture later on. Leave aside the bladder neck contracture. This patient is not having a very big prostate. You see, this is the Viru, and this is this. As per ultrasound report, the prostate is only 40 grams. He is most likely tubercular patient, not very fit for surgery, but yes, his symptoms are there. He is definitely disturbed by the prostatic symptoms. His PSA is okay. In this case, ordinarily, I am always using the Olympus bipolar TURP from the last 14 years from 2010 onwards. Up to 60 grams of the prostate, I always do resection, and more than 60, I try to do enucleation by the same resectoscope. This Olympus resectoscope has 4 loops. 1, like BNI, 2, like loop, 3 is enucleation, which has a different configuration, which you see on the torch also. You see, can you focus it? This has 2 things, 1 for mechanical, 2nd for coagulation. And this is the cutting, and the loop I have already here. There is 1 loop inside, one more, that is the buttonhole. That is honestly very good for, he is not having Olympus person. That is very good for fulguration of the bladder tumors. Yeah. Dr. Ajay, you were speaking something? Hello?
Yes, sir.
Can I start?
Sir, you can start, sir.
Yeah.
So with the patient not responding to medical therapy and looking the endoscopy picture.
Yeah.
What is your opinion, sir? I mean, it looks like more like a high bladder neck, and there are no, the lobes are also not kissing together.
Agreed. That's why I told, not very big prostate, small prostate, not responding to medicine. What options I have? Already good trial of the medical therapy has been given. These are the 2. You see, one thing more which I want to communicate to the younger generation, always have a good look to the bladder. There should not be anything extra in the bladder, like a small tumor or a small stone. At good number of times in your lifetime, you will also encounter that you have done the TURP, but later on patient had a bladder tumor. At least 1 or 2 cases, everybody must have experience in his lifetime. I have seen that because I am waiting for the last half an hour. I have seen the whole bladder nicely. There is no tumor. There is no other pathology in the bladder. So see this Olympus is not a electrical cutting. It is basically a plasma cutting. You see. What is plasma? Plasma converts the solid into liquid, liquid into gases, and gases into the plasma. Yellow. Yeah, see the glow, yellow glow. This is the plasma. This is the plasma. The depth of the plasma is only 5 millimeter or 6 millimeter. If you use the potassium, the glow instead of yellow will be purple color. So this yellow is because of the sodium chloride which we are using. The second advantage of using sodium, you all know, very less you can work for a very long time, and I have removed more than 120 grams of the prostate with this.
Sir, considering the weight of the prostate, is there any limitation of bipolar TUR also?
Any?
Considering the weight of the prostate,
yes, sir.
According to you, is there any limitation of bipolar resection?
Smaller prostate, one should avoid, honestly speaking, just give an incision. In this case, I'll prefer to give a small incision at the neck and come out. But these are not good. I believe not good for the lasers, not good for.
Sir, Sir, Dr. Pankaj Neshri is going to finish the procedure. He wants to show something. Can we shift to OTB?
Okay.
Dr. Pankaj, we are with you now. Dr. Pankaj Neshri? Dr. Pankaj? Can you listen us, Dr. Pankaj Meshri?
Hello.
Yeah, Dr. Pankaj, we are with you now.
Yeah. So there is a small problem with the machine. We have stopped. You could continue with sir for some more time. I'll tell you when I'm ready. So just to show you again, so this also adenoma is nearly done. Again, there is a very, very short attachment here. So I'll be just keeping on separating these attachment. Now, one important tip that I want to give here is, once you are near the bladder neck, switch off the outflow and try and push the adenoma inside the bladder. Now, once that happens, the weight of the adenoma itself would stretch these connections and disconnecting will be easier. So these machines need a very low temperature in operation theater. We need a temperature of around 20-21 degrees. But luckily, the temperatures are a bit on the higher side. So the machine has stopped. We will get it ready and I'll get back to you in maybe a couple of minutes. Hello. Am I there, sir?
Hello.
Dr. Pankaj, can you hear now?
Ajay, I am here. Pankaj is not here.
Okay. Can we go back to Dr. Pankaj Maheshwari's OT? No, actually, we were talking.
Hello.
Yeah, Dr. Pankaj.
Am I audible now? Yeah. So I was saying there was a small hiccup with the machine that has been sorted.
Yeah, okay.
What I have done now is I have reduced my frequency. I have now come to around 40 frequency, just because the temperatures in the say needed are difficult to maintain at this time. Now these are just the terminal mucosal connections. Just beyond this mucosa is the bladder. So you just cut them off. Okay.
Sir, how to identify that this is the site of bladder neck? Like in what situations?
You see,
you should be very careful so that you can avoid a injury to the ureteric artery.
Yes. So you will see a very translucent membrane like this. When you are at the adenoma, such translucent membrane will not be there. And under the adenoma on both sides, I can see the bladder. So I know where I am. And further, what I do is, as I was saying, once I come near the bladder neck, I switch off the outflow partially, let the bladder fill a bit. Now, this would help in a way that one, it will create some space for the adenoma to go inside the bladder, and two, it will, the orifices will shift a bit away from me as the bladder fills up.
Sir, sometimes in large glands, I mean, they are very close to the median lobe and it is very difficult to even see them also.
Yes.
So if such a patient, if you are doing whole lab, how to go about it? Like,
so most often once you say, now you see, this is where I know my bladder neck is. So definitely the orifices are far away from here. The only precaution I will take at this time is that my laser fiber should not protrude beyond this line. I will keep on working slowly here and slowly keep on disconnecting the attachments. But don't go beyond this line. Beyond this line, I carry a risk of burning the orifices. So there, I can see the bladder from there. These are very small attachments. So just don't go inside. Okay, and when there is a very small attachment remaining between the adenoma and the capsule, you can just give a small push to the adenoma and let it go inside. So like very few flimsy attachments are there, I just push it in. So it's done. Now we have a very, very good fossa open. That's my verumontanum. The fossa is open on all the sides very well. I will just do some amount of hemostasis. And once I am through with the hemostasis, I will do the morcellation. Now, again, to revise, if I have to say what would be my tips for enucleation, my tips for enucleation would be start at the apex, take an incision between the verumontanum and the lateral lobe, identify the capsule there. Once you identify the capsule, then just stay on the capsule. Take the incisions in a way that you convert the adenoma into a mushroom so that the connection, you see, the common time when a person gets lost in the tissue is when I'm trying to join the roof to the floor incision. If I reduce this incision so much that both the ends are in a single view, the possibility of me getting lost is very low. You can see the return of this tube. The return is absolutely clear. I can see the vision very well. My orifices are very, very far away from me. And we are in a good position to start the morcellation. If there are any questions, please, you can ask now.
So Dr. Pankaj, you are not a proponent of en bloc prostatectomy?
So my simple thought here is, you see, we are a teaching department. I do not want to complicate an already difficult procedure. One of the problems, most important problem that people face is in their learning curve. It's good to show, but it's not good to teach.
Yeah.
Let's teach people 2-lobe or 3-lobe technique and let them gradually on their own progress to en bloc enucleation if they want to.
Dr. Pankaj, in that case, since you are teaching,
yes,
so, do your students get to do TURP first, or they start with Holmium straight away?
My DNB program started 3 years back. And within these 3 years, we try and do few TURPs. I can tell you that my final year student, means this prostate in my center, I would not have even washed up. It would be done by my final year student. Today, the morcellation that I would be doing, I would probably be doing after ages, because morcellation is always done by my students. So what I mean is, because they have groomed with HOLEP as a technique, they are extremely good in this, taking bladder neck incisions, removing the lobe in the end, doing morcellation. The only place where I try to be there or sometimes take over is when they are working at this place near the bladder neck. Now, this is a dangerous place where I want to be actively there or help them remove this. But rest of the adenoma, they can do it extremely well. In today's time, when laser is so often available, when lasers like TFL are much cheaper, portable, we have seen such a beautiful enucleation done by TFL. So it is important that people learn enucleation. What energy source you use is probably immaterial. The only advantage of high power laser would be, one, that it will be a marginally faster procedure. So if I have to do a 150, 200 gram gland, probably I would not be very comfortable doing with low power or with TFL laser. The bleeding points will be less. you saw that there was hardly any point for hemostasis.
Yeah.
The reason being because I'm working at a high frequency, the simultaneous hemostasis is very good. So bleeding points will be less. So speed, large prostates and less bleeding points. These would be the advantages
Sir,
of
SP Yadav
hypotension.
sir wants to demonstrate something.
Yes.
Right.
I
Can
guess
we
that
shift
could
to
be
OTD,
without
please?
OT.
Dr. Ajay,
Yeah, Dr. Yadav.
you see, in the very beginning, it was discussed that this patient most likely having a high neck. You see, the high neck. So I always give incision to make it a funnel. And if there is a funnel like meatus, internal meatus, then he will pass in a better way rather than. And most of the prostate is out. I'll just later on clear it. Is both your orifices very far away. There is one orifice here,
Yeah.
and second orifice here.
So there are two important points here. Actually, the first point when Dr. Yadav started his surgery, he said about something about urethra. So
Yes.
for the students and for the new urologists, we have been using Vaseline-based creams in the urethra. Jelly is water soluble. So we are using Neosporin cream, and you can use any other Vaseline-based. So the chances of stricture are much less when we use the Vaseline-based lubricant, in addition to the Jalocan jelly which we normally use, because Vaseline-based ointment, they stay in urethra for a very long time. And second part is this bladder neck incision. We give bladder neck incision practically in all our prostate. We are doing TURP most of the time, and practically every patient has a BNI in addition at the end of the procedure. There are two advantages. Once you do BNI, you suddenly find more tissue coming up.
Yes.
Second advantage is
Yes.
prevent bladder neck contracture. So like a few minutes back, it was looking as if TURP has been finished.
Yes.
Now immediately after bladder neck incision, you see
Yes, a
that
lot of
more-
tissue has
more
come.
tissue.
Lot of tissue has come up.
Yeah. So some more tissue comes out.
Yes.
And your resection gets better.
It gives a idea of where the capsule is exactly.
Plus,
When you use that.
yeah, and secondly, of course, you prevent bladder neck contracture, which is very common in smaller prostate.
You see, things have changed after giving him bladder neck incision. How it was in the beginning and how it is now. You can see the capsule.
Sir, do you routinely use Olympus bipolar?
Yes, I
mean,
have.
where the sheath is the returning port for the current.
Yes.
In your experience, any incidence of the urethral stricture, particularly when the current impedance increased because of some fault in the loop or charring at the hind part of the loop?
See, I am using it for the last 14 years, 2010 onwards, having two sets, not doing any monopolar surgery. And reasonably, I am very happy. The current depth is not very much. Not very much. I have removed even 220 grams and reported in the Limca book also. The current as compared to the routine bipolar in this is different. If you look at.
So in your experience, the issue of the urethral stricture where the sheath is a returning port.
I am very much afraid of stricture.
Yeah, it's
in the very beginning, I
It's
told you.
More theoretical, not practical, not seen in the practice.
No, seen very, very, very frequently in the practice, sitting at the same place for the last 20 years.
The quality of bipolar instrument is very important. We have two very bad strictures with Indian bipolar. We are using Olympus now. And when we do coagulation, many a times we actually listen to crackling sounds coming out of the urethra. So that scares me, but so far with Olympus, we have not seen any stricture. Another point I would like to tell, especially for the beginners. Now, these are the prostate. Now, we are propagating bipolar as a better instrument than monopolar. The only advantage is you are doing it in saline, just to prevent the hyponatremia and all that. But these are the kind of prostates which you do not need bipolar. You can do monopolar, you can do bipolar, anything. Because this takes few minutes and your job is over. So don't get this message that monopolar is a wrong surgery. For this kind of prostate, you really don't need a bipolar. Since you have it, you do it. That's fine. But you don't have to have bipolar instrument.
The advantage, Dr. Ajay, with bipolar is chances of bladder neck contracture will be less with bipolar. Otherwise, in a small prostate, monopolar, if you go on coagulating, chances of stricture will be more. I don't know what people say, but I was in the beginning in the surgery department. People say hernia is the easiest surgery. I say no, hernia and prostate are the most difficult surgery as far as patient is concerned. If after hernia patient is not having a pain, he will never be free of pain his whole life. Same way, if after first prostatic surgery, he is not happy, he will never be happy. And every time he passes urine, he will definitely curse you. So prostate surgery is not as easy. That's why there are so many techniques.
Yeah.
Why so many techniques have come in? Appendix, no other technique, only one, open or laparoscopic. No other techniques have come in, but in prostate, so many techniques have come in because it is not very easy for a person to live with the prostatic complications. And anybody who has seen the feel of the feeling of the patient after prostate surgery, he will appreciate that yes, patients are not happy. That's why in the fine. That's why in the very beginning I said, please try to save the urethra. Try to save the urethra. That's all.
Sir, we are shifting to Dr. Pankaj Maheshwari, sir, who's going to show us the tips and tricks of morcellation.
Oh, yeah, it's very important.
To Dr. Pankaj Maheshwari, sir.
Good afternoon. Am I audible? Hello? Hello? Am I audible?
Yeah, Dr. Pankaj?
Yeah.
Yeah,
It was a
we are with
small
you.
gland. Sadly, I have completed the morcellation. The tips would be that I would put an additional irrigation to the my morcelloscope. I want the bladder to be optimally full. Intermittently, I would keep my hand on the tummy and confirm that the bladder is full. The tissue should always be under the vision. So with a suction, lift up the tissue, dip down your scope so that the tissue goes up, and see to it that the tissue completely doesn't block your vision. By the side of tissue, some amount of bladder should always be seen. There are two types of morcellation. The luminous morcellator is a tube inside a tube morcellation. This morcellation is a oscillating morcellation. The oscillating morcellation definitely has a distinct advantage. The risk of bladder injury is dramatically low. So that's the end of my procedure. My fossa is seen very, very clear. Are you happy with the fossa?
Yeah, it's a very beautiful
And
surgery
from the
demonstrated.
verumontanum, we can just enter it very easily. The bladder looks very clean. Both the orifices look good. Normally in this situation, in my setup, I would have put a 16 or 18 Foley without any traction or irrigation. We remove the catheter within 36 hours. So the patient is operated now. Tomorrow late night, the catheter comes out so that when the patient gets up next day in the morning, he passes urine and he's ready for discharge.
Yeah, very nice, Dr. Pankaj. Now we are going for an online demonstration of Rejum by Dr. T. Manohar. Can we connect to him?
Yeah, thank you. Am I audible? Please enable my screen, please. Yeah, I'm audible. Hello. Hello. They have to enable my screen.
Yes, sir.
Are we with Dr. Yadav?
Can I just show you the catheter at the end? Urine bag.
We are.
You can see the urine is absolutely clear.
We can believe that.
But I need to take some credit, sir. Thank you. Thoroughly enjoyed.
Thank you, Dr. Pankaj. We all were very keenly looking your technique.
Thank you.
Masterly enucleated prostate. Thank you very
Thank
much.
you so much, sir. बढ़िया हो गया सर. अरे ये बंद कर दीजिए.
We are shifting to OTD, where sir is now closing the case.
We have reached almost the capsule. Hello.
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 Yeah, Dr. Yadav.
We have reached almost the capsule. I'm not running any water. There is no water is running. You can see
Yeah.
hardly any bleeding. Day after, I usually remove the catheter after 48 hours.
Very nice, Dr. Yadav. Very, very
Yes.
nice.
Thank you. Thank you, sir.
Thank you.
Yeah,
So we
but
have,
sir, do you use the warm saline or normal temperature saline?
Normal temperature, body temperature. Yeah, here we reach the capsule.
Sometimes do you find difficulty in activating and engaging the tissue, particularly when there is a very small residual tissue near the verumentanum? Do you use the vapor throat also?
Yes, that's why he's not having, I would have shown the very good use of Vapotrol, very good use of Vapotrol, particularly in the bladder and at the apex near Veru. That's a very useful equipment, honestly speaking, for bladder tumors, resection of the bladder anywhere, and resection of the prostate here. Very good.
Dr. Yadav,
Sir,
we are shifting to an online presentation.
thank you, sir. Thank you very much. Obliged.
So
Dr.
Dr. T. Manohar was supposed to join us physically, but unfortunately, again, because of the yesterday's glitches with the airlines, he's not able to make it physically, but he has graciously accepted our invitation to present his cases in a semi-live fashion. Dr. T. Manohar, sir.
Thank you. Thank you for all the organizers of North Zone. And I'm very thankful for giving me an opportunity to share my experiences. Although I would not wanted to be there in the program there, I tried my level best, but then there's, I think even early morning flight cancellation was done. So anyway, I'll eager to show my presentation. Hope everything is heard, clear, screen is okay. I thank the organizers and the moderators and chairpersons to giving me this opportunity. So today I'll just talk about the complete similar video. I'm not going to the complete presentation. If you want, we can discuss that. And coming to straight away, the instrumentation which I would have been shown in the live there, it comes in the resume packet, comes in a complete one generator. And this is the instrumentation set. It comes in a disposable pack where you can see this is the actually the delivery device, which has got white button and a blue button. And there's one button which is not there. So there are 3 buttons in this device. And you can see this needle which has come out, which is about 0.8 centimeter and which has got 3 to 9 holes, 9 holes on either side. And this is the injection device. This is where it can host the water. And this is the tip of the needle where you can draw the water into this plain distilled water to take it. And this device got attachment to the 3 tubings here, 1 tube for the irrigation channel, the another tube for the irrigation, and the black tube goes to the generator. So very simple, straightforward. This tube comes in a pack and it has got a channels where we have fixed it into the portion. And this device is 16 French. It's a thin ceramic. You can see that white thin ceramic. And it has got a light tip there, which is a transparent bead to host the needle. And this is a 16 French vertically oval, which has got a step. And it's very, very ideal. It is better than 16 French catheter to pass it in. So that's what I'm trying to tell. So maybe you can get a small scopes on the table to assess. This is the 17 French. I always do the 17 French cystoscopy before doing any prostate procedure. So sometimes I use even a small 8 to 10 French scope to assess. We are not dealing with any of the strictures. And this is the complete set of a lot of jellies in any of the urethral procedure. And when I showed you that generator, in the sense, this distilled water, the main aim is to inject resume is a steam. So we call it as a water vapor thermotherapy. Resume is a company name. We have to mention in the hotel list or wherever it's a scientific name is the water vapor thermotherapy. So now, first step is to take this injection and this bottle, it also comes with, that's the bottle there. This is the generator where it can comes down there. You can see that it comes with a distilled water of this, and you just have to inject the air and see that there is no air collected. Completely of 20 cc, you can just, these are all the disposable ones where you can take it up and then slowly go all the way down and then rotate it anti-crate and then it can completely, so this is the ready for putting into the generator. So this is the where you can see this the generator, and once the water is given onto the step there. So this is again the same step which I'm showing here. So once that is done, this water has been placed in the generator. One slot is there. That is the one which has been placed, You can see that once again, I'll show that. And this is the slot there, where the distilled water has been placed. This is the tubing for the generator, and this is the tubing for the irrigation. So they just got two tubings are there. The tubing which goes here, it has got a color coded, very easy to operate. You put the tube color code, whatever is there, and you press it across. This is the pressure guided. It goes to the irrigation. This is to the generator, and this tube is connected to the steam. So this is the water which goes for the steam. So all these procedures, we always doing pudendal block, except the two cases which I did it about general anesthesia in out of the country. I mean, when I was in Gulf. But in India, most of the cases we have done with the pudendal block. And all these procedures under pudendal block, then our anesthetists are very well versed also, because since we are doing the transperineal biopsies also, we have been very well versed doing that. We are injecting the needle against the bone into the pudendal block. And few cases we have done, one or the two cases we have done under sedation, there's little small gel into that area. So basically, most of the cases can be done either sedation, prosthetic block, or a pudendal block. So in this case, most of the cases, we are very comfortable with the pudendal block.
Dr. Manohar, we'll just break to start the case on the other side, and then we'll come back to you. Just give us 2 minutes.
Sure.
Dr. Anil Varshney is starting his case. Yes. OT, please, Dr. Anil Varshney, sir.
A very good afternoon, friends. Can you hear me?
Good afternoon, Dr. Anil Varshney. We can clearly hear you.
Okay, very good afternoon. I'm very proud that Dr. Swapan Sood has organized all this BPH 360 degree, and it is really a 360 degree. You have heard about this case, and I am sure you are able to see the endoscopic vision. And this is a patient, you have heard about him, but these are the multiple bladder stones, practically 2.5 centimeter size each. So these are can you all see the endo view?
Yeah, we can see the end of you.
So the advantage of this holmium is that you can do simultaneously bladder stones, ureteric stones, renal stones, prostate. So that is the versatility of this laser. And that is one of the things which we always say. You have seen since morning the people, Tanuj, Dheeraj, all doing thulium and holmium. So we want one instrument which can deal with all kind of these things. And in a single setting, we are planning to take care of all these stones as well as 102 cc prostate. This is a high risk case with poor ejection fraction and CAD. And let us proceed without wasting time. I think you can go. I'll just first finish off with the stones, and then we will proceed with the laser. I'll just show you the kind of prostate we are having. See the prostate here. These are the two large lateral lobes. This is the anterior extent of these lobes. And if we come back, this is the viru, and the prostate is extending way beyond distal to viru. So this is how it is, and this is where the sphincter is. So we have, this patient was on catheter for a long time. When I did the cystoscopy, he had lot of infected urine. So that is one thing, his culture was positive. So I'm told that he has been on antibiotics. The question is, should we stage or not stage? But to keep the bladder pressures low in such cases, I put in a suprapubic needle. So you can see the suprapubic needle, which we have put just to keep the bladder pressure low. So that helps us that even if you have some kind of turbidity, it was very turbid. Just before scopy, we found that the bladder was very turbid, and these are the stones with lot of infection.
This needle you will remove before morcellation.
Yes, absolutely.
Then the pressure will be too high.
In morcellation, no, we distend the bladder sufficiently that we are able to morcellate. So any questions at this stage, welcome. Otherwise, let us start with this thing, the pulverization and fragmentation of these stones.
Yes, you can continue with it.
Okay, dear. God bless you.
Can we resume the online presentation by Dr. Manohar?
So I'm ready. I'm audible.
Yeah, you are audible.
Yeah. So now I think the instrument is ready. The three tubes are connected. The one tube which is see here, the blue one, which is the irrigation one, it has been closed. So while doing the procedure, this has to be closed because the irrigation goes in as a one line and then come back from the bladder. So this is closed while doing the procedure. What is required extra accessories are the telescope and a camera system, what you have to have, because all these things are disposable. You need to have a telescope and a camera system. So I'll show that the telescope, how it goes in. This is I think Wolf and Karl Stoves, both of them will go. This is the telescope which is going in, and then there's a click sound comes, so it indicates that the exact length, and you have to have a white source. Of course, you have to have a light source, and this is the camera head. We are fixing it. So this is how the system got in arranged now. This is how to fix it, and the same as lithotomy position. This patient is also this you can see the irrigation. There's a white button which I showed. When you press it single, this is the turbo irrigation. When you press it twice, the double irrigation comes. It is called turbo irrigation. So just I'll show you that once again, that you can see that irrigation which comes here. The one you press the button here, simple irrigation. This is a smart irrigation, turbo irrigation. So you can have irrigation which is little quicker. That is also a very good point wherein you can have a proper irrigation to enter into that, because this has got you see that urethra and it is a 16 fan. One should be very careful because that has got a bead there. Very gentle, very nicely it has to be passed. And you can see this is actually my first case, which is the large median lobe. He was a neurosurgeon by profession, and he had a serum creatinine of 2.3. He has got a retention of urine. He has a big median lobe. You can see that. And then he didn't wanted any general anesthesia. He wanted only the local anesthesia procedure. So we explained to him. You can see that there's the median lobe and it's the larger lobe. And he wanted, actually, I'm a HoLEP surgeon. I told him that, no, this is a case for HoLEP. I'll do it by mini scope, probably pudendal block. We have done a few cases of pudendal block, mini HoLEP also, but the patient was not very willing. So actually this patient is a first case which we did and I resumed. And this patient, of course, this is a complete video. You can see that once it is set, the 16 fan easily went in, and this is how the prostate looks, and it's ready to for injections. So I'll go to how it is being done. So now, this again, I'm showing that how the procedure is being done. This is a patient who has a 38 or 40 gram prostate. This patient was not fit for anesthesia, and he was having a lot of giddiness for the medications. And he also has a pacemaker, and he has a venous shunt which has been passed, and then he was not fit for surgery, and he had a severe obstruction. You can see that there's an obstruction, and we have gently passed and this guy we have taken up for resume and a pudendal block. So now the question is assess the median first, coming from the bladder neck. The distance between this to here is 0.5. So we are choosing the 0.5 to 0.5 is a 1 centimeter away from the bladder neck. And I shall show you once again. This is the assessment, initial assessment. You go there, I show you that earlier. The assessment, whether there's a median lobe is there with the required. There's a small median lobe. There's a small median lobe, which is just coming on the way. And then you just have to turn it back, come to the, turn backwards, and then come to the bladder neck. The distance between this tip and this is 0.5. So we have to choose 1 centimeter. 1 centimeter from the bladder neck, and it should be 1 centimeter away from the verumontanum. So right at the 90 degrees, usually at the 90 degrees, or you can do sequentially if it is bigger prostate. Now, this we have injected, steam has been pressed. It is only 0.4 ml of steam, goes for about 9 seconds. Treatment is over, 9 seconds is over. You can see that blanching. And then again, the first treatment is over. Now I'm coming back from here where we have injected. From here, then go back downwards, 0.5 to 0.5, and inject the one more injection into the area of the prostate, so that at the same time you can see that there's verumontanum is seen there. Then come back and see there is the verumontanum is there. This is the prostate. So 2 treatment has been given at between the distance between 1 centimeters each apart. And also you can give to some mound of the prostate once you're done. Now you go back again. 2 treatments have been given on the left lobe. And now come back from the bladder neck again, 0.5 centimeters. This is 1 centimeters middle, exactly 90 degrees at 3 o'clock. And this is at the 9 o'clock here on this side. And then, it has been a little edited here. So it's about 9-second treatment. and then come back again 1 centimeters from here, this prostate, and then look at the Vero there. Yeah, Vero is in front, and then slightly away. This is little above. I've taken little above into the area of the prostate, although it is not exactly at the 3 o'clock. It is just little above because the lateral lobe on the right side was a little bit more. See that that's about again 9-second treatment is over. Now when I come back, you see that it looks more obstructed now because you have created an artificial inflammation where the prostate seems to be now it is obstructed kind of thing. I feel that this is the bulging is extra here. I plan to give one more injection on that side. So what we have given onto the right lobe, and this again, each device can give 15 injections. So we have plenty of them. And then see that the mount was down here, so that I thought that I'll give it one mount to the bulging towards the in front of the Virumontana, slightly above. So this is the 3 injections, 3 treatments on the right lobe. We have already given 2 treatments on the left lobe. Again, 9 seconds. This steam, which is a 0.4 ml, which goes for 9 seconds, and the treatment is now. I think I'm just assessing to give whether this is a median lobe because it seems to be a severe obstruction, and this small median lobe just have to about 0.5 centimeters from the bladder neck. You can go on the summit on the mid lobe. This is the median lobe. So even median lobes can be treated with this. The previous patient which I showed, we have given 2 injections to the median lobe sequentially. So I don't have the recording of that clear recording. That's why I'm showing this video where we have given to all the 2 lobes, 2 lobe bar, 3 on the right treatment, and this 1 median lobe. So now the whole treatment is over. Go back to the bladder, see, just check it, and there's no bleeding. You can see the blanching effect. Completely, the whole prostate looks blanching. In fact, this patient, we are unable to pass catheter. We have to put a lot of jelly to pass a catheter in. So the inflammation actually is created in this, and there is a edema of the prostate. So this is the complete one-stage procedure of this patient. And I think this is you can see that this is the patient's 34 cc prostate, this patient, and this is the urine flow. I just want to show the case scenario of this patient. This patient had alpha blocker, and he had erectile dysfunction. He's a 48-year-old man, 34 gram prostate, had a severe erectile dysfunction. This guy wanted to preserve the ejaculation. This guy wanted to preserve the erectile function. In this case, it's a very small prostate, but had a severe obstruction and had a severe bad effects for the alpha blockers. In this case, I think I will show you only this slide. It's about another 1 or 2 minutes. Yeah, it's 1 minute, 1.5 minutes, wherein their technique is a little different. See that I was giving the exactly at the 90 degrees for the rest of the prostate. In this case, because we wanted the ejaculatory the function to be preserved, little technique modification. I come back, it's there. It's the midway between the bladder neck and the Veru is 1 centimeter. And I come back, say parallelly, but rotate little slightly above. So that I am just giving not at the exactly at the 9 o'clock. So I mean not at the 3 o'clock, slightly about 1 or 2 o'clock, between 1 or 2 o'clock, so that it goes there. Each injections will cover 1 cubic centimeters. So it is basically the convection effect. The convection of the effect occurs at the level of the transitional zone, and further conduction effect occurs towards the periphery. So and again, go back. In this case, we have given only 2 injections. It's not that, because the tendency is that, we tend to give because we are all resectionists, we are whole surgeons. We want to see the bigger, see that 1 more injection is exactly at the upper level. This is now, again, not exactly at the 9 o'clock. This is towards the 11 and 12 o'clock junction. So it is higher. So this is a little technical modification in resume to prevent to preserve the ejaculatory function. So these are the same time which I was injecting. This injection, we can see that I did a transectal ultrasound. We can see that this is a peripheral zone, and this is the transitional zone with injection which is affected. And you can see the final effect of this. So this is how it looks. And then this patient required only 2 treatments. And we have done about 11 cases and 25 out of the country, 26. And this is one of the case samples where in uroflowmetry you can see that. And this is the post of 2 weeks, and this is 6 weeks. And the person who had, this is actually the guy who had a 48-year-old man who wanted to preserve the sexual function. This is the first case where this patient had a low flow, and then you can see the flow here at the 3 months. And this is another case. You can see the flow here. He's also had a chronic retention, and this is a 3 months follow-up. Thank you.
Thank you, Dr. Manohar, for a very nice presentation. Other than the concept of treating 1 cubic 1 cubic centimeter tissue. Is there any way to assess whether you have adequately treated the prostate during procedure?
Yeah, no, it is not possible to assess. That is the reason the AUA guideline has come with a guideline of doing the prostate treatment from 30 to 80 gram. Preferably, I have not done anything more than 60 gram prostate. Most of the cases are about 40 to 50 gram prostate. So it's basically because the effect is on toward the transitional zone and you require only the transitional zone to be opened up. And so you don't have, because you can do a transect ultrasound, what I did, and it shows that the effect is only toward the transitional zone. And that's the only thing we can make it out. And we don't have any guideline to see that. In fact, it is not good to see once you do it, it looks more of obstructed kind of scenario.
For how long do you keep the catheter?
It depends upon the size of the catheter. So away from the 30 gram, for 30 gram prostate, some of the cases, that's like that previous patient who had a 48-year-old man, which is about 31, 32 gram prostate. We didn't keep a catheter, but it didn't wide. My policy, if there's small prostate, not to keep a catheter, just ask him to wide. If he doesn't wide, then put a catheter. 30 grams one day, in each 10 gram extra, another day extra. Suppose if it is a 40 gram, you keep it for 2 days. If it is a 50 gram prostate, keep it for about 5 days. 40 gram for 4 days and 50 gram for 5 days. Each gram, I think you increase it. So basically, you require somewhere between 3 to 7 days of catheterization in a normal situation, sometimes more.
Okay, would you recommend this procedure electively in a patient who is otherwise suitable for any other conventional way of treating the prostate?
Come again? He is a patient who was conventional for other procedures also.
Otherwise suitable for any other method of treating the prostate, would you recommend this way procedure electively?
Yes, this is all patients has to be electively on this, but I don't think we have done anything on emergency basis. But this is the advantage of, because we have to explain to that this patient has got local anesthesia procedure. Right now, the indications are those who are having a high risk or complications or contraindications or side effects with the medications. Number one. Number two is those patients who are very highly comorbid, who are not very willing for anesthesia or high risk for anesthesia. And those specifically want to preserve the sexual function and ejaculatory function. These are the three my classical indications. Right now, we are doing it. And we explain to them, because the bipolar therapy, we do a whole lot of bipolar therapy, we have TULEP, we have resume, we explain to them the advantages of this. And then even we have done, we have got even Eurolift also. So we explain to them the need for the procedure and what is the nitty-gritty, because the disadvantage, the flip side of the procedure is about 7 days of catheterization, as against I don't even put a catheter for about after 6 hours in HOLEP, and then in TURP for about 2 to 3 days. So in resume about 5 to 7 days. So the flip side is catheterization. The advantage is that it has got sexual function, ejaculatory function preservation. It can be done under local anesthesia. It can be done as a daycare procedure, and the patient can walk on the same day.
From the audience?
Sir, the question is, do you have any patients who couldn't void after the procedure, like they had difficulty, they couldn't void?
Oh, there are plenty. This is the one of the procedure where I think the effects are, what I showed, the effect is about 6 weeks and 3 months. Unlike in TURP or in HOLEP, you see the patient is widening in the next day and then is widening to his glory. But whereas in this case, there are about 7 patients, which I mentioned, about 37 patients out of 7 patients, they didn't wide for about nearly about 2 patients of them didn't wide almost up to 3 weeks. In fact, we have to keep the catheter in about 3 patients for about 3 weeks. And then a little bit of tissues were passing in them. And then maximum catheterization was 20 days in our short series of this. So some of them required. But I think the initial period of resume is little stormy. One my caution word in Indian patients, we have to do a digital rectal examination and confirm he is not dealing with some tenderness. Deep palpation, no tenderness, and this is the patient for resume. If you have a severe tenderness or mild tenderness, I think this patient will have a stormy postoperative period with a dysuria retention. So I think catheterization is a bit the flip side of this. Some people may require for a longer duration. We have to convince the patient that is very risky. And I think it is one of the thing which is in the OPD, they're going to bother. Even if you have two patients whom you have done back to back, they come with a recurrent retention, I don't think that's going to bother you. But 3 months later, the results are exciting.
That the necrosis which happens following injecting the vapor, will it lead to like mucosal necrosis leading to like passing some tissues or what? I mean, anything like that?
No, not really, because only 20% of these cases, I don't know why they pass, little bit of tissue pieces can be passed, but in the literature also you can see that less than 10% passes, but it is actually the auto necrosis, the autolysis of the cells, which causes the convection method. So it's a convection method which goes perpendicularly toward the lateral cells, and then the conduction effect happens. So basically the cells which are desiccated and they become retracted. So you don't see too much of tissue passing out there. But of course, however, there are about 10 to 15% of them will tend to pass few bits and tissue pieces will be passed out as some kind of red blood clot kind of thing. And it's a dark, they tend to pass a few of them. Although I have not done more than 60-gram prostate, but those patients might be having up to, I mean, that's even Elterman have done even up to more than 80 gram they have done. And they tend to then, when I was speaking to him, he said that personally speaking, the bigger the prostate and also the prostate, the hardness of the prostate, probably if they have given it to the two injection the same side, the tissue exfoliation is more. That's what I experienced. And I think probably injecting the same into the same area possibly will produce the tissue nephrosis. If you are sequentially done, I think this is not commonly seen.
I think the data has to emerge now, since as more and more people start using this technology, and the long-term data and also the predictors of which patients are going to respond very well when compared to other patients, that data when it comes only, then we can have a definitive answer to that question, I guess. I think it's a wonderful presentation.
Right now they have 5 years data as compared to, but then they are not randomized as such. And then if you ask me for, I mean, of course, see, these are the, we cannot say that this procedure is for everybody. As I said, mentioned, this is one of the method where the patient, basically this method, the mist, the whole treatment of mist has come into the picture because of the complications of medication management. Nowadays, I think our longevity of 72 years is also increased in India. It's become 72 years. And we are seeing more and more less patients. 66.9% of the Indian populations are more than 72 years now. And then the more medications, as you can look at the literature, if you cross the medical management for more than 9 years, people are presenting with the phenile tremors, they have constipation, sexual dysfunction, and after 9 years, there's one of the reports showing memory loss. If you ask specifically the patient who has taken for more than 7-8 years of alpha blockers, you ask the patient, ask the patient's wife, and I was inquisitive to after seeing these reports. Yes, they tend to have some kind of memory loss. Basically, we should understand all these mistreatment have come in the place of side effects of the medical management.
Fully agree, sir.
If you use for a correct indications judiciously, this has got the future.
Yes, definitely. Thank you so much, sir. It's a wonderful talk. I think we will wind up the talk here, and we're going to.
Thank you, Dr. Manohar, for joining us.
Thank you very much. Thanks for the invite. And I'm sorry that I couldn't come there because of the lot of issues here. So anyway, thank you so much for listening to me. And all the best for the conference.
So with this, we'll also have a change of guards for the chairpersons. Thank you so much. May I invite the new set of chairpersons, Dr. H.S. Pawar, Dr. Sameer Trivedi, Dr. Ashish Jindal, and Dr. Sagar Sabharwal. So we are ready with you have seen the semi-live resume. We are ready with the another live resume being done. This would be done by Dr. Shreyas Bhadravar. He is from Eurocul, Pune. Sir. Hello, OT, can you please present the case? Dr. Sanyam.
Good afternoon, sir. Anil, sir. I'm Dr. Pahwa here.
Hello, am I audible?
Can you hear me?
Yeah, sir.
Hello.
Before you proceed, there is another announcement. The lunch is ready. It is going to be a working lunch only. You can go right across the gate you are saying of the hall, the lunch is there through the exhibition area.
This is regarding the case. Hello, am I audible?
Hello?
Am I audible?
Yes, yes, you are very
Yeah,
well.
this is the case which is planned for resume. This is a patient, 52-year-old gentleman with complaints of frequency, urgency, urgent incontinence, and nocturia. He has comorbidities of AKI. He has an IPSS of 19. He has a grade 2 firm prostate. He has a prostate of 28 grams. The truss and abdominal ultrasound can be seen on the screen. PSA is 1.7 and creatinine is 2.25. You can see the uroflowmetry on screen. He's planned for resume, which will be done by Dr. Shreyas. Over to Dr. Shreyas, please.
Good afternoon, sir. So I have done a cystoscopy with a 20 French cystoscope. So you can see that he has a median lobe, and the prostate lateral lobes also are mildly enlarged, but mainly it is the median lobe which is causing an obstruction. So first I go about with uh, finding the length of the prostatic urethra. So I am now at the bladder neck, and so the prostatic urethra is about 2 centimeter long. So now I'll be showing you the initial setup of the resume device. So first of all, I have taken this sterile water in the syringe, and I remove this stem and I give it to the assistant so that he applies it to the delivery device. So this is a delivery device. This power.
Can we see it on the full screen, please? The external camera on the full screen.
ये दिखाई. So this is a delivery device. So now if you can see this white thing, if I press this, it starts the irrigation. And if I press it, the gray button, then the needle comes out. Okay. And if I press this retractor needle, so the needle goes inside, and this is the activation of the steam. So I give the irrigation.
Dr. Shreyas.
Yes, sir.
How does the measurement of prostatic urethral length help you in deciding your further procedure?
So if you feel, we measure the field of view through this delivery device. So if you can see here, I have. So this appears to be the field of view. These are the two stems of the resume. So we draw an imaginary line from the exit of the two stem, and the line drawn from the tip of the delivery device till this imaginary line midpoint, it is about 0.5 centimeter.
Okay.
Okay. So we can estimate this 0.5 centimeter and find the length of the prostatic urethra.
Okay.
So now the so now this cystoscope.
Dr. Pahwa here. So how, like, this patient had very prominent median lobe. Does
Yes.
it make some difference in your case selection?
So in resume, we can treat the median lobe.
That is a plus point if you compare with lip.
Yes. Now I'm starting with the irrigation. First, I do the priming of the device. I take out the needle, and then I press the blue button so that the priming starts. Priming goes for about 30 seconds. So the priming is completed. Now I retract the needle. Now again, there is one cycle of pre-treatment is required. So it goes for 9 seconds. You can see the steam which is coming out from the needle. Okay. So now the device is ready for the treatment. Jelly level.
Dr. Shreyas, what is the sheet size that you're using?
So this sheet comes with, it is a 16 French sheet, which is available with the Resume device. So now I'm at the bladder neck. So this is an imaginary line. So this is one field of view. This is the second field of view. So 1 centimeter. Another 2 field of view, which is about 2 centimeter. And this is the proximal end of Veru. So it is about nearly 2.5 centimeters. So now again I go inside the near the bladder neck. So I decide I have it is about 2 centimeters. So I can give 2 treatments on each lobe. So
it covers nearly 1 centimeter forward.
So this is about 1 centimeter. I deploy the needle and then I press this blue button, which delivers the steam for 9 seconds. So after 9 seconds, I leave the needle for about 2 to 3 seconds inside. And then I retract the needle. So again, I come near the, so this is away from the proximal end of, so again, I'll giving treatment here. You can see the belching of the tissue there. Now I go on the other side. So I'm planning to give a treatment for a median lobe as well. So for median lobe, what we do is we go 1 centimeter from the bladder neck and tilt the angle for about 45 degrees.
So, especially in median lobe, like you're supposed to spare bladder neck area because there is some apprehension it can involve in bladder neck contracture.
So I'm away from bladder neck. I have given treatment at 1 centimeter away from the bladder neck. So you can see nice belching of the prostatic tissue here.
So that was my initial apprehension. Like, so if it is a very large median lobe, in those cases, should we go, yeah, there's something.
So if it is a large median lobe, more
Sometimes it
than
is totally intravesical growth.
intravesical, we consider it as a like we can give a treatment for at two sites, 1 centimeter from the media bladder neck.
Sparing bladder neck.
Yes, sir, sparing the bladder neck.
What is depth of penetration? You can, it is possible to change or it is fixed depth of penetration.
Pardon, sir?
The depth of penetration is fixed or you can.
Yeah, it is fixed. So normally what I do when the needle is inside, I make a tilt with the scope so that it
can vary.
maximum needle goes inside the prosthetic tissue. So now I place a 16 number catheter.
Is there any way of monitoring whether your needle has gone properly and whatever necrosis had to happen is going to happen? Any way of
So
monitoring
there
at
should
all?
there should not be any leak of the vapor. As you saw in the first treatment which I gave, there was some amount of leak of the water vapor.
Okay.
So we try and avoid such kind of leak inside.
And how long would you keep the catheter?
Catheter I normally keep for about 7 to 10 days.
Okay. And almost all patients start voiding after this period, or there is a subset of patients
So
who fail
there
to
will
void?
be no, initially there will be a little bit of burning and bleeding at passing urine. So I normally give up alpha blocker with 5-alpha reductase inhibitor.
Dr. Shreyas, what is the ideal size of the gland? Is it equally good for very small glands or very large glands?
So the gland size about ranging between 30 cc to around 80 cc is ideal for a resume procedure. So this patient, he is a young 57-year-old, and he's an good candidate for a resume because he is sexually active and he wanted to preserve his retrograde ejaculation. Another set of patient where there is if the patient is like has undergone unfit for surgery or elderly patients who are unfit for any kind of anesthesia, so we can do this under prosthetic block.
Any possibility of damaging the ejaculatory duct openings or the terminal end vasa if you are very close to the verumontanum?
So I normally tend to go stay away from the verumontanum. So I have not seen any injury to the duct as such.
Do we have follow-ups like if later a patient needs more invasive treatment like TUR or something? Does it make any difference if he's undergone this procedure earlier?
So procedure earlier before the resume therapy.
No, procedure following this.
Following this, so
Had this earlier and now later he needs.
So we have done a good number of cases at our center. The literature also says the retreatment rate is about 4 to 5%. So in our center, we have done one who required an additional treatment. He has a large median lobe, but his prostate size was about 61 cc. We did a TURP on him after about 6 weeks because he had a retention again. But otherwise, on ultrasound, his prostate size has reduced, but the median lobe was still persistent. So for him, we had to do a TUR.
Dr. Shreyas, nice presentation. I have one question, like for a younger patient, as you are saying, relatively younger. So suppose if it is a small gland, 30, you are saying you are taking 30 to 80 grams. If it is 30 grams gland,
yes.
So it is usually considered there is more dynamic function is there. Dynamic component is more there. So that is definitely with bladder neck. So that part usually we sparing. So is this subset of patient is responding well, or there is some outcome is different?
So,
do you have some data or some experience?
yes, in such patients, we had a 47-year-old patient where his prostate size was 31 cc gland, and we had done single treatment on each lobe. So what happens is the prostate tissue, when it shrinks, it tend to open up the bladder neck as well, and we put him on alpha blocker for a brief period, about 6 weeks or so. So they might improve with that this thing. So
Dr. Shreyas, can you listen to me?
yes, sir.
Well demonstrated. I would like to ask one more thing. Do
Yes.
you think one indication is in a young patient who want to preserve his sexual activity? Second is the unfit patient. Third, can we add that I have done large gland TURP and some apical lobes are left, which is causing a poor flow. And I just ask him to come in as an office procedure and do a resume and send him home with the Foley. Do you think it is the
Yeah, we can do it. If the residual gland is still there, we can do a resume on such patients.
such patient will be helpful, or it is just a desperate indication?
No, they may be helpful because the resume, the water vapor which we inject, it is just confined to the capsule. It doesn't go beyond that capsule. That is the advantage we have. So only the central zone is treated.
So take home message could be: one is young patient who want to preserve his sexual activity. Second is the one elderly who is unfit. And third, you have an easy escape for a urologist who has done a TURP or maybe whole lab, who's left with some apical and get away with an easy office procedure.
Yes.
Thank you. Thank you so much.
Thank you, sir.
Thank you, Dr. Shreyas. Nice.
Thank you. Thank you for having me, sir.
Is there a question?
Yeah. Dr. Shreyas, just one last question.
Yes.
What I believe, basically, though resume is a very nice procedure, we mostly get a good result, say after 2-3 months. But is there any way, because most of the endoscopic procedures on table, we can assess, we can know, yes, we have a complete procedure. We have done, say, TURP, HOLEP, or even Urolift also, we can make out endoscopically, yes, there is an ample, adequate space we have created. So probably this is one of the limitation of resume, that intraoperatively or during the procedure, we cannot assess the adequacy. So what do you think about this?
So my take would be that we measure the length of the prostate, the length of the prostatic urethra, and giving adequate treatment to adequate size of the prostate would be a better option. We can't, yeah, I agree with you that we can't make out immediate effects of the treatment, but the after effects we can assess by doing a adequate targeted therapy for the lobes.
Now, since you have done probably many cases, have you ever gone back doing a cystoscopy, say after 2-3 months, to see really it has created a adequate space for any cavity? Yeah, the fossa. Like we say for a TURP, we usually look a very wide fossa or a HOLEP also. So, well, I think a better assessment will be an endoscopic assessment after, say, 3 months, rather than going for an ultrasound or a Euroflow to see the symptomatic improvement. So that will be probably a challengeable thing in between the other resection or enucleation and as we compare to resume.
Yes. So I have not done except that one case for where I did a TURP after resume. He had shrinkage of lateral lobes, but the median lobe probably it was intravesical more, or I don't know, but that median lobe was causing a trouble for him again. But the lateral lobes were well within this thing for him. But other than that, I have not done any post-procedure cystoscopy as yet.
Thank you so much.
Thank you.
Thank you, Dr. Shreyas. Very nice demonstration.
Thank you.
Can we shift to Dr. Anil Vashle's OT? See what is happening. Are we connected? Hello? Hello?
इसको खोलिए.
Dr. Vashne, can you listen us?
Hello.
Yes, sir.
I'm Dr. Pankaj Maheshwari.
Yes, sir. Dr.
Yes.
Samir here. Yeah.
Samir. Now you see, this is a patient who has undergone TURP around 10 years back. He's come with significant obstruction. When I did a cystoscopy, my first...
Sir, just a minute. We are not seeing any pictures here. Can we see the pictures? Can we connect to Dr. Pankaj Maheshwari's OT? Yes, sir. Please go ahead.
Yes. So I'll just show you what has happened in this patient. So my first opinion was that probably we don't need to do anything. But when I emptied the bladder, okay, I'll just empty the bladder and then show you.
He has undergone a TURP, sir.
He's undergone a TURP 10 years back. He's come with significant obstructive symptoms at this time. With nearly empty bladder, when we see this residual lobe seems significantly obstructing.
Yes.
So patient's right lateral lobe is residual. Left side, he seems to have been resected well, except a small lobe here.
Yes.
Okay. And there is some amount of apical tissue.
Right.
So what do you think? I think we should remove this part of the obstructing lobe.
Yes, I think, sir.
Yes. So I will start with this. Now, in a previously operated patient, sometimes the planes may not be very good, but the principles will still remain the same.
Okay.
So I'll take my first incision here. You can see these small dots, openings that you see. That is between the verimonttanum and the lateral lobe. Go deep here. Then I will take an incision which will go from bladder neck along this lateral lobe, come till here. Then say elevate this right lateral lobe and then come from the roof, maybe from at this level. So at this level, we will join the incision here and just enucleate patient's right lateral lobe. At the end, if we feel necessary, this small nodule would also be removed.
So slightly proximal to Viru also we'll have to go.
Yes, so we will be going significantly proximal to Viru. Our incision will come nearly up till here.
Right, right.
And the verumontanum is there. Okay, so all this tissue needs to come out.
Right.
Ek stool de de bhai.
Dr. Maheshwari, I'm Dr. Pahwa here.
Yes, sir.
So that's really a challenging case. So what workup we have done in this case?
Sir, they have done a urodynamic test. I will ask somebody to say, show the reports online.
Yes.
CMG. इनका यूरोडायनेमिक रिपोर्ट प्लीज दिखाइए. हाँ, उनको दिखाइए वहां पर. Okay, so they will be showing you the, इसको हटाइए, ये प्लास्टिक हटाइए. पूरा हटा दो. नहीं, हटा दो, हमें नहीं चाहिए. हमें कैमरा हाथ में चाहिए. चलिए. So till they show you the reports, let me start the procedure.
Yes, yes.
Please.
Okay. So this would be my first incision site. Ready? Dr. Sab, can the table go down a bit? Table down. नहीं, आप down. I don't want it up. Don't make it head low or head high. You'll let the table go down if possible. Otherwise, don't. Now, for the students, I would want to say here that when you are doing any prostate enucleation, the table needs to be absolutely flat. See to it that the patient doesn't have any head low, because in a head low position, the amount of fluid intravasation would dramatically increase.
So we are able to see the urodynamics of this case.
Yes.
Which shows very poor flow with good detrusor pressure.
Yes.
And
very high pressure actually.
Continue, sir.
So I think we are justified in doing this procedure.
Yeah, looks like obstructive pattern.
Yes,
Very,
yes.
very high pediate and low cumin.
Yes, very right.
So now getting into this proper plane is the most important thing. Once you are in the right plane, the by defocused beam, the adenoma seems to separate very well. So here we have got this incision. I will probably, ये bleeding कहाँ से है?
Dr. Pankaj, can I ask one question?
Yes, please go ahead, sir.
Sir, to such a case, you like to do a pre-operative trust by yourself to understand what is the anatomy? To see the capsule, I mean.
I don't think it will really help me much.
Okay.
Finally, my decision will be based on my cystoscopic image only.
Okay. Thank you.
Just today, somebody asked me when was the last I had to use electrocautery. Chaliye, that is not today now. So now this apical dissection is done. We will go in front of the verumontanum and deepen this to the same level. One of the things which I have found over years doing, say, enucleations after TURP has been usually this plane is quite virgin, because obviously in TURP we do not go to the depth that you would go during enucleation.
Yes.
How much mechanical pressure are you applying, sir?
Not much. So I like the camera to be extremely free on the telescope, on the eyepiece rather, so that this movement becomes easier. In this patient, this movement is getting a bit tough. So here you will agree that the capsule is beautifully seen all around.
Yes, yes.
Okay. So now we will take a bladder neck incision. So now should we take this part also towards our adenoma? So we'll take an incision which goes from here.
Point you highlighted, like in once after TURP, if you're going for this enucleation, you get a very virgin plane. So this is very important. Quite often, if you're going for re-TURPT, that is most of the time very challenging, and quite often we'll end up, because from surface we can land up with capsule penetration and more bleeding. So it looks like that is also a relative indication for maybe enucleation after post TURP. That may be a better after. It looks very clean here, definitely with your expert hands. But otherwise, because if you're doing re-TURPT in TURP, so depth of tissue sometimes it is very variable. So it's always a little bit challenging.
So I'm going slow and trying to see where my adenoma leads me. It's a extremely multinodular type of growth, a very irregular growth. So again, it is extremely important in this situation that I don't use too much pressure. If I try to do blunt dissection, I will break the adenoma in between at places where I really don't want to enter.
Yes.
So the adenoma seems to be going in this direction here. The bleeding points are much more than what I would normally find. So again, here the predominant dissection is happening by the weight of the weight of the scope. So I'm just gradually elevating the scope as I'm coming out. What I like to call it is I convert this incision into a trough. So widen this incision as much as you can. Where does this go? This probably will go in this direction. We can take this separately.
Can we swap to other OT? Dr. Anil sir also started.
We'll come back to you, Pankaj sir.
Yeah,
Yes,
sure,
Dr.
sure, sure.
Can we go to Dr. Anil Vashni's OT, please? OTC. Are we connected to OTC?
Hello.
Hello, can
Anil.
you hear me, friends?
Yes, sir. Dr. Sameer here.
Okay, Dr. Sameer. So we had 4 large stones, 2.5 centimeter each, practically small eggs of a bird. We have pulverized all of them and now retrieved. Now the next step which I am doing is this is the floor which I am creating. So if we look at the view from where I have started,
yes,
and I have not done anything, but at the moment I am simply working at the floor. So the concept initially was that you create a 5 o'clock incision and 7 o'clock incision and remove the median lobe. And these 2 incisions take significant amount of time. So gradually the evolution of laser enucleation has come up. And in this evolution, the thing is that why should we at all cut through the prostate? So when we cut a 5 o'clock incision or 7 o'clock incision, we are cutting through the prostate. And that is what bleeds. So the thought process has all completely revolutionized. So if we look at this, here is the viru, I gave this inverted V incision by the side of it. And if we come out, this is the adenoma distal to viru. This much is the length of the thing.
Yes.
And if we come further out, see that this is the adenoma here and this is the adenoma here. So if we simply keep stretching these two, this floor, so half of our this new orientation is that we have created this floor. If this floor is extending right from here, right up, 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 up. So if we are satisfied with creation of the floor, only thing is the scare of in the mind of youngsters is that we can undermine the trigone at some of this point. So to prevent undermining, one has to reorient. And if we go through the adenoma now, looking here, this is where we have created. So just to prevent undermining in a large gland, one can give a incision at say 6 o'clock when you don't have much of medial lobe.
Yes.
Yes. So this will be marking the proximal limit.
Right.
And then we will complete. So this is the state of affairs and this is the floor which we have created so that one thing is that we are not scared of going down. The other thing is we are not scared of going proximally. And so therefore 2 markings are very, very crucial. And the third will be roof. So we will develop the roof and this is how I'm going to develop. And similar, the way I have developed the floor, similar way I am going to develop the roof. So the whole app I simplified and presented that if you do develop the floor, develop the roof, and 2 lateral lobes are at 3 and 9 o'clock. So that completes the whole procedure. So I think I have, this is the plan. And now I'll continue with the plan.
What happens, sir, if there is a big median lobe?
Yeah, so you go by the side of it. Either you make a small cut because whenever you have a big median lobe, there is a depth.
Yes.
So this depth, once you have made the floor like this,
yes,
there is a very small depth at one of the grooves. So that one can cut, or you can do nowadays N block along with the median lobe.
Okay. Right.
Yeah, so the whole thing will come along with the median lobe.
So, Varshney sir, good afternoon. I'm
Ah.
Dr. Pahwa here.
Sir,
Very nice dissection. Sir, what you will advise, like you are doing in monoblock dissection, definitely this is a wonderful concept. For beginner also, you can say ki they should start with that conventional technique, then they should adapt, or they should start with this. What
No,
advice
no,
you
no.
will
The
have?
beginner has to first understand the laser, that how much is the depth of laser, how much he has to keep the distance, because this concept of en block is practically bloodless technique, because if you are all the time at the capsule and sealing the vessels at the capsule, where will be the bleeding? When we cut through the adenoma, it bleeds. But for beginners, it is advised that whenever they feel confident about the anatomical orientation, then only they should venture into it. Because what happens is when we are doing with 5 o'clock or 7 o'clock, your anatomical orientation is absolutely in your control. So the question is that whenever we do en block, the orientation may be lost.
Yes.
So therefore, the beginners are always advised that until and unless they are confident of anatomical orientation, they should not venture into en block.
Right. Thank you.
Now, here you see, this is the bladder neck area where I will simply just define the trigone. So this will see, here is the trigone. And once you have defined the flush, make it flush with the trigone, then only you will develop it from behind. But this I always call that in a scaphoid shape large gland, this incision and incision from Viru, they are the ones they can be combined. So this prevents undermining of the trigone. Now, if you see, this cutting here is not sufficient. This has to be lateralized. So until and unless you lateralize it, your limit can injure the ureteric orifice. So therefore, if you see, this is the place, this is the trigone, and at this point, one has to be patient enough to lateralize this incision. This is going to prevent any kind of injury to the ureteric orifice. So one has to be liberal and keep on widening this groove. So once you have widened here, this is from practically bladder neck, which is we are widening at the level of the floor. Having widened this, I am sure that we can safely connect this to the lifted floor. Now, this is the adenomatous thing. This now what I am doing is, I am practically going for two lobe technique. Because this is, even at this stage, one can do it en bloc, because had I left it here, I would have done it en bloc. Now, if I cut it and join it, it becomes two lobe. Because here I have cut it and I will cut it at 12 o'clock also. So that, because it's a 102 gram gland, it is always safe that you make it two lobe. For a demonstration, I think it is good that we make it two lobe technique, because you see, this floor which we had developed till here, now this is plane is very nicely coming up, and if you have a defined area at floor, you can connect it very, very easily. Many a times I am asked this question that where you keep the fiber, how far is the distance? Now, if you look at it, if you keep near contact mode, the advantage of this is that if you appreciate, all the bleeders get coagulated, the small bleeders. So that makes the procedure. The other thing is that you have to be slow. Now you will be surprised why I say slow, because Tanuj may not agree with me because he is very, very fast. But the slowness adds to hemostasis. The new machine which has come is Moses. In the Moses, they have done some technical innovation so that even if you are fast, you can have good hemostatic effect. So the Moses effect is something which the machine is very expensive, not good for Indian state of affairs. But some of the medical colleges and some private corporate sector have got this Moses technology. So you can do this job very, very fast. The faster enucleation, better hemostasis. But learning HOLEP means, I always say that it is a game of mindset. I am proud that so many people have picked up since morning. You have seen many operators. They have witnessed and they always say, sir, we have mastered it by seeing your videos. But then this is what we dreamt. Pankaj and myself, we dreamt that this technology must reach to every urologist in India. Unfortunately, the medical colleges and medical institutions are still yet to pick up. Otherwise, I'm sure that during your MCH and DNB programs, this HOLEP will find its place as it is now. Robotic surgery is also catching up fast. So the future belongs to, because this is another question which I am asked, that if even after 20 years it has not been adopted all over but the thing is that the learning, there is definite learning. You don't have to perforate, you don't have to enter the adenoma, and still you will be surprised that I am simply widening the floor. So this is all the floor business. So this on this side also, we are just widening the floor, and we keep on widening till we reach 3 o'clock. You will be left with only 2 mushrooms at 3 o'clock and 9 o'clock at the end of the whole procedure. Any questions, Dr. Pava?
Very clean, clear-cut, nice design. It's like the same plane which we used to do with for open enucleation. This is, I think, basic philosophy which we are using.
Basically, the endoscopic variant of enucleation.
Yeah.
And here, the point, many times we are asked this question, that how it differs from bipolar enucleation and thulium fiber enucleation. So this is something which I want to emphasize, that you will appreciate that I am using fiber and my sheath is being used as a retractor.
Right.
At no stage I am pushing, or mechanical force is zero. If we use thulium, you saw Dheeraj in the morning, he did a wonderful thulium fiber enucleation, but some degree of mechanical pressure was there once he has reached the correct plane. And if you do bipolar, it is all mechanical pressure. So that is what one has to safeguard. Now, having done this, I think we have adequately developed the floor on both the sides. And even in this case, we have done this 6 o'clock in season, which we could have avoided. Now, another thing which is very important is this 12 o'clock tissue. Now, many a times you have lot of 12 o'clock tissue. So one has to understand that how much to leave and how much to preserve. Now, if we come back to Viru, this is Viru, and if we come back here anteriorly, this is our sphincter. Now, the technique is you go 5 mm proximal to the sphincter, and this is where we have to give one small incision, mucosal incision proximal, that prevents us from going deep, going distal. So this incision on both the sides, I call it a butterfly incision, wings of the butterfly. So if you have on both the sides, the adenoma is a spherical structure. So if you have a spherical structure, means your movement of hand has to be in that 180-degree opposite to the spherical movement. So if you are moving like this, you are likely to leave, we call it artificial viru. So what I am going to leave is an artificial viru somewhere like this. This is a small stone which is troubling us, settled by fragmentation. But if you look at it, on this side, we have created one part of the wing. On this side, Also, I am going to create the other wing of the butterfly. So this is a mucosal incision, and this is what prevents any kind of stress incontinence until and unless there are certain factors beyond.
Yeah, sir, there is a question from the audience.
Yes.
Dr. Mayank wants to know what are the laser settings that you're using?
This laser setting at the moment is very low, that is 25. 25 is the coagulative setting. Why I have made it 25 is that because precision is required. So if you have a higher setting, with this precision you cannot work. This is the degree of cutting and coagulation to preserve. And the other thing is that we are working near the sphincter. So if we are working near the sphincter, and the job is that we are leaving, we have to create this artificial viru anteriorly. So this is how I am creating this artificial viru, and see the adenoma. If you are moving anteriorly, the adenoma is falling. So which also proves that you are in the correct plane. So this is the movement which
Do you
will
change your settings in between, or
yes,
they're constant?
yes, yes. No, no, no. We keep changing. Only this mucosal cut I am going to do with this energy. And having done this, now I am sure that we have done enough. We can increase the settings. So the other setting we will go, and you see with this is a higher setting, and at higher setting the bleeding starts.
Sir, what is the fiber size that you're using?
This is 500 microns, 550 microns. So if you have a 550 micron fiber, and this is the mucosa. Now, having given a proximal incision just proximal to sphincter, the other area is that I want to leave this mucosa. Now, if I have to leave this mucosa, I have to cut somewhere here. So this is another thing which will developing the roof. So in developing the roof, this is the other incision which I give like this, and try to reach the way we reached floor. Similarly, we are going to reach the roof here. Now we have got the transverse fibers. So having seen these transverse fibers, this movement of hand is very, very important. There is no jerky movement. The hand is stationary, and you can appreciate the way I am detaching the adenoma from the capsule. The identification is that capsular fibers are transverse running and fluffy is the adenoma. Now this similar thing we are going to create on this side. So we'll go anteriorly till we get the capsular fibers. So see, now anteriorly the tissue is very less. So if the tissue is very less, one has to explore that when are we going to the capsular fiber. Now we are getting the capsular fibers. So this is how we have to define and reach. Now adenoma is very, as I told you, spherical, or it could be oblong or abnormal in shapes. So one has to see that where it is going. Now if this is our bladder neck, this is how we have to develop the roof. And this process of developing the roof has to be extended right up to the incision which we have given proximal to the sphincter. So halfway, I always say that one does not have to be fixed in ideas that one has to do a retrograde or an antegrade technique. It is the most good for beginners is that you come from bladder neck to mid fossa and come retrogradely from this thing. So now this is how we are developing the roof. Can you appreciate the little bit of dubbing of tissue
Yes,
here?
very right.
And this is how we have developed the roof. Now still the roof is not fully developed. Why I say not fully developed? Because we have to see the incisions that we have made this proximal to the sphincter. Now if you see, this is the viru here. This is the lobe one, this is the lobe other, and this is where the sphincter is. So this is the sphincter. And if we go proximal to the sphincter, so our action should be This is our artificial viru. Can you appreciate this artificial viru which we have created?
Yeah. So there is another question from the audience.
Sir.
Now what are the laser settings? 25 was fine for that upper pole mucosa.
Yeah.
But now you have, yeah,
Now it is 60.
60. Okay.
Now this all depends upon the kind of prostate you have. So if you have a soft prostate, vascular prostate, you can work with 60. If you have fibrous gland, you can go to 60, 80, 100,
So
or
what-
even more.
How much of it is hertz and how much is joules?
This
60 is what?
60 is this thing. Hertz is 30 and the joules is 2.
Okay.
So that is the proportion.
Yes.
But we always vary according to the type of prostatic tissue we have. So we can do it if it is not cutting well, we can increase the energy. The machine has the potential to go up to 3.5 joules. So if it can go up to 3.5 joules, so one can also test. I always say for that the way you drive the car, you have to know the roads. So if your road is good, then you can drive at any speed. So you have to, here you have to define the road as well as you have to define the speed. So it is all in your hands, how you define the road and how you define the speed. Now, if you appreciate in a demonstration, it is always good to keep it on a 60 because see, I want to show you that if in the right plane, this is how it falls. Can you appreciate the adenoma? I'm just gently pushing, but I'm not pushing much because the more you push, more it will bleed. So the whole game of pushing is related to the bleeding, and then you have to coagulate the bleeder. So
Ashish sir, we will take permission to go another OT for a few seconds, then again we will come back.
Sure.
So can we connect to OTB? I think Dr. Maheshwari is altogether completing the procedure.
Am I there?
Sir.
Yes,
we are
I'll
back.
just show you what all I have done. I have separated this adenoma all around here. I was about to disconnect it at this level, but again, for some reason, my machine has stopped. Okay. So this has been separated all over till the bladder neck. Okay. So now it is this connection. I need to separate this connection from here, get into this plane and keep on separating the adenoma. So at all places, we are not on capsule. You see, there is some tissue still here also. But my plan at this time would be to get the major chunk out so that then I can concentrate on the smaller tissue later on.
Okay.
So I can see the capsule here, but there is some adenoma on this side. So probably I could do a course correction and come from here. Sadly, not a case for demonstration because not only this is a huge gland, this is also a very, very nodular gland. And your slight pressure breaks the nodules and you tend to get between the nodules. But the principles remain same. I have to identify capsule and be on the capsule.
Right.
Don't worry about these such small bleeders that come up. Once you elevate the tissue, those bleeders will stop on their own. So here we are probably at the right plane at this place. Okay. We'll come back on this side and restart our separation of the adenoma. So I'm quite happy with the capsule at this place. So are you with me and that this is a well demonstrated capsule?
Yes, much better.
It is important that I should be able to get under the adenoma properly. And it needs to get separated all along. You see, if it remains attached at some place and you continue to dig in between, then you would be lost in the plains. So there we can see the capsule very, very beautifully. Let's get under the adenoma again.
Even the bed of the adenoma looks uneven in this case.
It is very, 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 very uneven. So to identify where exactly I need to go, it is taking a bit of time, but anyway, we are moving well. And my primary aim will be to get rid of a major chunk of tissue.
Yes.
So smaller tissues, adenomas that stay behind, we'll take a call at the end, one, whether we really need to remove them. And then removing them is not going to be a difficult job. Haji? Can I say something about you? Okay. You see, I always am convinced that you are Raj Kapoor of Urology Society of India. No, I have made you a showman. And a person who is surrounded by. No, I have always loved your work.
Pankaj sir, we need to move on.
Yeah,
This thing is waiting
please,
for you.
please.
We are watching you. A tough case, but a very nice job that you are doing. And a redo case is always difficult, but we all appreciate it.
Hello, just a second, just a second.
Yes.
I have a question here. I'm Adhika here. I see it was the laser fiber and developer.
Relatively better plane.
Now Malik sir has given some tips, so maybe things will improve. So, all right, sir, we'll keep watching you. Fantastic job. A big round of applause from the audience for this case.
Thank
you, sir. And we'd like to invite Dr. Rohit Kaushal to demonstrate a semi-live presentation on truss-guided transperineal stabilized fusion biopsy for prostate.
Haji, I think it is just a matter of your
A very good afternoon to everybody.
I'm more
At the outset,
comfortable.
I'd like to thank the organizers for giving me this opportunity.
Huh.
So I'll be speaking on the transperineal fusion biopsy prostate. So as we all know, prostate biopsy is a cornerstone for all the diagnosing prostate cancers and mostly performed transrectally as of now in most of the centers still. And since inception, the prostate biopsy techniques
right.
have actually changed
Absolutely.
by adapting new technology and
Can
discoveries.
we mute the OT, please?
So
absolutely,
the PROMISE trial and precision trial, they were very well informative on the role of multiparametric MRI before a biopsy. Now, moving on to the approaches of
No,
biopsy.
I think मेरा audio बंद कीजिए वहाँ disturb हो रहा है.
So now coming on to the approaches of prostate biopsy. So broadly, we have the transrectal route and the transperineal route for biopsy. Within the transrectal, the finger-guided biopsy is one of the biopsies which were being done and also being done today also in very hard nodular diffuse prostate, in which we don't require any ultrasound guidance or in fact any fusion biopsy. Next is the standard 12 contrast guided biopsy, and currently we have the MRI targeted biopsy. So the MRI targeted biopsy through transrectal can be performed either by a cognitive registration fusion biopsy or by a software assisted fusion biopsy or by in-gantry or the in-bore biopsy in the MRI suite on various platforms like the Artemis or the BK5000 machine or by the Euronav. Now coming on to the transperineal biopsy, it is mostly performed either by the freehand technique or by the stabilized technique. Within the freehand, we have various attachments or devices through which we can do the freehand biopsies, mainly like the precision point device, the coaxial needle, or the biopsy needle guide. Within the stabilized version, we can do either by a grid template based or by a robotic platform. So I'll just skip this literature. I'll come to the video. So these are the devices which are usually needed for a freehand transperineal biopsy. The first one is the precision device, which fits onto the probe and through which a needle can be passed onto the each side of perineum. And there's a single entry point on each side of the gland through which the biopsy needle can be traversed and multiple courses can be taken through this device. The next one is a coaxial needle, which doesn't need any precision device. Simply 14 or 16 gauge cannula can be inserted and through which the biopsy needle can be passed and biopsy can be done. Or the other attachment can be biopsy needle guide, like you can see in the last figure. Now for the stabilized transperineal biopsy, we are using the BK 5000 machine, for which we need these hardwares. The first one is a stabilizer, which actually fits onto the operating table. The next is a stepper, which fixes onto the stabilizer, and the grid, which is placed on the perineum. So for transperineal biopsy, typically we need a biplanar transducer. As you can see in this figure, it has a transverse array as well as a sagittal array. So now, what are the limitations? Most of us are actually doing today the cognitive fusion biopsy. What are the limitations of cognitive fusion biopsy? All the MRs are done in the supine position. So MR orientation is mainly in the supine position. The prostate orientation differs in every patient, number one. And when we do actually doing the biopsy, patient is either in the lithotomy or the left lateral decubitus position. So the orientation of prostate changes. So to counteract this problem, the fusion softwares have come into play, and through this software, we can actually reorient the prostate and match the actual prostate orientation when the patient is lying in the lateral decubitus or in the lithotomy position. So like you can see in this figure, so the supine position, the MR, the prostate is visualized in the left-hand side. When we reslice and reorient the probe, it becomes the orientation of the lesion changes. So by utilizing the predictive fusion, which the recent software fusion offers, we can actually reorient the prostate gland and match the actual orientation of the prostate in the left lateral decubitus or the lithotomy position. So I'll be showing my video in short. So we utilize the BK 5000 ultrasound system, and we do a transperineal stabilized biopsy. So it has two portions. One is the workstation, which we do in the backhand, in which we do the contouring and the reslicing of all the images, and we save a tentative biopsy plan. And then this tentative biopsy plan is actually stored onto the BK ultrasound system, and then we move on to the OR setup. So in the workstation, the first step is importing the MRI images onto the software, which is a MIM Symphony DX software. This is a dedicated software installed by the BK company on our desktop, on which we import all the MRI images, and then we get all the sequences which are stored in the DVD of the MRI. So on this, we typically choose these sequences, the DWI sequence, the apparent diffusion coefficient, ADC, the axial T2, and the coronal T2, out of which the most important for contouring is the axial T2 and the coronal T2. We may or may not choose the ADC and DWI. It doesn't matter as far as the contouring is concerned, but just to complete the list, we need at least these 4 sequences. So the first step is contouring and marking of the region of interest or the suspicious lesion. So for this, we select, like you can see in the left-hand side, we have the prostate, lesion 1, lesion 2. So accordingly, whatever we are contouring, we just mark it. And on the right side, you can see the marked contour of the prostate. And in pink color, you can find the lesion on the left anterior transition zone. And we correlate this with the coronal sections as well. So now the typical feature of this reslicer is that there's a virtual probe, like you can see in the left-hand side. This virtual probe is repositioned to orient along the rectal axis. So the probe is tilted along the axis of rectum so that the prostate is reoriented according to the patient position, like in lithotomy or in left lateral decubitus. And there's a virtual grid, like you can see on the left-hand side lower diagram, there's a virtual grid which is actually the replica of the actual grid which we'll be using during the transperineal biopsy process. So now once the contouring and the marking of the region of interest is done, the biopsy plan is made and stored onto the database on the desktop. This biopsy plan is then transferred through a portable device, either USB or a hard disk, and this is imported onto the BK5000 ultrasound system. I will be showing the video shortly. So this is a whole video of how we do the actual contouring. So there's a dedicated MIM Symphony DX application, which is installed on a desktop. The MRI images have already been loaded onto this software. So we select the desired patient. So upon selecting the desired patient, we get all the sequences which are stored onto the DVD of the patient. Out of which we need to select the most important sequence, which is the axial T2, the coronal T2, and ADC and DWI. Yeah. So upon selecting all these sequences, so yeah. So now you can see on the left and top, we are having the axial cuts. Below that, we are having the coronal cuts. On the right side, we are having the DWI and the ADC sequences. So we go on to the axial cuts, we scan, and we see whether all the sequences are present. Then we begin a contouring of the prostate. We also check for the coronal cuts, whether all sequences have been imported adequately or not. So we then move on to the axial cuts once again and start our contouring process. So we start contouring right, starting at the base. If there's a median lobe, we have to include that median lobe as well. So we do the contouring on every alternate sections and finally interpolate all the sections together. Like you can see, we have included the prostate on the alternate sections. So finally, we interpolate all the slices and then the whole prostate is actually contoured. As you can see, from the apex to base or base to apex, we have included the whole of prostate in all the sections. We again cross-check on the coronal cuts, whether the whole of the prostate is actually included or there's any fine adjustment to be done. So after this, we move on to marking the lesions, the suspicious lesions, using a 3D brush. So in this lesion, the patient had the first target, he had two targets. First target was in the left anterior transition zone, which was reported to be Pirates 5 lesion. So after thorough discussion with the radiologist and getting a mental picture of the lesion, we do the marking of both the target lesions. So this is the contouring of the first lesion being done on each sections till the lesion is extending. So over here, I'd like to stress that we have on the MRI, we have the number of sequences, like the sequence number 14, 15, 16. So we discuss with the radiologist, we see where the lesion is, we make a mental image, and also at the same time, we note down the sequences in which the lesion is present. Like for example, this lesion is extending from sequence 14 to 18 on the MR plates. So we similarly, we mark the lesion on from 14 till the 18 on that location. So this patient had two lesions. One was in the left anterior TZ, and the second lesion was in left peripheral zone. You can see in the video the large peripheral zone lesions. So this is the second target. So this also is being contoured in the subsequent cuts. So finally, it is being checked on the coronal sections. After doing this, although it is not strictly mandatory, but mostly I mark the urethra as well for the orientation purpose during the actual biopsy process. So on the coronal cuts, in which we can see the entire extent of the urethra, we do the contouring of the urethra as well. And we can see this on the axial images. So now this is a very important step. This is known as a reslicing. In this, you can see there's a virtual probe, and you can see the prostate contoured, and there's a virtual grid on the right side. So we actually reorient this virtual probe along the long axis of rectum so as to orient the lines, as you can see in this video. First, we reorient it along the axis of rectum. Then we position this, I don't know if you can see, there are two lines. There's a one gray line just beside the probe, and there's a dotted blue line on the top. So we have to place a dotted blue line just below the upper border of prostate and the gray line behind the prostate.
Dr. Rohit, can you just pause for a few seconds? Dr. Vashne is about to finish the case. We'll take closing comments and come back to you. Sorry for that. Can we connect to OTC, please? Dr. Vashne's OT? Hello?
Hello, can you hear me?
Yes, sir, we can hear you.
Okay, so now I think this is the Viru, and this is what we have done the distal to Viru. See, this was the tissue this much distal to Viru, and this is the sphincter here. So this should be appreciated that we have precisely separated the adenoma from the sphincter and the Viru. And see the sphincter here, and this is the length of Viru which is there. Now, this is the left lobe. While we were having the talk, I have completely enucleated. And this is the artificial Viru which we had created. And if you look at the this other lobe, this also the floor we had developed, this. And now we have reached right up to, I would say, 10 o'clock. And this whole adenoma, the one of the adenoma is sitting inside, floating inside. And the other adenoma is just near to be thrown inside. So we have done the dissection right everywhere in the capsular plane, no perforations, simple stretching of the capsule at some of the places, and the sphincter is completely intact. So this is just
very well done, sir. Very well done, sir.
So
We can
thank you, and you can continue with the.
Can we have a round of applause
great,
for Dr.
great
Vashne,
job,
sir?
sir.
Excellent
Great.
job.
You can hear great round of applause.
Okay, thank you everybody.
Thank you, sir. Thank you, sir. Yes, Dr. Rohit, you can continue, please. Can we have the audio back for Dr. Rohit? Audio for
audible? So like you can see, this is a virtual probe on the pointer, and this is the gray line, which you can see. And this is a dotted blue line. So this gray line has to be just posterior to the posterior border of the prostate, and this blue line, dotted blue line, has to be just below the superior surface of the prostate, so that the entire prostate comes within this virtual grid. This virtual grid is a replica of the original grid which we'll be using on the patient. So after doing this reslicing process, we check that the entire prostate is within this grid and equidistant from both the sides. Yeah, so you can see the lesions over here. And this markings on the grid, 1, 1.5, 2, 2.5. So they adjust this virtual grid such that the lower border of the prostate is just above the 1.5 line. The relevance of this I'll be telling you on the video once I start with it. So after this, we save this tentative biopsy plan onto our desktop. You can see the lines 1, 1.5, 2. So this has to be just above the 1.5 line. So this is saved as a biopsy plan on this software and then onto the desktop. So now you can see the biopsy plan is saved on the software database. We again check it. This is finally saved on the desktop. So now coming to the actual biopsy process, how do we do it? So the patient is placed, we do all our transperineal grid-based biopsies under general anesthesia as of now, because we want absolute patient rest, no movement at all. So patient is placed in a social lithotomy position with the scrotum lifted up and strapped, like you can see in this figure. The local anesthesia is infiltrated for post-op pain relief, as you can see this figure. These are all the hardware which is involved in the actual grid-based template biopsy of the prostate. So this you can see is the actual stabilizer, which is mounted onto the operating table by the side on the side rails. And this attachment is the second attachment, which is attached onto the stabilizer, on which our stepper would be mounted. So this is the complete setup of this stabilizer. This is the stabilizer with two controls on the left and right side, by which you can control the stabilizer to and fro, right and left, rotatory movements, everything. And this is the actual stepper, which actually controls your ultrasound probe to and fro and right and left. So this you can see, we have control over the stabilizer, and the stepper is mounted onto the stabilizer. On the stepper, we have a cradle on which fits our ultrasound probe. So this is the stabilizer, this is the stepper. Now, the biopsy plan which we had saved onto a desktop, we import those through a pen drive onto this ultrasound system of BK5000. Once it is imported, we get these sequences. The biopsy plan is over here. So this is a short video how we actually do the process. So this is the preparation of the biopsy trolley. We take, depending on the number of the suspicious lesions, we take extra course, and we take 8 systematic course. This is the grid which we'll be using during the biopsy. You can see the label. So we use this side of the grid. Just a second. Now, in transperineal biopsy, we typically use this barred biopsy gun, which is 18 gauge, 20 centimeter in length. Initially, we were using 25 centimeter, but over a period of time, we have found that using the shorter length of needle gives less wobbling of the prostate in the biopsy. So we have modified the length of the needle. Initially, we were using 25, now we use a 18 gauge, 20 centimeter needle. So this causes less wobbling and hits the target exact at the point. So you can see this is the stabilizer which is mounted on the side rails of the operating table. Yeah. So once the biopsy plan is imported onto this system, we get two options, transperineal and transrectal. So we have both the provisions of transrectal and transperineal fusion. So once we load this data on the system, we select the transperineal. If you have to do a transperineal, we do transrectal if you have to do a transrectal fusion biopsy. So moving ahead, this So this is a stabilizer. And this is the biplanar ultrasound probe which we used during the biopsy. You can see the sagittal array and the transverse array. So using this knob, we can control our stepper movements. This is the actual stepper.
Dr. Rohit. Dr. Rohit, can we move it faster a little?
Actually, the video, there's some hitch in the
Yeah,
video.
I understand,
That
but
is the
just
problem.
forward it a little.
Yeah. So this is the actual stepper, which has a cable which is connected through an USB port onto the system. So it mounts the electronic device which actually senses the fusion process. And the top one is the on which the stepper is this mounted onto the stabilizer. So this is a stepper on which the grid is mounted, and then the grid is placed on the perineum. So these are small knobs which can control our Z, X, and Y axis movements in different planes. So the probe is prepared with the ultrasound jelly and the condoms. And this is the pointer which actually fits onto the slot on this stepper. This is the cradle of the stepper on which the ultrasound probe is mounted. And it is latched. So the probe is inserted into the rectum under vision. And this is the stepper knob by which you can control the to and fro movements of the probe. As you can see, the real-time ultrasound images which you can see on the axial section. So we scan the prostate from base to apex. Then we fix on the grid onto this stepper. And it is fixed firmly against the perineum. So after fixing, we fuse the MR images with the real-time ultrasound images, and we check in the sagittal sections. You can see the targets, one in pink. And this, the pointer is the probe position. And green is the urethra. So exactly we mark the coordinate, and we insert a needle in this exact coordinate. And in the sagittal section, the top, you can see the needle piercing through the prostate. This is the pubic arch. And this is one of the coordinates through which we take the biopsy. And this is finally marked using green pointer. The second lesion is over here. So similarly, we repeat the process for the second lesion as well. So this is a post-biopsy picture you can see. There's absolutely no bleeding. This is a final report which is generated and handed over to the patient. You can see the prostate contour. This is a lesion and the number of biopsy cores we have taken from each lesion. You can see on a 3D as well and this lesions. So this is given to the patient, and you also generate a report at the end in which you can fill in the final biopsy report. Thank you.
Very nice. Thank you, Dr. Rohit. Just
you.
brief question.
Yeah.
How much does it cost to the patient to get this biopsy done at your center?
It costs approximately 75,000 for the transperineal general anesthesia.
Okay, and this includes a systematic biopsies plus targeted biopsies?
Yes, we take 8 systematic cores and extra 3 to 5 cores on each target lesion.
So I think we'll close this session. Yeah.
So basically, any type of whether the lesion is in the anterior or in the apical region or in anywhere else, we can do transperineal biopsy safely. There's no such indication which transperineal scores over transrectal. All the indications of transrectal we can do as transperineal as well. There's no differentiation as of now. But yes, for if the patient is a very anterior lesion, large gland with very anterior lesion, I would rather prefer for a transrectal than transperineal because the pubic arch comes in way, and many times it's difficult to pierce the needle through the arch or under the arch and hit the lesion. So for very anterior lesions, yes, transrectal scores over transperineal. A stabilized version.
Any other questions from the audience? So
So it's very enlightening presentation. Thank you. Thank you very much, dear.
We have another biopsy lined up while these cases are being finished up before the next cases start in the OT. There is a freehand biopsy demonstration also by Dr. Karandeep. So we can have that at this point.
So we invite Dr. Karandeep for the counterpart, transrectal biopsy, trust guided.
Can I have my presentation? At the outset, I'd just like to thank the organizers for giving me this opportunity. Um, I would just like to say in the beginning that I was under the impression until 3 days ago that I would be doing a live demonstration. And I was just told about the semi-live demonstration. So all these videos, I would like you, if you could excuse me for their quality, because I have essentially borrowed almost 80% of the videos from my friends. So I will present it as a case format. It was very interesting because yesterday and day before yesterday, I was going through all the literature that is available. And if you see in the West, almost everybody has moved away from transrectal biopsies and has kind of shifted to transperineal biopsies. But I feel, especially in our country with our socioeconomic and financial conditions and the inavailability of transperineal everywhere, transrectal still plays an important role. So this patient is a 65-year-old male. He's hypertensive. His PSA was 24. And on MRI, he had a Pirat's 5 lesion in the right peripheral zone in the mid part. So for any patient who is about to undergo a transrectal biopsy at our center, we usually have a perioperative checklist that we follow, where we usually make sure that the culture is sterile. And we always give antibiotics, which we start 1 day prior. Usually preferred antibiotics are fluoroquinolones. On the day of the procedure, we advocate the patient to have a light breakfast, and an EMA is given almost 2 hours prior to the procedure. The routine investigations that we always do in these patients are PTI and our viral markers. And in case patients who are on antiplatelets, we have to stop them prior to the procedure. So this is the machine that we have at our setup. It is the BK machine, and this is the probe. It is a 7.5 megahertz probe, and it has an attachment with it. So this is the attachment. The attachment that we have is the side firing attachment. So when you prepare this probe, the first thing that you have to do is that with sterilium, you have to sterilize the probe properly. And then we apply a condom on the probe. And then we apply the attachment, the side firing attachment. Then we apply jelly and another condom on the probe. Just for the sake of presentation, the probe also comes with an end firing mechanism, which is helpful in doing biopsy of lesions which are at the apex. So the position, we already know what the position of the patient is because it is done quite routinely, trust biopsy. It is very important that you do a DRE right before you do the procedure, because you don't want any surprises in the procedure. You don't want to encounter any surprises. So after we've cleaned the parts, we drape the patient. I usually instill betadine into the rectum as well. So this is just a short video. So the biopsy gun that we use, as sir has said, is the BART 18 gauge gun that we use. We use the 22 to 25 centimeter long gun, and it has a side firing mechanism and an end firing mechanism. So this is the side firing mechanism, and on the back of the gun is the end firing mechanism. So this is where the core comes. It's about 18 to 19 mm, and the markings that you see on the needle are the centimeter markings of the needle, so you know how much you've gone inside. Now, to load the biopsy gun, you have to press both the knobs, because if you press just a single one, it will not fire. So you can use either the side firing or the end firing technique, and this is where the core will come. So So in our machine, we have a guide as well. So this helps us to kind of know where the needle is going. Now, we usually also give a periprosthetic block in patients because we find that this makes the biopsy procedure more tolerable. And especially when you fire the gun, sometimes what happens is that there are jerky movements that the patient can make, and this hampers in getting a good biopsy. So usually the periprosthetic block is given at the base where the prostate meets the bladder and where you see the seminal vesicles. So this is just to show how the marker appears. Now, so this is, so you've got to understand when you look at the image on the ultrasound, the right side is actually on the left for you and the left side is on the right. So this is how we inject the local anesthesia on the right side. You need to see the tenting in the rectal mucosa, and it's very important that you just give the local anesthesia when you see the tenting, because sometimes if you go too deep and you give the anesthetic agent, it will hamper with your vision and your ability to take a correct biopsy. Now this is giving on the left side. So you can see how it opens up the space between the seminal vesicle and the prostate. So now, after we've put our probe inside, first we do a scanning ultrasound, where what I usually do is I go up to the bladder, and then this is the axial section and this is the sagittal section, and then I look at the prostate as a whole. So you've got to understand that the left side is the right side and the right side is the left side in the patient. And so you go up to the bladder, you visualize the seminal vesicles both on the right and the left side, and then you gradually make your way down to the apex. So here you can see that there is a lesion on the right side, a suspected lesion. And what we usually do is we do 12 core systematic biopsy, and we do targeted biopsy of the lesion as well. So now this part here, which you can see very well, is the peripheral zone of the prostate. And as I have shown here, this is the peripheral zone of the prostate. And in the center, as you come down, you will be able to appreciate the urethra better along with the fibromuscular layer along it. So this is when you come down, you reach up to the apex. So always do a scanning ultrasound of the prostate. And then this is, we are looking at the suspicious lesion that is there. So this is the entire prostate. And then we can go from right to left. In case of patients who have a catheter in situ, the urethra is very well seen. But as this patient does not have a catheter in situ, the medial and lateral lobes are based on after we do a scanning ultrasound of the prostate. So now coming to the biopsy. So first, I usually do a biopsy at the base, where I prefer to do it from lateral to medial. And you can clearly see after you have selected the point in the lateral area at the base where you want to do the biopsy, you fire it and you can see the needle actually going into the prostate, and then you take it out. It's very important at this stage you have an assistant on hand who can collect the core promptly. And then you move to the medial side and you take the biopsy of the medial side. So after you've done this, then you bring your probe down, you go to the mid gland level, and then similarly there on the lateral and in the medial side, you take a biopsy. After that, we bring the probe further down up to the area of the apex. Now, I have a side firing biopsy there, so I use this. But in some centers where end firing biopsy is available, the apical region can be done with that as it gives a better sample. And then you can take the targeted lesion biopsy as well after you've done this on the left side. So, post-procedurally, we usually place a povidone-iodine soaked gauze per rectally, and we ask the patient to remove it after 4 hours. And the patient is asked to get up from the bed very slowly because these patients generally have syncopal attacks right after you do the biopsy. And they are explained about having blood in urine and while passing stools. But if this persists beyond 3 days, it's always better to evaluate them. And always keep the patient with you till the patient has not passed urine. It is better to send the patient and warn him of the signs of urinary retention. We usually continue antibiotics post-procedure for 3 days. And there is always a chance that the patient might develop sepsis. And for that, it is always necessary to hospitalize the patient. Thank you. I would like to thank my junior
Thank you,
Supreet,
Dr.
Shrey,
Karan, for very nice presentation. So where do you find perineal biopsy is now trending well? So where you find this is still mandatory, or you can say it is inevitable, like we should, what is your take home for?
Sir, honestly, I don't have much experience with transperineal biopsies. And all the biopsies that we do at our center are all transrectal biopsies. But I do believe that of transperineal biopsies do have a role for patients who are who have a positive urine culture or say have anterior prostate biopsy, prostate lesions. There definitely the transperineal biopsy is better. In the West now, almost practically they have gone from transrectal to transperineal.
You use fluoroquinolones as your preoperative prophylaxis.
Yes,
Do you
sir.
think that's enough in current age?
Sir, some patients do require a combination, and but as our practice, we've continued with fluoroquinolones only. But yes, some patients do require an
Because
extra.
the resistance levels have really gone up for
Yes,
quinolones.
sir.
So time to probably
Ideally, you
augment
should
the
have an antibiogram for each hospital, which should be followed.
Okay. Thank you. Thank you, Karan.
Thank you, Chairpersons. We come to the conclusion of this operative session, and now we are ready with the last operative session of the day, where we are going to have HOLEP being done by Dr. Devendra Sharma and robotic prostatectomy being done by Dr. C. Malikarjun. For this session, may I invite the chairpersons, please, Dr. Vijay Bora, sir, Dr. Sailesh Shah, Dr. Atul Mittal, and Dr. Gurpreet Singh Bhangu. So we can have last comments with Dr. Pankaj Maheshwari and Anil Vashne, then we'll shift to the next surgeries being done. Hello, OT. Dr. Pankaj? Hello?
Hello. Dr. Pankaj Maheshwari is OT. Pankaj? Hello. Can we communicate with you, Dr. Pankaj? I think he's not connected with mic.
जरा देखिए भाई हमारी आवाज आ रही है?
हाँ, आवाज आई अभी.
आई सर ठीक है. So sir, if I have completed my procedure, that's the verumontanum. All along we have completely removed the adenoma. It was a fairly challenging case. The two big adenomas are there in the bladder, and now I'll start morcellation. The orifices are far away.
So you think a complete enucleation has been done or any part is removed?
No, sir, near complete, I would say, except this area, there is some tissue remaining here at maybe from 12 o'clock to 10 o'clock, but otherwise the fossa looks fairly good.
So you are planning to do morcellation now?
I will be starting morcellation now.
Okay, which morcellator you use?
I have had a biorad morcellator.
Okay. Is that the same? which
Sorry,
you-
I have got a UF morcellator.
Sir,
Sorry.
the members of the audience, Dr. Varshne sir is ready to, with his closing remarks. Dr. Varshne sir.
Doctor?
Hello, Dr. Shailesh Shah. Very good evening. Anil Varshne here. How are you?
Yeah, but we can't see your pictures.
But you can hear me, so I'll just tell you that this was a difficult case because we had 4 bladder stones around 2.5 centimeter each. So that we have pulverized.
We are now seeing.
Okay.
and- yeah.
What we have done is we have removed, this was an infected case, culture positive, and 102 gram prostate and 4 bladder stones. So what we have done is we have pulverized all the stones, and this is the bladder, and we have removed the whole prostate. This, see the trigone here, and these are the orifices. This is the left orifice. Can you appreciate? Hello?
Yeah, we can see the orifice.
Yeah.
And the fossa is excellent.
Yeah, no,
And
no,
there is no bleeding at all.
This is the fossa, and I'm coming back. See the kind of fossa this is, and this is the viru. And this was prostate was quite a lot distal to viru. So I'm now just at the extent of viru. And if I have to show you the sphincter, this is the sphincter. So can you appreciate the sphincter?
Can you show us the sphincter?
Yes, sir. So this
The distal sphincter and
yeah. So
is there
this is the sphincter.
and
Sir, we can't see you endoscopic view.
You
Yes,
can't-
yes, now we can see.
Now you can see the endoscopic view. So from urethra, I am entering ahead and see the viru which is in the center. And if I have to show you the sphincter, this is the sphincter. Can you appreciate the sphincter now?
Yes, yes, sir.
This is the sphincter and this is the distal to viru. How much it is distal to viru? Both the apical lobes have been totally removed. And this is the capsule. Can you appreciate the capsule all around? So,
Anil sir, we can appreciate, I am Dr. Bora. I have one question from you.
Sir.
Sir, such a large bladder stone you did per urethra and 102 grams prostate per urethra. Such a long time sheath will be there in urethra. Is there any chances in follow-up for structure formation?
I think that's a very good question, Dr. Bora. The art lies in the fact that all these patients who have such large stones, large prostates, they get retention of urine, they are catheterized. If they are not catheterized, better to catheterize them for maybe a week or so. And once you catheterize them, their urethra becomes very friendly. So that is step number 1. The step number 2 is we have finished the whole procedure in 2 hours, including all 4 bladder stones, enucleation, and morcellation. So this is the time, and if you can show the prostate, the large prostate and the bladder stones, everything has been removed in 2 hours.
How do you assume the post-operative stress urinary
see,
incontinence?
This is the kind.
Now, which are the patient where intraoperatively you think that this patient is likely that stress urinary incontinence after the surgery will remain for a longer time?
Yeah, so these are very elderly patients above 80 years of age, very large glands, maybe 200, 250, diabetics, patients with very tight suspensory ligaments, where if you struggle at the anterior tissue, then this could be. So these are certain areas where you suspect. And in these cases, even if they are catheterized, we teach them Kegel's exercises a week before.
Okay, sir. Thank you very much. Very well done. Can we have applause for Dr. Anil? Can you hear, sir?
Hello. We are going to start our next case in OTD. Is a 76-year-old male with recurrent acute urinary retention with catheter in C2. He's a hypertensive and on transrectal and transabdominal ultrasound.
Please keep the slide of the history.
We are going to put the slides there from the auditorium only. I request Dr. Kamal from there if we can put on the slides for this patient.
No, right now we are seeing the surgeon and the lithotomy
Sir,
position patient.
we are putting on the slide, sir. Just a moment. In the meantime, I'll just tell that on transrectal and transabdominal ultrasound, the prostate was 130 grams. He's a 76-year-old male on catheter since last 20 days. His serum creatinine was normal. His PSA was normal. And the surgeon who is going to operate is Dr. Devendra Kumar Sharma with a DNB in urology and MCH in urology from SGPGI Lucknow. Sir has worked in SGPGI and MPUH Nadyad, and his special interests include renal transplantation, laparoscopic urology, female urology, and pediatric urology. I request to shift the audio there to Dr. Devendra.
Good afternoon, sir.
Dr. Devendra.
Yes, sir. Good afternoon.
Good afternoon. What is your plan in this case?
So first, I would like to do cystoscopy. Can you see the endoscopic image?
Yeah, we can see.
So urethra, as this patient was catheterized, is friendly. And now you can see that I am entering into the prostatic urethra. So this is sphincter. Now prostatic lobes are starting appearing. This is Viru. And now we are into the bladder. So this looks like a bilobar enlargement, no medial lobe. Okay. So I am planning to do MOLEP in this patient by bilobar technique. So as already you have seen MOLEP by masters like Dr. Anil sir and Dr. Pankaj Maheshwari sir. So this is 136 gram prostate.
Seeing the smile on your face, it's very easy for you.
No, it's always difficult to demonstrate. Yeah. So this is left lobe, which is slightly bigger than the right lobe. This is virumontanum, and the prostate is reaching up to this level. So it's almost 1.5 centimeter beyond the viru. Okay. So I will start from 5 o'clock and with the laser setting of 2 and 40.
In the meantime, Dr. Pankaj would like to finish off with his final comments. Over to Dr. Pankaj, please.
Hello. Am I audible?
Yes, sir. Yes, sir, Dr. Pankaj.
Okay,
Please go
sir.
ahead.
So things are moving well. The morcellation is happening very smooth. As I had said in my first case, there is a distinct advantage of oscillating morcellation that the risk of injury to the bladder mucosa is very low because the blades are continuously under your view. Before we sign off, I would just want to show you the machine that we have used. Can you show that machine? We have used a Quanta 150-watt machine. Recently at Fortis, we have acquired this machine. And undoubtedly, it's a wonderful equipment, a extremely silent equipment. For lithotripsy, it has added advantage of vapor tunnel. I would request Nirav to give some details about the machine. You can take my camera, mic.
We'll be moving on to the robotic prostatectomy. We have a 73-year-old male with recurrent acute urinary retention. He's currently on catheter. He has a grade 4 firm prostate. His transabdominal ultrasound and transrectal ultrasound will be on your screen. He has a 310 cc prostate with a PSA of 3.5 and a creatinine of 0.94. The uroflowmetry and the urodynamic will be on your screen. It will be done by Dr. Malikarjun. Over to Dr. Malikarjun, please.
Hello, am I audible?
Yes, sir. Yes, sir. Go ahead, please.
Oh, hi Vijay.
Hi, sir. How are
Good
you?
to see you. Well, I got a real Punjabi prostate today.
Sir, this is 310 gram prostate.
No, real Punjabi prostate, which I used to see when I was a resident once upon a time. And I were favorites of doing a retropubic at that time in SGPGI, sorry, PGI. But today I've got a robotic thing where I'm doing a transvesical rather. I think the case is a 300-gram prostate. So the possible risk.
Sir, we can't hear you properly. We can't hear you properly.
Malik,
yeah,
please wear the mic properly.
I'm wearing the. Yeah. Are you able to hear me?
Yes, yes.
Yeah. Now I'm just remembering my olden days in PGI where I used to do this sort of a prostates. Real Punjabi 300 grams prostate. Wonderful. But anyway, we are doing a transvesical approach today and a robotic approach today. I have some slight variations which I differ from the routine operations what you have seen. I'll demonstrate those. So the plan is to do a bladder flap and do a transvesical enucleation of the prostate. Well, the whole surgery is going to start with an omega-based flap on a semi-distended bladder. So an omega-based flap with a semi-distended bladder. That's how the whole thing starts off. So you have a semi-distended bladder now, and I can see that there's a gap between the abdominal wall to the bladder wall, and this is an omega-based flap which I create. And
Sir, we can't see endo pictures. from
yeah.
UAP.
Endoscopic picture, please. Are you able to hear? See.
Dr. Malikarjun.
Yes, sir.
Whatever you narrated about the case, can you repeat it?
Yeah.
There is some problem in audio visual sound, so we are not able to get what you exactly said.
Okay. No, I didn't say anything much, sir. I think you had the clinical material, which is around a 300-gram prostate. And I expect a resectable weight of the prostate after enucleation being probably 150 to 180 grams, because the ratio is around 40 to 60%. And the way what I am going to approach is a transvesical way, wherein instead of giving an incision into the bladder and retracting the bladder walls, I would make an omega flap onto the bladder so it can fall back on its own. That's all I said. Did you get the endoscopic picture now?
No, right now we are seeing you. The endoscopic view will be seeing now.
Yes, yes. हाँ, उसको एक्सेप्ट करना पड़ेगा. I think.
Can I ask,
can go to
Malik?
Yeah.
Is it the size which is an indication of robotic enucleation?
Obviously, I don't think.
No,
I
but
don't.
Those who are good resectionists or
They can do it.
We can do in a 2-stage.
Yeah.
Stage 100 to 150 gram we remove, and 48 hours after that the keeping SPC, we remove the other gland.
Ab-
Will you
ab-
accept that alternate?
See, I think we are discussing
If I
here.
don't have a robot, what do I do?
No, exactly. What we did do 10 years ago, we didn't have a robot. So we were discussing what are all the ways somebody can manage the prosthetic enlargement, which we require to do. So if you look at a large prostate, what are the options we have? You have a good HOLEP like what Anil has done, great. A THULEP or what somebody can do, or a bipolar enucleation, very few do it, and or a transvesical approach of enucleation, or a two-stage prostatectomy if you're not comfortable with. I think the factors decide upon many things: your ability, surgeon's expertise, how vascular is the gland. So many other factors which decide how is the approach is. This is one way of managing in a very large prostate, where even a HOLEP or a THULEP will require a 2 hour or a 2.5 hour urethral instrumentation time. So to decrease it, this is one option. So people are coming with a MioLap or a mini lap, whatever you call it, with a smaller scopes to decrease the urethral trauma. If you consider that as a reason for it, in which case, what are you going to do with a large prostate like this? You will end up in having a urethral instrumentation for a 2 hour duration, and the risk of urethral stricture, which is being going to be high. I am not questioning, I am not even criticizing any technique. What is good in your hand and what is safe in your hands is the best way to do. If you have a robot, you try this. If you don't have a robot, you try a HOLEP only. If you don't have any of those things, do a good open prostatectomy, which is still I consider is one of the very good procedures done very correctly. Am I right, sir?
Malik sir,
Yeah.
25 years back,
Yes.
if this much size of prostate,
Mhm.
a choice would have given to you prayers or melons.
I have now done
What you have
just
chosen?
one thing. I would have done an open retropubic prostatectomy. That is what we were very fond of. In fact, we were very fond of doing that. But in this sort of a large median lobe, sometimes we would have preferred a millions like going transvesical prostatectomy.
Thank you, sir.
Did you get the endoscopic picture? Have you got the endoscopic picture? Hello?
Yes, we can have, sir.
You have it?
Yeah.
Then I can proceed. I'm just waiting for it to be confirmed. So if you look at the bladder, it's a semi-distended bladder. It's not very full. And I want to do an omega shaped flap like this, so that the bladder flap comes down and everything is seen in front of me. So this is, I'm just starting the flap. I've just marked the flap. I'm just starting it up. Are you able to see it? Did you get the endoscopic picture well? Hello? Hello?
Sir, we can see, we can see.
Okay. If you're able to see, that's fine. This is something which is coming in the way, this median umbilical ligament, so I'm dividing on one side. But most of the time, my incisions range between the two median umbilical ligaments and they stay as it is, as usually. But unless it is coming in the way, then only I think about dividing it. So my contention is to put a urethral catheter to start with, have an IV set attached to it. And my way of doing it is going to be a little change. I'm going to put a SPC, a small SPC, because the anterior wall of the bladder is completely not touched. I'm not dropping the bladder at all. So I'm going to put a small SPC, keep a 20 French urethral catheter for 2 days, and 2 days later, after the urine is clear, I send the patient on SPC, taking out the urethral catheter. I don't want to keep the urethral catheter for a long period of time in these patients, and I can send them off with SPC itself. So this is my usual way of doing it. So I keep a 2-way above and a 2-way below and take it out, the urethral catheter, once the urine is clear, and discharge him. So this is my approach of doing it. And so if I see that MRI, I saw that there's a huge just waiting, focusing. So there's a huge median lobe. I need to see how I can manage. Sometimes the difficulty faced in these patients is if the bladder is very thick and smaller, that becomes a problem. But anyway, giving this sort of a flap is going to circumvent all those issues with a thicker bladder like what you see here also. It's a fairly thick bladder which is being seen. Having a semi-distended will give you the right approach. Too much of distension is not needed to make this flap at all. So having done on this side, come to the other side.
You are making this flap on the dome of bladder
Yes, I am on the dome of the bladder.
in a semi-distended bladder.
In a semi-distended bladder. I have not touched the red J space at all. I'm not interested in doing anything in the red J space. I leave it just like that. I don't need to make any stay sutures on the bladder to create a traction on the bladder to open the bladder. This flap itself will fall back and look like as if we are open the bladder, and it will not come in our picture at all. I've got the same, the ports is going to be the same as radical prostatectomy, which for a CA prostate, nothing different. I usually put my left-hand port also, two robotic ports on the left side, but they are tuned here with a right-sided one and the assistant sitting on the left side of the patient. So my third arm is going to be there on my right side. That's okay. I can manage with it. I can manage.
Ali,
Yep.
Dr. Keshav here.
Yeah, Keshav.
Don't you think that apart from your flap falling back, other than that, there's not much of advantage?
No, not much.
In fact, your opening, the bladder opening is quite large.
No,
taking
opening is
this flap.
definitely larger, no doubt. This is a disadvantage. What my feeling is, majority of the times I've seen people doing with the traction sutures onto the bladder, the instruments will be going on, hitting those bladder area, that the traction sutures, and they break sometimes. So I think I'll just keep the assistant away from all those headaches of not able to do anything there. And second thing is, it gives direct approach to me. There's no need to do anything beyond. It gives a direct approach. Keep ready with the suction. I'm going to open the bladder sometimes. Be ready with the suction. So depending upon the size of the bladder, sometimes I may open it. The traction may be bigger. Suck it, suck it, suck it. The thing may be larger, or the opening may be large, or sometimes it can be small also. So depending upon the contour and sometimes whatever is feel, I feel extra 1.5 incision onto the bladder is not going to make a big difference at all. That's all. Nothing more. It is out of convenience. I'm not advocating this. This is some modifications what I always felt is fine enough.
Mali, have you tried robotic retropubic?
No, I haven't tried.
Because that would be more anatomical than this.
No, but the problem with no anatomical, I'm fine with it. But what happens with retropubic on a robotic way is going to be for making the bladder fall back completely. Suppose this guy develops a CA prostate tomorrow. I want to think about doing a prostatectomy, radical prostatectomy tomorrow. Once I make a retropubic approach and drop the bladder there, and
Sir, we'll keep you watching.
Sure, go ahead, sir.
Can we shift?
Sir, suction, the
to
multiple
Dr.
small
Devendra?
stone bits there, take it out. That's a ureteric orifice there.
Dr. Devendra,
That's it. Suck it up. Suction and suck.
can we go to OTD, please?
Suction and suck. Suction and suck.
Yes, sir. Am I connected?
Can we shift to OTD, please?
Yes, yes, Dr. Bora.
Dr. Devendra.
Yes, sir.
Which homium you are using? Laser?
It's Moses. This luminous.
Moses.
Moses, yes. I am using energy setting of 2N40. I have developed a trough.
And what are the settings?
2N40 for the cutting, and for coagulation 1.2 and 20.
Okay.
So what I have done till now, so I developed a trough at this place around 5 o'clock and another cut made on the 12 o'clock. And I have cut this mucosa, which was, this is a sphincter. Can you appreciate this thing? And
Yeah,
this
yeah,
is
we can
adenoma.
see.
So I am developing a plane between sphincter and adenoma.
Okay.
So, and overlying mucosa, I am cutting like this mucosa, which is overhanging over the sphincter, I am just cutting it. At this time, I asked my assistant to give little bit pressure on the irrigation, because these mucosal bleed many a time hamper your vision. And then from here, I go little bit inside and ask my assistant to give little bit irrigation pressure, and then develop a plane between sphincter and distal part of the adenoma. So this is capsule, this is sphincter, and this is adenoma.
We can appreciate. You are using bilobar technique.
Yes, bilobar technique.
Devender.
Yes, sir.
I'm Silas, sir.
Yes, sir.
Can you tell us when will you use the 100-watt holmium rather than the Moses, which is 120 watt or more than
Never, sir, never in my life. That's why I'm keeping my energy setting here also, despite they have given me Moses, I am using 80.
80?
And 80 total energy setting, 2 and 40.
So then what is the benefit of Moses technology?
This main advantage, what I was discussing with this, that it's in the stone. So it prevents the retropulsion of the stone, because it forms a vacuum, then energy delivers through that vacuum to the stone. So stone doesn't move up. So that's the main advantage of Moses, especially in stone disease, not in HOLEP.
Not in HOLEP.
Yes, sir.
Oh.
You mean to say Moses technique is only good for stones,
Yes,
not for prostate?
yes.
But
not
the
for-
company
and if you are using, somebody is used to using more energy setting, then probably they can do faster enucleation when they are using higher energy setting.
Dr. Devender,
Yes.
company propagates for the better enucleation, less bleeding, faster resection.
Yeah, maybe somebody who is used to it.
In the stone, you need only 20 watts energy. You don't
Yes.
need a very high energy at all.
Yes.
So I would like to know from you that how the Moses technology will be helpful in a stone surgery.
So basically it creates a vacuum bubble initially in the first shot, and that second bubble which takes the energy to the stone, that energy travels through that vacuum and lead to minimum retropulsion of the stone. So that's the biggest advantage what they are propagating. Am I right? The Olympus people are here, probably they know the better. So this is again, we need to make a good trough at 12 o'clock as well as 7 o'clock. And we just keep on widening this trough and reach to the plane which we are developing from distally.
At Jaipur, you use a Moses or you use a 100-watt
I am using 100-watt holmium, sir, over there.
So what is the difference you are feeling here?
So right now I'm not using 100-watt, which is the and 120-watt. So probably once I will be comfortable with this machine in later part of my procedure, I can use that setting. But right now I'm using, which I'm using with 100-watt laser. So
Can you go to the other OT? Dr. Malik's OT, he is putting the clip, I believe.
Hello?
Upstairs.
Yeah.
Yeah, Malik.
I just did okay, cut it off, take it off. Cut, take it off. Okay, I just kept a stay suture onto the large lobes what we have. We saw that a lot of the projection, intravesical projection. So the understanding what we need to do, can guy just circuit please. I'll just show. Just circuit please. Hello? Yeah. Sir, can we cut off the pumps, please? Flow trans. So this is the ureter here, ureteric orifice, that's a ureteric orifice. This is the median lobe. In a regular radical prostatectomy, what will you do? We'll make an incision here, go behind the bladder wall and go towards the seminal vesicles. If you come here a little higher, what will happen? There will be mucosa followed by the adenoma. So we need to create a plane at this level rather than it little go back. The more medial you go, more little you go, the tendency getting into the bladder is going to be very high, which need to be avoided, which need to, even in the sides also. So you go to the highest portion of the things where is the bladder wall, get to the highest portion here, and then think about incising the mucosa there so that you can come into the plane correctly. Can I have a scissors, please? And can I get the Flutron pumps off, please? Venous pumps off. Venous pumps off. Sometimes this venous pumps, what we keep it for preventing DVC, deep vein thrombosis, can produce a significant amount of bleeding during our procedure. So I tend to close it up when even in a radical prostatectomy at that point of time. So the first thing is, this is the projection of the whole prostate inside. This is the projection. So there's going to be deep deking inside, which is going to be involved. Can you wash it once? And now we are going to make a first plane is going to be posterior, and we create a plane in the posterior point and then come anteriorly. So this is what you're going to see is going to be the adenoma. So let me come somewhere a little higher only. Just mucosa. You cut the mucosa. You may get a small mucosal flap, but you will see the adenoma directly. There will be a lot of bleeding. This is a very, very vascular gland. My bipolar is.
Malik sir, at
Yes.
this junction, you will advise stenting for the beginners.
No,
at this junction.
not necessary. Not necessary. I
You
think
are the
they-
expert.
No,
So-
it just falls away. You see, the question is make an incision, good incision, and then you get onto the adenoma plane. It just, the ureter will just fall away. There's no doubt. I don't think it's necessary. Maximum, instead of stenting, if you want, take a infant feeding tube, keep the infant tube in the ureter. That's enough. I think that should be good enough in case you are little cautious about it as you've been. Being cautious is always appreciable. Nobody says no to it. It's a question of being cautious. So I'm just making a plane on the mucosa. I'm just making an incision onto the mucosa. That's all. So the incision onto the mucosa should expose. There may be one or two small bladder fibers there, but after that, yes, that's a plane of the thing should get exposed. Keep the suction here. Yes, that's it. So there is some bladder fibers. See, these small bladder fibers will be there still. Go nearer, see that. Don't think that that's an adenoma, but still there is a bladder fiber there. There's a bladder fiber there. So there's a spreading of the bladder fiber which happens because there's a slow growth of the adenoma which happens as the time passes by. It is never one day. It goes. It takes long time. So there's always a bladder fiber which spreads all across. So slowly develop the plane by gentle incision. Identify where the bladder fibers are there. Can you make a suction, please? So, and you will maybe finding these are completely having vesical varices. All these tumors, all these large prostate do contain significant amount of vesical varices. So the major part of the bleeding is more mucosal than a vessel. The single vessels are easily manageable. These mucosal bleedings are the difficult one to manage. That's a difficult thing. So you need to be cautious about that mucosal bleeds most often rather than the actual this thing. And as I told you, all the time we have been discussing in all enucleations, what happens is people say that this actual capsule is multi-layered. Everybody, you saw Anil doing, he has come in one layer. You saw Pankaj doing, they're in a little different layer because it's all multiple onion peel layers. That's what everybody feels that whenever you start doing an enucleation, it is not one. Anybody can go into any of those one plane, but anyway, that is good enough. So you feel that there are 2-3 planes which may open up as you go ahead. You need to be careful about, and possibly mixing those planes together is going to be some answer for it. So in the same area, you get into one plane, come back, yes. And another area, you get into another plane. So the in-between tissue may contain some fibrous tissue, sometimes even adenomatous tissue also. See this? There's a plane here. That's a plane, nice plane seen here now. That's an actual adenomatous plane. What I thought as an adenomatous plane till now was nothing but a compressed adenoma along with some muscle fiber. See this? I got into the true plane now. I'm confident now.
So I see that when do you say that is confident? You'll see that vessels running all over the adenoma. You see the similar picture when you do it transurethral also. So you come into the plane, so you come back, again identify yourself, regroup yourself, that you made a plane onto the U-shaped incision. Now I'm sure, okay, I'm fine. I got the, I know where I am. So I start going. Tendency is to go onto this elevation. Please don't go onto that elevation. Stay into the prostate. It's much better. Stay near the prostate. It's much, much better. And the maximum you may enter into the prostate, doesn't matter. But staying into the prostate is much better rather than getting into the bladder. That's going to be more detrimental, more painful. Because there lies once the bladder starts separating, the muscle starts separating, it becomes more difficult for you to understand the planes exactly. So if we lose the plane, come back again into the original area where we've gone. Yes, you got one more layer which possibly need to be taken. So I am taking out that one more layer also now. These are some bladder fibers which have been spread out over the median lobe. That's it. And I'm still again considering it. So you may find those vessels which come from the surface coming here. See this? I thought the muscle ends much ahead, but still it is projecting into this area. The actual thing is somewhere here. So the point which I wanted to emphasize was you have multiple layers coming up, onion peel like appearance coming up. You need to have some place where you find it correct and then proceed accordingly. Wash it once, clean it up and suck it up and wash it once. Am I okay? Hello?
Yes, yes, sir.
Yes, okay. So
Sir, how
now,
you will differentiate between the bladder, and this prostatic adenoma?
Which one?
Fibers, prostatic adenoma, where you are going, and bladder fiber.
no, that's exactly. We sometimes get confused. You see, there is no specific bladder. I'll tell you. There is only some fibers of the bladder which spread over onto the onto the adenoma, along with the adenoma. So we may not be able to identify. Sometimes we need to regroup and readjust as we come across. That's what I'm trying to say. There's no way we can identify. If you go laterally, you end up in going into the bladder muscle. That's exactly what I wanted you to do, not to do. This is what I was telling about, not to enter into the area of bladder. That's exactly. See this? This is the thick bladder
have
here.
to dissect on medial aspect actually.
Come onto the medial aspect, onto the bouncy part of the adenoma. That is the place where you're going to be safer. On the bouncy part of the adenoma, you're going to be safer. So I made a complete incision, suction here. So I made a complete incision. Initially, I thought this is the correct layer. No, there is another layer here which is combined. So I felt I went back. Very nice. I think I'm fine with it. I'm happy with this layer. So I'm proceeding accordingly. So now what happens is we need a little more traction onto the prostate to come get enucleated, which is not happening here. So what is the point? The anterior part is still attached. So now the crucial point at this moment is going to be the anterior part. The crucial point is the point is not the posterior area. The crucial point is going to be the anterior part. So I'm going to come down to the anterior part now, and there is a thing. During my procedure, you saw I've taken the bite or through the whole of the Foley's catheter. I felt, see, somehow, I don't know, I don't have an explanation for this. What I felt was the chance of cutting through the tissue was much lower I've done this thing. Probably the Foley's catheter starts taking away my previous videos doesn't contain it, but this I started recently, wherein I pass through the Foley's catheter so that probably it takes away some amount of pressure onto the gland and takes away that cutting through the gland. That's the biggest problem through cutting through the gland.
We'll keep you watching.
Sure, go ahead. I just want to tell one thing here. Just before you leave, listen to this one point, what I'm trying to say. The most crucial point of any enucleation is going to be this area, anterior part. There is not much of adenoma here. It is directly attached to the deep venous complex. So be careful here. You can go back and come back. I'll show you some points at that time. My only request is to see that
we can see the catheter.
Yeah.
It means it's the anterior to median lobe. How you will appreciate the lateral lobes of prostate?
These are the lateral lobes. This is the lateral lobe. This is the urethra. This is the lateral lobe here. This is the anterior commissure here. This is the anterior commissure. So whenever I'm making an incision onto the anterior commissure.
So
come
once you cut the
close.
anterior commissure, then only you can see the lateral lobes.
No, this is the lateral lobe. This is the lateral lobe. Side, see, this is the lateral lobe which is going ahead. What I'm trying to say is when you come to the anterior commissure, stay close. Stay close. Don't go here. The tendency is to go here because thinking that the whole thing is prostate. No. Stay close here. That is what I wanted to say before you go. That's the reason why I said. So I'm staying close. This is the surface of the prostate here. I saw that there. And this is the detrusor muscle fibers which is spreading onto the side of anterior surface of the prostate, which I am separating and trying to come below that fibers to come onto the anterior part of the prostate.
Okay, sir. We'll keep
can
you
go and
watching.
come back. You can go and come back.
Can we shift
Meanwhile.
Dr. Devendra OT, please? OTT.
Right, suction.
Dr. Devendra.
Dr. Devendra. Can you hear us? Dr. Devendra. Can we shift to OTD, please?
Hello. Dr. Devendra. Can the audio connected to this OT? Audio visual people.
Hello. Hello.
Hello, Dr. Devendra.
Yes, sir.
Now we are with you.
Okay, sir. So there is some technical issue. The laser stopped functioning. There is short circuit in the OTB. So I have developed this plane, which already shown. And after that, there was a spark. We are just correcting those problems. So I am about to finish this left lobe. So this whole plane is developed distally. So I will stay in this plane only and reach up to the bladder neck. Like this.
No, they have a luminous 100. You can ask for that, no?
But there is some issue with the wiring, sir. There is a spark at the.
Dr. Devendra.
Yes, sir.
You keep on operating in a standing position?
Yes, sir.
Always?
Not always, because here camera unit is the fixed side. Okay. So in my theater, I just sit and do whole up in sitting position, but that screen is adjustable. Okay. So over the period of time, I learned that ergonomics is the most important part of any endourological procedure, especially if you are working for long hours.
So what are you planning now?
So just planning.
What are you planning now with this issue now?
Yeah, this is adenoma. This is the capsule. I will keep on developing plane in this area and we'll connect the dots. Like here is the bladder neck area. So I will take this plane and join this plane. And again, similarly, from 9 o'clock to 12 o'clock, I have developed this plane. So I will just stay in this plane between the adenoma and the capsule. So once laser will be functional, I will restart the procedure. Meanwhile, you can continue discussion with Dr. Mallikarjun, sir.
Ravinder, how do you keep bladder empty?
Usually I keep on palpating and it's a continuous irrigation kind of sheath. So it keep on draining. Most of the time it doesn't block because there is no significant bleeding, no clots. So most of the time it's keep on draining.
Okay. Otherwise, what we do, we put a small vein flow on inside the bladder suprapubically. So bladder keeps little empty all the time and your vision is clear.
Okay. Okay. I never tried this thing. It's a good idea.
So how much energy you are using? 80 watts all the time?
80 watts all the time. When I need to coagulate, most of the time I defocus and apply energy on that particular bleeder. Most of the time with this setting only, it stops. If sometimes it's difficult, big bleeder is there, then I change the setting to 1.2 to 1.5. and 20 to 30 hertz.
So what coagulation setting you keep?
In this machine right now, we have kept 1.5 and 20.
No, if there is a large bladder,
Yes.
how do you close it? Or how much setting you keep the machine?
Okay. I changed the setting. Like in this machine, there is both the options are there.
Yeah.
One is cutting setting and the coagulation setting. So in coagulation setting, I've kept 1.5 and 20.
How much?
20 frame. 20 hertz
20 hertz or
and 1.5 joule.
yeah. So either you give it as a 10 hertz or a 15, 20 hertz. Means you have to decrease the frequency and energy you have to use 1.5 joule or so.
Okay.
That's good. So in all the cases, do you do bilobe dissection? Suppose there is a large median lobe.
Yes.
So then how do you proceed?
In that case also, I make a fixed plan, like in any procedure, I start at 5 o'clock like this and keep the median lobe on the right side. So median lobe plus right lobe I take together. First I finish the left lobe, and after that you have enough space so that this right lateral lobe as well as median lobe, there is enough space, we can push it on the opposite side and take it out. So as a rule, I am doing bilobar technique, whether it's a trilobar prostate, large median lobe also. In large median lobe, what we found that there is difficulty in irrigation. So bladder keep on filling repeatedly if median lobe is really big, like more than 2 centimeters. So that blocks the outflow. So in those cases, we can do just median lobe first, and then once that obstruction is removed, we can do both the lobes separately.
Then in this Moses machine, do you have all the problems of like blast shield going on?
Pardon, I couldn't get you.
The blast shield, like we'll have in the 100-watt laser.
Yes, I think it's the same mechanism. So blast sheet damage is maybe happening in this machines also. Okay.
So means doing prostate, there is no advantage of using this
950
high-end machine Moses.
Devendra.
Yes, sir.
The large adenoma is left out. It is just, you have done some 20-25% of the work.
Yes, sir.
Are they working on the machine, and is it likely to start the Moses again? Or what are you waiting for now?
No, this machine to be started, they are correcting this whole system. Probably I will restart with Moses only. So it's not the problem of the Moses, but what I discussed with the technical guy. They said the wire required for these kind of machine is 6 millimeter, whereas the wire here used was 4 millimeter. So probably some load issue was there. So there was a spark, and after that, that main switch went off.
Okay, you organize it. Meanwhile, we go to OT of Dr. Malik.
Okay, sir.
OTA. Audio visual, please shift sound there.
Thank you, sir.
Dr. Malik.
I'm with you.
Malik.
Yes, sir.
We are with you.
Yeah, I think I have done a little part of anterior part. Now I am come back to the posterior. My point is I have done a complete mucosal incision. So I know where my mucosa is divided. The posterior part is separating away very nicely. So I am just completely enucleating it almost mechanically now. The lateral aspect I'm going to come. I've got a fantastic right hand of mine. who is the man for Sopan, I think, is one of the great assistants I've ever seen and a fantastic guy. I don't know. I'm sorry to find it. Didn't find his name, but I'll definitely. So I've done my posterior job already. So I've just pushed it up and come to the other side now.
Can I ask one thing? Suppose if it is a large adenoma of 400, 300, 500, when do you do robotic Millin's prostatectomy? This is a transvesical.
Yes.
So
This is a transvesical.
is it that every time you will prefer to go via bladder?
See, if I need to do a robotic prostatectomy, I would prefer to do a transvesical only, sir, because I want to preserve the. You see, this.
Could you get the question, Malik?
Yes, I got the question saying that why not retropubic? You mean to say that's what, right? Hello? Hello?
Yes, sir. Yes, sir.
That's
Why
exactly.
not to do retropubic?
Why not retropubic? See, that's a point even you asked me just now. But my feeling is, if I need to do a robotic prostatectomy in this, for this sort of a glands, I always prefer to do a transvesical. Reasons: number one, the size of the gland is not small; it's quite big. Even a retropubic prostatectomy, to get it out through the retropubic route also is not going to be easy job. That's number one. Number two, second point, if I don't need to open the retropubic space, which is not essential to do a enucleation in this matter. For this, I can leave it aside and I can keep it for my future necessities in case necessary, like a CA prostate, developing a radical prostatectomy later. That's number two. Number three, large gland, I need to get it out. I think it's transvesical gives me a better appeal and way of doing it. I don't deny that fact. I need to drop the bladder for a retropubic way. I need to drop the bladder and reflect everything. Then only I'll be able to reach that area. That's the reason why I prefer a transvesical. You see, I got the apex now. You see this? I got the lower apex. You got me? Saw this? Hello? Hello?
Oh, yes, we can see the apex.
You can see the apex of the one side lobe on one side. I enucleated it, and this is the sphincteric fibers which are there, which is going to be very important. I'm going to retain them. On one side, I'm fine with it, and I'm going on to the other side. And then the reason why I left the catheter inside, because I'll be able to identify when I am reaching, rather than asking the assistant to put the catheter where it is and end us. I've already fixed the catheter to the prostate, so I know when I'm going to get once I divide the catheter. So this is a urethral muscular fibers which I'm dividing. Possibly this is it, and I'll be able to get it. It's a large gland. It's not a small gland. This is an apex on this side, on the left side of the patient. So this is the urethra here. This is going to be the urethral part. I'm going to retain as much inside. This is going to be the urethra, and that's going to be the catheter which is going to come in the center. I haven't decided yet about the left side yet. On the right side of the patient, yes, this is the right side of the patient. Let me rearrange the fraction. Okay. So let me get across onto the other side. Suction to me. So these are all the bladder neck fibers which need to be divided.
Still the apical lobes are going down, both sides.
Yeah, it is there. It is lot of adenoma inside. In fact, the internal projection is very small. This projection of the thing of the median lobe is a small part. The intraurethral area is going to be very high. The intraurethral portion is going to be very, very high. The biggest thing is I wanted to tell was this anterior part. There will be lot of muscle in the anterior part, which looks as if it is an adenoma, and we'll be going on resecting it. You enter into this area, you end up into the opening the DVC. There's hardly any tissue what restricts them to get into the DVC. So beware. See, identify. Many times I feel that it is adenoma, then it recollect itself saying that no, this is bladder muscle only. or reflected bladder muscle. So you end up in dividing those muscle fibers multiple times. This is what I noticed. See this? At one point, you'll find this is the point where the lower part of the prostate, there is no covering of the prostate and the adenoma just enucleates at this point. See this? Only it comes in the last part, not in the beginning part. See this? Yes, exactly. See this? That is the apex of the prostate. You got realized it? Saw the apex of the prostate here, this lobe, and I'm dividing this muscle here. I think I'm confused you or I'm not able to impress you. Either of the two. So this is the lobe and this is the apex. Clear?
Hello?
Okay. Okay, I'll come to the center again. Okay.
No, still the apical lobes are going down.
I'll show you. I'll show
Yeah.
you. This is one.
But
One side.
you didn't answer the question that if there is you m- you might be doing a diagnostic cystourethropy before you decide.
No, let me, just before you ask, see this. This is apex on one side. This is apex on one side. Am I clear now? I'm opening that urethra here in the center. I'll see the urethral catheter now. Yeah. Now you can ask the question.
Catheter is in.
I'll get it now. Yes. Yeah. You can ask the question. You were asking the question. I just wanted. I'm just reorganizing my traction again and again because that's a major part which is helping us. Yeah. Yes, sir. Shailesh? Shailesh? Oh, it got disconnected?
Yes, sir.
No, Shailesh was asking a question. That's an apex here. Okay, I think I've come down to the catheter now. That's a catheter. Right. Hello?
Dr. Malik?
Yeah.
Rishi here, sir.
Hello?
Rishi here, sir.
Hi, Rishi.
Sir, in this procedure, we are relatively blind at the apex when we are cutting because Viru is not seen. And in such a large prostate, what happens is generally the prostatic lobes extend beyond the Viru.
Yes.
So how do you really?
No, I've already
make
gone,
sure that
Rishi.
you don't cut this into?
Yeah, I already gone across onto that area. I divided one part of the wall of the urethra. It becomes difficult in a large gland to understand where exactly is the Veru. But in many cases, or contrary to your doubt, in many cases, let me reorganize. I don't think I can approach in this fashion. In many cases, I was able to preserve Veru, Rishi. I'm telling you the truth.
You have very neatly entered into the exact precise area, Manoj. We just want to know how.
I'll
exactly
show you. That's
did
exactly what I was trying to show you now. I'm dividing the median raphe and I'll see where I've entered. Okay. Now I know where I've cut. This is the thing. I'll show where I've probably entered into the thing. The median raphe is divided and separated. Okay.
Yes.
Right? Now I think Baba catheter thoda ढीला कर दो. चलो इसको रहने दो ऐसा. Come down. Let me see. Oh, it's a large gland. I don't know whether I can show you now. No. Come down. No, I don't think space is not adequate. But anyway, pull back the catheter. I'll try to get it across. Pull back the catheter. Little. थोड़ा pull कर लो. ठीक है. इधर आ जाओ.
So in some cases, what we have done at our center, we did cystoscopy and scored the
that's one way.
exact area where we wanted to.
Yeah,
go.
true.
So sort of do a enucleation to start with and then proceed with the prostatectomy.
Perfect. That's one my answer. No doubt about it. See, I think I just can see the Veru once. Sakkarla beta. 1 minute. Until the depth, anterior posterior diameter, the diameter is this too high. I can't see it anything here. But contrary, I was telling you whenever I've dissected and did it, I ended up in having a bigger this thing. Can I? आपको अभी तो ये निकालना पड़ेगा मुझे कैथेटर तो जरूरत नहीं है चलो कैथेटर निकाल दीजिएगा 1 मिनट take out the catheter wait take out a catheter take it out come suction I think I'm coming to the last point, which is the most crucial and difficult point is coming through this on either side of the apex. Yes. Okay. Let me. Okay. Let me get the posterior part. Okay. Let me get suction here. Okay. Suck here. Yeah, that is the lower part of the apex. Yes. Suction. That's a catheter. No. Suction. Yeah. You have the next another instrument, right? उसको use करो अभी. नहीं आपका दूसरा इंस्ट्रूमेंट है ना दूसरा पोर्ट में से एक फोर्सेप्स डालो इसको पुश करो I need that assistance now. This is the reason why I need that extra.
Can you connect us to Dr. Devendra's OT?
Yes, sir.
Yeah, I think now you are lucky.
Now, yes, we are lucky. We
Firing is started.
Yes. Again, we need to resettle the things. Like this bleeder, I just defocus and firing on the bleeder. And it has stopped bleeding. I'm deliberately keeping my resection enucleation around the adenoma only. Yeah.
Dr. Devendra, you are working with the same laser or?
Same laser. There was some issue with the electric part, not with the machine. So there was power supply issue. So I was just discussing with Dr. So that there is a major power issue in whole Jalandhar. So probably they are doing this whole thing on the backup. There is. थोड़ा सा पानी दो ना हल्का सा। थोड़ा सा कंटिन्यू
Hello. We are moving on to our last patient in OTC. Patient is a 64-year-old with poor flow, thin stream, obstructive LUTs. IPSS score was 22 on DRE grade 2 firm prostate. Transabdominal and transrectal ultrasound showed 64 grams prostate with a 22 grams median lobe. Uroflowmetry and urodynamics showed obstructed flow. The plan for this patient will be TUFLEP by Dr. Dheeraj.
No, can you show the slide for the history? We can't understand. For a moment, you can freeze one of the OT. Please show the slide and then explain the clinical history, and then we can understand.
Oh, okay, sir. I will put on the slides or. The plan for the patient will be TUFLEP and to be done by Dr. Dheeraj. Earlier, he did the TUFLEP with the 35 watts laser. Now he's going to do with the 70 watt laser. The slides are going to be on your screen in a moment.
So the plan is to do with 35 watt laser.
No, 70 watt. 70 watt laser. The earlier and which he did was with
Okay.
35. Sorry. It's with the 35 watt laser only.
So it's a thulium fiber laser or it's a thulium laser?
Just a moment, sir. I will connect. It's a 75. The sir will explain. I think I will switch over to Dr. Dheeraj only.
I didn't get you exactly which laser we are going to use.
Doctor.
Sir, am I audible? I'm Dheeraj from the OT. Can you hear me?
You are.
Yes, sir. So the case has been presented to you. I'm using a Biorad 75 watt machine, but I'm using an energy of 35 watts in this case. If you can see the screen, I'm using a frequency of 35 hertz and I'm using energy of 1 joule. That is my regular setting.
May I know who is speaking? What is the name of surgeon?
I'm Dr. Dheeraj from Vijayawada, sir.
Okay. Thank you. Sorry for asking.
No problem, sir. So for this case, I'm using the Biorad Quantino laser, which is a 75 watt machine, but I'll be demonstrating this case using only 35 watts of frequency. And this I'm using a 19 by 22 French resectoscope from the RZ company. And I'll be using morcellator by the Biorad, which is Toomey morcellator. So should I start the case, sir?
What is the reason you want to choose low power laser?
Sir, the basic reason is that I have a 35 watt machine and I started my enucleations with the 35 watt. I do all my laser enucleations with the same machine. And I don't see any reason why we should not do enucleations with the low power machines actually.
The clinical examination wise, it is grade 2.
Yes, sir.
How much will be the weight of the prostate? Sonography wise or clinical, what do you think it is the size of the?
Ultrasound wise, the plan size is 60 grams, which I have been told. And I'm doing the cystoscopy as I'm talking to you. I'm just having the first glance of the prostate myself.
This is a which company? TUFLEP 75?
This is a Biorad Quantino laser from the Biorad company. Yeah.
Okay.
So this is a verumontanum. If you can see this urethra. Yeah.
The scope which you are using holding the fiber is a thin scope or it is a routine laser scope of 26, 24?
I've been using this mini scope. The scope has an outer sheath of diameter 22 and an inner diameter of 19. And the telescope which I use is a 2.9 mm lens, unlike the standard 4 mm lens which we use in our standard resector scopes.
No, to reduce the stricture rate and other complication, now there is a trend to go for the smaller sheath for the
Yes, sir. I definitely see two advantages of using the smaller resector scopes. The first advantage is, like you have said, the stricture rate has really come down, at least in my experience, using the smaller French resector scope. And I also believe that when we are trying to achieve these anatomical planes in the enucleation, you can enter the narrow spaces very easily with the smaller French resector scopes. Unlike the 26, if you are trying to enter narrow spaces, you can't do it very easily. But with the 22 and the 18 French resector scopes, you're able to enter into the planes and you're able to develop the good anatomical planes very well with these smaller scopes. It's not only the stricture, but it also, I feel, it enables us to do a better enucleation. So I'll be demonstrating an unblock technique. I generally do unblock techniques. I started off with the 3-lobe, then switched over to 2-lobe, and most of my work these days is unblock technique. So I'll be demonstrating you this ventral mucosa preserving technique by giving an inverted V-shape incision. So should I start the procedure, sir?
Yeah, please go ahead, please.
Yeah, before starting the procedure, I take the initial 12 o'clock marking like here, if you can see, just above the verumontanum. This is the verumontanum here. Just anteriorly, I give a initial 12 o'clock marking. If you can see, this is the 12 o'clock mark. And the idea is here to preserve as much ventral mucosa as possible, which will overlike the striated sphincter complex. If you can see here, this is a sphincter. And I want to preserve as much of ventral mucosa as possible, which I feel is very essential to have an early continence of this procedure. So I start off this procedure by giving a 12 o'clock incision. And just by the side of the verumontanum, what I do is I give a little mucosal incision. Unlike the thulium YAG lasers which we were using earlier, where everything is in the contact mode, this laser can be used just like the holmium lasers by the non-contact mode as well. If you can see, I'm not hardly touching the prostate. And this laser is actually generating some bubbles, which causes the photomechanical effect. So the idea here is to go into the capsule. You can see with the gentle mechanical push, I'm able to enter the plane very nicely near the verumontanum. So the idea is here to create a posterior plane here. If you can see by gentle mechanical pressure, I am actually separating the prostate of the capsule. So this is how I develop the plane initially, just by the side of the verumontanum. And a similar thing will be done on the opposite side as well. Even though this patient has a median lobe as well, I prefer the en-bloc technique, which I feel is the truly anatomical enucleation if you do the en-bloc rather than the 3-lobe technique. See, with a gentle mechanical force, I'm able to develop this plane very easily. If you can see, this is the prostate gland, and this is the capsule here. And whenever there are some additions like this, we can use the laser energy as well. And the rest of the areas, we can just, with a gentle mechanical push, we are able to automatically develop this nice anatomical plane. This anatomical plane will be developed in a mechanical fashion from the 6 o'clock to the 12 o'clock region on both the sides. So if you can appreciate here, I'm not using much of the laser energy. And the plane is being developed very nicely here. And whenever there are some fibrous strands, I use a little bit of laser energy as well to develop that plane. So if you can see here, I've developed posterior plane on both the sides. Now I'm going to join in the midline also as well, just in front of the verumontanum, and develop a uniform posterior plane connecting both the lobes. Maybe this is the only area where I'll use a little bit of contact mode to make the procedure a little quicker. But otherwise, if I have a good anatomical plane, I would rather use a little bit of mechanical force as well to get into those planes easily. So this is a beautiful capsular plane which I'm able to get. And I'm progressing this dissection from the 6 o'clock towards the 3 o'clock region here. So as I said, I'll be demonstrating this early unblock technique with an early apical release. My technique is that the 12 o'clock incision which are given here, what I've essentially done now is raised a mucosal apical wing here. If you can see, this is a prostate gland, and this is the capsule, and this is the sphincter region, and this is the mucosa which I would want to preserve. So what we have essentially done was we have developed apical mucosal wings on both the sides. Now what I'm going to do is I'm going to preserve as much mucosa as possible. This is a 12 o'clock incision which are given, and now what I'll do is I'll gently give an incision of the mucosa in an inverted V fashion. So this is the inverted V on one side, and this is an incision, mucosal incision, which is going on to the other side. So basically what I've done was I would want to preserve the entire mucosa here, this ventral mucosa, which will overlay the sphincter complex. If you see here, this is a capsule, this is a verumontanum. See how the prostate gland actually is beyond the verumontanum. And if you can see here, this is all the sphincter complex. This is all the sphincter complex. I would want this ventral mucosa to cover it after the procedure, which is very essential to maintain a good continence after the surgery. So this mucosal incision which I have given will be slowly deepened up. The
Good
most
evening,
important
Chairperson.
part.
Dr. Malikur Arjun is at the almost towards the end of his this thing. Kindly engage him in your talk. Right?
Can we shift to Dr. Malikoti, please? OTA.
Hello? Oh, I did a mistake here. Okay. Got sir.
Hello, Dr. Malikarjun.
Yeah. No, there's nothing big. I'm just going on suturing it. I'm just going on, he's going to the bladder neck area. I'm going to suture completely with a running suture.
Mallikarjun?
Yes, sir.
Dr. Gupta here.
Sir, namaste.
Wonderful surgery. We have enjoyed
Thank
your
you, sir.
operation. The question is, are you planning to do subtrigonization or
Yes,
you
sir.
are
I'll do it at the
doing
end,
the
sir.
bladder neck
I'll do it
closer?
at the end, sir.
At the end. Okay.
Because if I fix it up, my pulling
This you are doing for
suture, this
hemostasis
pulling
purpose.
suture will loosen it completely. That's the reason.
This one you are doing for hemostasis.
Sir, this is basically for hemostasis.
Okay.
This is basically for hemostasis, nothing more. It got loosed at one point, so I'm.
Sir, Dr. Shailendra here. Sir, as we are doing a persisting suture, so this will cause a narrowing at bladder neck, or
No,
it is just
so
my
such a
apprehension?
huge thing, nothing happens. Basically, such a huge prostate, this is not going to be a persisting effect, is going to be hardly any. It's a huge prostate. Okay, I lost some suction too, some amount of got lost. So what I do is a first thing, but basically the idea what I was actually telling was this detrusor muscle in the anterior surface, which is going to be of utmost importance. Leaving it as a prostate will end up in you getting into the DVC. This is what I wanted to emphasize again and again, because it looks very thick here, and it looks as if we can still go into the prostate, and we are still going into the prostate. It doesn't appear that it is a muscle, but it is a muscle. It's very thick here. What you see in the posterior aspect, you don't see that muscle at all in the posterior aspect, whereas in the anterior aspect, it is not so. You hardly see the adenoma. You mostly see, you can see when I'm splitting the anterior commissure, how much adenoma was there in the anterior commissure? Hardly anything. In fact, I overjudged and went a little inside. That's the reason why this amount of tissue is here. Otherwise, even this would have not been there.
Mallikarjun,
sir,
there's so much of human cry in robotic radical prostatectomy for preservation of the bladder neck. But here you see is a wide bladder neck, and I'm sure the continence will still be better or same. So, what is the role of this bladder neck in the preservation in the continence? You think really it is matters or it doesn't matter?
The issue is a different thing. There are so many compromises that can happen in the whole continence mechanism, because of which we try to preserve as many as possible. That's what we are trying to do. In a benign surgery, the things are very clear. Tomorrow, in fact, I have a talk on that only, sir. That part, prostate, benign prostate, and the continence preservation. I have a talk tomorrow afternoon, morning on this only, because my feeling is what we see in a radical prostatectomy is different, and what we see in a benign prostate is different. Though the ultimate requirement is going to be requiring of adequate length of lysosphincter length, which is going to be essential for maintaining a regular passive continence. We do lot of research on the active continence part, like external sphincter, etc. But the basic thing, most important thing is going to be the passive continence, and which is dependent only on by the length of the smooth muscle, functional urethral length or the functional smooth muscle length, which is necessary there. So if we can maintain.
Now, some French group has described urethra sparing simple prostatectomy.
Yes, sir. That's
so
possible.
yesterday we have done one in Vedanta. We know Sachin was operating. I was watching him. So what is your comment on that?
Sir, that is one way of doing it, sir. If you can save, you can save it, sir. It depends entirely upon our way of doing it. I think so many ways of doing skinning a cack, and if you can do it and you can still preserve some more, it is always advisable and it is always appreciable. I don't know whether we really save the whole thing, or we are just saving the mucosa, or the tissue what is left into the mucosa, under the mucosa, is good enough to retain continence. I am not sure about it. But if you are able to, I think that's good enough. But are we able to or not is a point to be answered.
Okay, Malik will come back. Can we,
Sir, please.
Can we go to Dr. Dheeraj Oti for the THULEP? OT3. Audio visual people, please connect us to OT3.
Am I audible, sir?
Devendra is audible.
Sir, I'm speaking Dheeraj from.
Oh, you are Dheeraj,
yeah.
but then your picture is not seen. Now we are seeing.
Okay, sir.
Okay.
So I'll tell you what I have done, sir, so far. So initially, as you know,
please show us what did you do.
Yeah, this is the verumontanum. If you can see, this is the posterior plane which I have developed. And as I went from the posterior plane towards in an ascending fashion, I developed a little bit of this lateral plane as well. And this is almost the 1 o'clock region. On the other side as well, if you can see, this is the 6 o'clock again. And all round I've dissected, I've separated the apical part of the prostate. And slowly I've reached till the 11 o'clock position here. The only part which is remaining of the apex is of that which is in the anterior side. And I believe this is the most important step in any en bloc enucleation, where we reach the anterior plane. This is the most important step, most difficult step maybe. As I have demonstrated prior, what I've done was I've given an inverted V-shape incision from there, from this 12 o'clock position after raising a mucosal apical wing. You can see this is all the ventral mucosa which I am preserving. So the important goal here right now would be to make a uniform anterior plane. And this is achieved by deepening the incision which I have given, at the same time following the surgical plane which I have developed from the posterior to the lateral. So this is the uniform. This is a good plane which I have developed from the posterior and the lateral side. So I'm doing that simultaneously. I always come back, see the mucosa here. This is a mucosa which I have want to preserve, and come back here and deepen that mucosal incision which I have given. So enucleation is all about landmarks. If you can see here, this is the ventral mucosa which I want to preserve, and this is all the capsule. That is all the capsule. So we maintain our landmarks, and we will never get into trouble in enucleation. Once we lose the landmarks, that's where we get into trouble. So I've gone into the anterior plane of the patient's left lobe. I want to replicate the same thing on the patient's right lobe as well. See, again, this, if you can see here, I've got a good surgical plane here from the 6 o'clock almost to the 11 o'clock position. And the only part which is remaining here is the anterior part of the lobe, which needs to be separated. This is a mucosa here, if you can appreciate. And this is the small part of the apical gland on the patient's right lobe, which needs to be separated out.
Dheeraj, what is the energy setting?
Energy setting is 35 watts, 35 frequency hertz of frequency and 1 watt of energy.
So this is a pulverization mode or other mode?
This is
tissue mode.
This is the tissue mode, which they call it in this BioRad lasers. Tissue mode, yes.
So what is your frequency and what is the wattage?
Frequency is 35 and I'm using 1 watt of energy.
35, 1.
Yes, yes.
Because we are not seeing much charring in your case, you know.
Yes, sir. Charging happens only when we do the contact mode. You will appreciate a little bit of charging just because I'm working near the sphincter region where I need to separate this. But once I progress with the dissection, you will see less of this charging even more, because I'll be using the non-contact mode rather than the contact mode, which we need to use in the thulium YAG lasers.
Okay.
TFL is a good combination of both the lasers. It has the advantage of the holmium dissecting properties, as well as it has a good hemostatic effect, which the thulium YAG has to offer us. See, now I am able to, if you can notice, this ventral mucosa, this technique is the early apical release with the ventral mucosa sparing. If you can see, the entire mucosa has been separated, if you can appreciate that, which lies over the striated sphincter complex. This is entirely, this ventral part of the mucosa is entirely separated. So now what I've done was,
Dr. Dheeraj, when
Yes.
you started the procedure near the apex, it was more of a mechanical energy, and as you are going towards the neck, you are using more of the laser energy.
that's a very good point, sir, because I use predominantly laser energy at the 12 o'clock region, between the 11 o'clock and the 1 o'clock region, when I need to preserve this ventral mucosa, which is where the striated sphincter muscles are very near to the apical part of the gland and also near the bladder neck. So,
One thought process about this use of mechanical energy near the sphincter was that more push and pull actually may result in a little bit of tearing of the sphincter musculature. So in that respect, what is your experience with respect to the early incontinence?
Yeah, that's absolutely true, sir. More amount of mechanical pressure we use, they'll be causing a little bit stretch on the sphincter. So that's the reason why I like this unblock technique. See, what I essentially done with this unblock technique is that I've separated this striated sphincter complex along with the ventral mucosa much early in this procedure. You can see here that the striated sphincter complex and this ventral mucosa, which is overlying it, has been completely separated. So even if I use mechanical energy now, it is not going to cause any stretch on the sphincter. It's very safe to use some mechanical energy as well at this point of time. So once the apical part of the prostate is completely separated, now what I will do is I will take the dissection towards the bladder neck from between the 11 o'clock and the 1 o'clock position. So unlike the traditional technique where everything is done in an ascending fashion, I would want to have a control of the bladder neck at between the 11 o'clock and the 1 o'clock position, because if you can see here, we almost reach the bladder neck. This is a very short route. If you go in the 12 o'clock position here, if you can see, this is the apex, apical part of the prostate. This is the sphincter region, and it's a very short route towards the bladder neck. If you can see here, these are the bladder neck fibers. So as I slowly progress towards there, I'll enter the bladder now any moment. But if you take the other route, posterior route, you'll have to go through a longer route. And also the capsule near the trigone is very thick and you tend to cause a lot of perforation as well. See, nicely the bladder neck has been opened up. So this I prefer to do between the 11 o'clock and the 1 o'clock region. And once you open up the bladder neck, the good thing is that you have a whole set of new landmarks. Once this bladder neck is open, I utilize it to the maximum. The entire bladder neck I'm going to open now so that I'll have a whole set. This bladder. So if you, I'm use yes. Bladder neck completely open. Yeah. And my principle of doing this enucleation from here on would be take the dissection from above below rather than below up. See now how I'm dissecting from above downwards. I have total control of the prostate. And I can't, it's very difficult to perforate the capsule when you are coming from above downwards. Otherwise, if you are taking from this gland from below above, then there's a high chance that the perforation is there. And if you can see, there's a bleeder here, active spurter. And I'm using nothing else, no other setting. I just use the regular setting which I'm using, that is the 35 watt. And with pinpoint coagulation, there's good hemostasis. I'm sure holmium laser, we need to defocus it. We need to spend some time coagulating that vessel, but not like that. But in TFL laser, we'll have good property of this thulium, thulium ions, where the absorption is very close to the water and it's the hemostatic ability is very good. And if you want me to do mechanical as well, I can do some mechanical energy also. See how I'm able to slowly use mechanical pressure also to enucleate this gland. And only near the bladder neck, I'd probably use this laser more than what I use in the other areas of the prostate. Opening up this bladder neck gives you a direction to which depth we need to continue this dissection. So my principle would be to actually take the prostate from above downwards and from lateral to medial. That way I feel that we'll have better control of enucleating the gland and cause less perforations. That's what I believe. So almost this left lobe, enucleation, lateral part of this left lobe has been completely removed. So same thing will be repeated on the other side as well, where I'm taking the dissection down from above. Same thing would be like from above downwards and lateral to medial. It's a little vascular gland, I would agree. But with the excellent hemostatic ability of this laser, we can take care of such vessels in an efficient manner. I'll follow the same principles. I'll open up the bladder neck here. And from above downwards, I'm going to take this prostate gland. And if you can notice, everything is being done with the 35 watt frequency in a low power. I'm not sure I would require more energy than this. I'm happy with whatever energy is being delivered from this setting.
Dr. Dheeraj, we'll keep you watching.
Sure, sir.
Okay. Can you connect to OTA, please? Connect to OTA. Dr. Malik.
Suction, please.
Malik, sir.
Yeah, am I audible?
Yeah.
Okay, I have
So
done the.
you are stitching prostatic tissue,
See, this is the verumontanum. That's a verumontanum. I use that urethral margin to suture to the trigonal area. And I'm trying to use this suture to have some sort of a hemostasis. Some slight bleeding is there in the anterior wall here. I just want to have 1 or 2 sutures there. So I'm trying to get it back across into that area. There used to be one procedure which I think there used to be something called plication of the prostatic cavity, which was done as a resident. We had done few cases, but it has never been found to useful since the day we had balloon catheters with traction. We stopped using that. If I remember, Gupta sir might be knowing about it.
Sir, my question is, do you give traction in this case? I mean, in these type of cases?
I don't think it is
Number one.
needed.
And number two, what are the incidents of bleeding, post-op bleeding?
In fact, I never had to do any case of clot evacuation or re-exploration till now for any patient who underwent a enucleation procedure. Either it's bipolar or it is either bipolar or robotic simple prostatectomy till now. What all happened was only for TURs, not in enucleations. That somehow it never happened. So I'm just taking care of some sort of a bleeders in the anterior wall, which is there bleeding. So I'm trying to just placate. I'm not going to do anything specifically for them. I'm just going to placate that prostatic cavity that itself will clean the bleeding. See that the bleeding has settled. There's something called plication of the prostatic capsule, which used to happen once upon a time when there is a large prostate to decrease the bleeding. That is what the principle is, that just get the prostatic capsule nearby and the bleeding stops. And regarding the use of traction for this man, I don't think it will be necessary. What you see here will not be seen once I finish this job. And I don't think it will be necessary at all. But anyway, cut it. I finished it now. Just divide this. The verumontanum is there. The trigonization is over. I just divide this. Get me a scissor. There is some tongue of tissue which is handling here, which I want to excise. This is a tongue of tissue. Cut it off. Cut this off. And I always put the short, not so long. I always put an SPC in these patients. Our technique of doing is in these patients is put an SPC. The anterior wall of the bladder is absolutely free. The suprapubic area is absolutely free. So what I'll do is I'll put a SPC 14 or a 16, which I use it for irrigating, and give me a scissor and suction at the last moment. Give me a scissor, suction. And I do that. What I do is suction.
Sir, years back in transvesical open prostatectomy, there are very high incidence of incontinence, post-op incontinence.
Once upon a time, when the vision was not there, not necessarily now. I don't think it is seen. Basically, in fact, I would say the incontinence and stress incontinence rates were much higher with enucleations done by our own lasers or anything, but usually not. Usually, this may be whatever you find it here is very transient, and whatever you saw there is very, 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 very magnified view. I don't think you need to worry about that at all. But anyway, any enucleation, let me tell you very clearly, any enucleation, I accept what you said, is any enucleation procedure will have a transient stress incontinence, irrespective of whatever attempts you do. If you don't have it, wonderful, you've done a great job. If you have it, that is acceptable. That's what I feel. That's what I feel. Can you put a urethral catheter 20 number 2-way, please? Can I have a scissor? I need a scissor to excise this. Okay, doesn't matter. It's not needed. It's okay.
Sir, very well done.
Thank you. And I'll just put an SPC.
Can you listen to applause of the audience?
No, don't worry. Not applause is not the indication, not a problem at all. So
thank you, sir.
Thank you. I'll just close it up like this again. I'll put an SPC. I'll close up. Put the urethral catheter first. And put an SPC first, otherwise. Put an SPC. SPC and incision. Put a needle first. Let me see where it is coming and then you can put it. समझे बेटा? हाँ. Needle लगाओ पहले जहां पर मैंने मार्क किया था हमने. Incision दे दो. No. नीचे बाग काफी नीचे जाना है. यहाँ पर आएगा. हाँ नीचे जाओ. अभी. Towards legs. आपका needle towards leg.
So can we have the closing comments from Dr. Devender also? So we have almost finished our OT sessions for the day.
Mallikarjun,
Yes, sir.
why you are doing SPC? Not required. Three-way catheter is good enough.
I know, sir, but I still somehow I've been at a traditional thinking process. What I do is I'll put an SPC, I'll take out the catheter once the urine is clear, urethral catheter, and send him on SPC. Let him come back after 10 days, and then I'll clamp the catheter. That's how I've been doing, sir.
So, sir, we can continue to have your visuals on one screen.
Sure, sure.
Meanwhile, we'll continue with our rest of the sessions. Thank you, Chairperson, sir, for facing the last session. But before we close the OT session, can we have an applause for the OT team, the anesthesia team, and all the residents and nurses that have helped us throughout the day? Thank you, Dr. Sopan Sood. You must have heard the applause from the hall.
Never take minute.
Dr. Sopan, do you have any closing comments from there?
Yes.
Dr. Sopan?
Center Miller.
Okay, so we'll proceed with our next session.
Yes.
May I call upon the next set of chairpersons for the session? This is a debate session. May I call Dr. N.P. Gupta, sir, Dr. Ashok Sharma, Dr. Shailendra Goyal, and Dr. Anil Varshney. Dr. Anil Varshney, sir, I saw him just a little while back. Okay, he'll join us. So this is a debate session, and we are going to have two sets of debates. Okay.
अच्छा नीचे irrigation कर दो.
Dr. Sapan.
Hello, Rishi. Can you hear me?
Good evening.
Hello, good evening. Can you hear me?
Yeah. Tapan,
Yes, sir. Good evening.
good evening. How are you?
I'm fine, sir. Thank you. And I
Good
really
show,
appreciate
good
your
show,
coming
so
all the
far.
way for this workshop. I just wanted to take a couple of minutes before we end the operative workshop to thank my team who've been working since 2-3 days incessantly trying to keep the cases going through the workshop. I think we have shown a total of 16 cases. There are still a couple of cases left. They will continue with the cases because we have promised the patients. But I think we try to show you some of the unique cases which we could show over from the OT, and we managed to show you about 2 cases of HOLEP which were more than 100 grams primary, one HOLEP with stone, one redo HOLEP, which was another 100-gram prostate, a 310-gram prostate. Mallikarjun just performed a wonderful prostatectomy. And Devinder did a wonderful resection on a 130-gram prostate. I think Dheeraj also reveled in the workshop. He showed us a wonderful enucleation using the thulium. I think there were many skepticals among the HOLEP fans who were not so sure about the tulip and its importance and its role in enucleation. But I think both Anshuman and Dheeraj have sort of overturned that dictum. So I want to thank all my staff. They have been working for me. Rakesh, they cannot come on camera because they are still assisting. Rakesh has been there, Varinder has been there, Rajiv has been there, Ranjit has been there. They have been the main assistants in all the.
You can rotate your camera and show them.
Yeah, sir, I cannot show them because they are on different OTs and the camera is from one OT and I think you'll only see their backs. Not really they are working. I want to particularly thank my anesthetist, Dr. Saurabh and Dr. Yasir. Are they around? Can I show them on the camera? Is Saurabh here? So Saurabh and Yasir kept the list going. There was hardly any break between the cases, and there was a continuous transmission on both the screens, and we kept it like that throughout the entire conference. And I want to thank all the vendors who were really there. They've been working since yesterday. Quanta has been here, Jenna has been here, Biorad has been here, Stores has been here, and Boston Scientific with the Resume and the Molep, which was the last game which was conducted. And last of all, I hope you really appreciated the conference. I hope it was good for you too. I enjoyed conducting it from the operation theaters of Patel Hospital. Thank you very much. And we are closing off for the day, and over to Rishi for the rest of the conference. Thank you.
Thank you, Swapal Sood. On behalf of all the delegates and faculty, we like to thank you and your team for excellent demonstration of these cases. Thank you very much. Now we move on to the next part of this scientific program. We have two debates here, and the first debate and clinical case discussion is here. The debate one is 55-year male with history of LUTS, IPSS 18, 32-gram prostate, no median lobe, not improved on Alfusin over 1 year. Now, in this, we have three speakers, HOLEP or HULEP by Manish Shingla, and bipolar TUR, Dr. Abreen Singh Shah, Resume Dharmendra Agarwal, and Eurolip Tanush Pal Bhatia. So may I request Dr. Manish Shingla to please start your presentation. Role of HOLEP. I'll repeat again, 55-year male, 32-gram prostate, no median lobe, no improvement on medication.
Good evening, respected chairpersons, senior colleagues, and dear friends. So I'll be talking in favor of HOLEP regarding this particular case.
You have 5 minutes for your presentation.
बेटा और एक ले लेना. Sorry, I think my mic is on. Boss, can you switch off my mic?
So the case here is of a young patient, 55-year-old, and 32-gram prostate is a small prostate in a young patient. So Dr. Manish Singla will justify for the HOLAP and THOLAP.
So there is a case of 55-year-old male with moderate lower urinary tract symptoms with IPSS of 18, and he has 32 gram of prostate with no medial lobe, and this patient has not improved on alfusos in over 1 year. And I'm assuming that he's a married man and he has completed his family, and I'm also assuming that he's not a professional porn star. So I'll favor this patient in favor of HOLAP. I would counsel this patient because of its efficacy, because of its durability, because of its limited effect on sexual function, and because of its cost effectiveness. And last but not the least are the technical reasons. So we all know that HOLAP is a excellent procedure as far as flow rate is concerned, but the resume and Eurolift are not very effective as far as Euroflow improvement is concerned. So the maximum improvement which is noted after resume and Eurolift is up to 40%. So let's assume a patient has a Euroflow rate of 9 ml per second preoperatively. The maximum improvement reported is up to 13 ml per second, which is not very significant. The people talk about the change in quality of life after resume and Eurolift. The maximum improvement in IPSS reported is up to 40%. This man has a 18 IPSS. The maximum improvement would be around up to 10 IPSS. And we all know that catheterization time after resume is 7 days, minimum to up to 2 weeks. So this is the kind of Euroflow you get after HOLAP and other resume and Eurolift. So these are the kinds of Euroflow you get after HOLAP, after bipolar TURP, resume and Eurolift. So I don't think it's a much improvement in resume and Eurolift. So if we talk about the durability, we have now 15-year follow-up data for HOLAP where reoperation rate is 0 to 0.7%. While in up to 5-year data is available regarding MIST, and the retreatment rate after resume is 4.5% at 2 years. And for Eurolift, retreatment rate is up to 12% at 2 years and up to 48% at 5 years. And it increases by 6% every year. So you'll counsel this patient that there is a very high treatment rate. And by the end of 10 years, there are 60% chances that he'll get a retreatment with MIST. So now this is the talking point of this case, basically, this effect of HOLAP on sexual function. So there are few facts regarding erectile function, ejaculatory function, libido, and partner's experience after HOLAP. So it has been seen that the erectile function remains stable in 85% of patients after HOLAP. 15% patients reported improvement and 7% reported significant improvement after HOLAP. So now this is again an important point, the ejaculatory function after HOLAP. So I have done some review of literature regarding the ejaculatory ability, volume, pressure, and Bother score after HOLAP. So it was found that the 70% of the patient reported retrograde ejaculation after HOLAP. Still 30% were able to ejaculate after HOLAP, although 15% reported some decrease in ejaculatory volume. More than 90% patients who had retrograde ejaculation, it was not bothersome. And there was one study where ejaculatory preserving HOLEP was done. They were able to preserve ejaculation in 88% of the patients in ejaculatory preserving HOLEP. So there was no change in sexual desire after HOLEP, no change in intercourse satisfaction or overall satisfaction after HOLEP. Now the cost factor is also very important. I have noted the minimum cost after HOLEP. It is 40,000. We are doing the CGSS patients for 40,000. Bipolar TRP, I think it would be a similar cost. Resume is minimum 3.5 lakhs and 4 lakhs for Eurolift. So I think the patient's values, preferences, expectations, and POCAN should be taken into consideration. Maintaining ejaculation is an important point, but we should not forget our first goal, that is treatment of LUTs and the durability of the procedure. Let's be fair. Thank you, sir.
Thank you, Manish. We'll have the question answer at the end of the all presentations.
Now we invite Dr. Arvind Singh, bipolar TRP and enucleation.
Good morning. Good afternoon, everyone. So for the same patient, I'm going to talk about bipolar, either TURP or enucleation. We know the patient has a 32-gram prostate, IPSS is 18, and there is no median lobe, and it's not improving on medicine. And bipolar, TURP or enucleation, as you know, is an electrosection where high-frequency current is used. The current passes from one active electrode to the another. Conductive irrigation fluid is used. The quasi or true bipolars that are available. There are different types which are available. Gyrus, where one part of the loop acts as an active and the other acts as a passive. Karlsruhe has one where upper and the lower part acts as active and passive. Double stem. And then there is quasi-bipolar where the sheath acts as a passive electrode. Lots of varieties in the loops. You can use them for enucleation. You can use them for TURP. And then bipolar enucleation has been called various names. It's called transurethral bipolar enucleation of the prostate, PCAP or BPAP. It can be followed by either morcellation or you can do the resection of the enucleated adenoma by the bipolar itself. Lots of HOLEPs have been demonstrated in the morning, and bipolar enucleation has also been demonstrated. It's very easy to control. It's basically an anatomical endoscopic enucleation of the prostate where a little mechanical force helps, and hemostasis is perfect. So the points that go in favor of bipolar TURP that I'm vouching for is that most people already know the technique. They learn it in residency. It's very cost effective. There is literally low learning curve for the newcomers. It's a reliable, the machine is sturdy, there's less equipment failure, time-tested technique, there is no time limitation, and it's standard of comparison for all others. Starting with the cost, it's cheapest. There is no laser requirement, there is no fancy equipment, no extra investment, no limitation as we have in RISM. There is no recurring cost as compared to consumables that are used in laser or RISM. And bipolar cautery is one of the cheapest equipment that you can have out of all three modalities that we are comparing it with. And the utility is that you get a bonus that you can use it in laparoscopy as well. You cannot use RISM, Eurolift, or laser in any other place. It's available. The people who know how to do it, they're available. The equipments are available, and this accessibility is also there. The learning curve, which is one of the major points, HOLEP has a learning curve, RISM has a learning curve, Eurolift has a learning curve, but most urologists know how to do TURP. It's not just training. Your performance does not depend upon training. Training is just a part of learning, and learning is a part of performance. So you will make mistakes as compared to HOLEP, which can, when you start learning, you will have residual adenomas, you will have strictures, you will have requirements for slings, and incontinence definitely would be there. And the results as compared to bipolar TURP comparing to HOLEP, the results are similar. It is a cost-effective way. And if you're giving similar results, I don't think we have any other, I don't think there is any other requirement for any other modality. It's a versatile modality. You can use it for small prostates, large prostates. You can use it if there is a median lobe. You can use it if there is an anticoagulation patient is having less blood transfusions, dysuria. And the major point is cost. It is one of the cheapest out of all. The cost to the patient comes to roughly 30 to 40K. If it is CGHS, it will come to 20, 28K. As compared to Urolift, Rhythm, or even holmium laser prostate, which would cost you more than 50K minimum. It does not have incontinence features like HOLEP, we are comparing side effects. And if you compare the practice patterns, it is one which is available with masses. Still, till date, most of the people are doing, majority of the people are still doing TURP, and it takes the major share of treatment. And this was from Central European Journal of Urology, where they showed that 500% increase in the 2000 to 2016 in bipolar TURP itself. And if I compare enucleation, bipolar, the results are similar with bipolar TURP. Its efficacy is similar at 36 months. Significant improvement in IPSS, QOLs, QOR, and QMAX, and low acute urinary retention rates, hemoglobin drop, or transfusion rates. Even the midterm IEFF5 score were comparable if the patient is sexually active. They said that it's comparable to monopolar TURP, which by now is still considered as a gold standard. So my conclusion would be that 55-year-old male, 32-gram prostate, bipolar is perfect for him. And if the patient surgeon knows enucleation is better. And I'm backed by all the guidelines. EAU 2024 says bipolar TURP is the current standard for 30 to 80 ml grams of prostate. And if you're doing bipolar, it has more perioperative favorable outcomes, and they recommend it strongly. AUA says the evidence level for TURP is grade B. Even our own guidelines, USI, they say that for TURP should be offered to men, strongly recommended for 30 to 80 ml. This is a flow chart describing EAU's current treatment protocol. For 30 to 80, TURP still is the current choice. So you have to understand there would be lots of ways. बहुत रास्ते होंगे एक मंजिल तक पहुंचने के लिए. HOLEP होगा, Rhythm होगा, Urolift होगा, bipolar होगा. But what constitutes the gold standard would be it should be easily available across the globe. It should have an easy learning curve, cost effective and affordable to common mass, least complications, should be versatile, durable, optimum operative results, and most importantly, it should be replicable by majority. There are 11 modalities in the market. 11 modalities in market में for treatment of prostate. But you need to understand, bipolar को पकड़ना मुश्किल ही नहीं, नामुमकिन है. Because bipolar is drawn. Thank you.
Thank you, Dr. Avrin. Now we move on to the next debater, that is for resume, Dr. Dharmendra Agarwal.
Good evening, everyone. So I'm going to talk about RESM. Is it the rise of a new era? So we all know that RESM is a water vapor therapy, and the principle on which the RESM therapy works is the principle of convective water vapor ablation. It has emerged as a viable option to manage lower urinary tract symptoms, and it is fastly spreading its wings. So starting with the slide demonstration of how it works, it uses the stored thermal energy into the water vapor as unique heat source, and that water vapor is injected into the prostate tissue. The heat is dissipated into the interstitium of the tissues, which causes the cell death over the time, and that tissue is slowly removed by the body by the mechanism of apoptosis. Because of this slow removal of the tissue, the urethra lumen expands, it opens up, and it remains, and the heat which is given into the prostate remains contained into the prostate zonal anatomy. So we all know the mechanism of convective thermal energy, in which the heat is transferred equally among all the cells with the help of interstitium. However, the conductive thermal energy, it supplies the heat mainly to the part where the energy is touched or where the energy is conducted. So that is the difference between most of the energy ablations which we use as compared to the RESM. The RESM system consists of a handheld delivery device and a generator. The generator has a radio frequency power supply, multiple system controls, and a transurethral delivery system. We saw its use today morning. It is performed under local anesthesia or maximum under a sedation. A check cystoscopy is performed to assess the urethra and prostate lobes. Delivery system is passed into the urethra and prostate. Prostatic urethra length is assessed. The vapor injection starts from the proximal to distal part, starting almost 1 centimeter away from the bladder neck, and the steam is delivered via a retractable needle. The goal in providing this kind of treatment is to create contiguous, overlapping treated areas along the normal curve of the prostate and prostatic urethra. So as we can see in this diagram, we are creating some overlapping areas, overlapping zones, which are treated with this thermal vapor therapy. And we are also focusing our target on the bulk of the adenoma. So the guidelines for determining the number of treatments which are required for per lateral lobes is actually dependent on the length of the prostatic urethra. We assess the length of the prostatic urethra from the bladder neck to the perimentinum. And for every 1 centimeter, we provide one treatment per lobe. So for less than 2 centimeter urethra, we provide almost 1 to 2 treatments per lobe. For 2 to 3 centimeter, it's 2 to 3 treatments, and more than 3 centimeter of length, we provide about 3 to 4 treatments per lobe. And we use the field of view of the cystoscopy because the cystoscopic view is considered to be about half centimeter in the length. So we take 2 field of views, and then after 2 field of view, we give our first treatment, and every alternate field of view, we give this one treatment till we reach the perimentinum area. The multiple trials have been done for the RESM treatment, and we have shown that the IPSS improvement from the RESM after 1 month is about 30%. In 3 months, it is 53%. In 6 months, it is 62%. And most of the times, it remains persistent with the time. Qmax in uroflowmetry, it improves 55% in first month, and it reaches up to 71% in 6 months' time. In the ED score, ejaculatory functions, there is no change preoperative as well as postoperative. That means it is completely ejaculation preserving technique. Average catheterization days for the small prostate remains around 4 to 5 days, and for larger prostate, it remains around 10 to 14 days. Coming back to our index case, where we saw a patient of 55-year-old, moderate lower urinary tract symptoms, 32 grams, small prostate, there is no median lobe, and he has taken the medical therapy already for 1 year. So he has failed with medical therapy. Now this patient, we do not know whether he desires his sexual preservation. We do not know whether he wants to preserve his ejaculation or not. It is true that we are in our Indian scenario, we say that ejaculation is not very important. But what I have realized is patients are actually less hesitant to talk about it. They do want to preserve their sexual functions. They do want to preserve their ejaculations. They don't want to talk about it with the society and with the doctors. So the benefits of RESM is ejaculation preservation. It can be done under local anesthesia. It is less invasive compared to the classical resection and enucleation. The procedure time takes barely 5 minutes, and the retreatment rate is about 4% in next 4 to 5 years. And when we compare other modalities, we all know HOLEP and bipolar, there is no ejaculation preservation. In Urolift, yes, there is some preservation there. HOLEP, THULEP, bipolar TURP is not possible under local anesthesia. And we quite commonly see some old age patients also who are not very fit for procedures to be underwent under an anesthesia, and who are on anticoagulations, and they are not very fit to stop anticoagulations. These are the patients who are actually candidates for the RESM. HOLEP, bipolar TURP are definitely more invasive as compared to the RESM, and there is no implants, there is nothing left inside the body. So I agree that RESM is not a magical treatment, but there is definitely a subset of patients, a subset of population who benefits from this, and it definitely forms a bridge between the medical therapy and the directly invasive surgical options. So my question is, after the failure of medical therapy in a young patient, should we jump directly to the invasive TURP or enucleation, or should we give them a trial of a minimally invasive surgical treatment? Thank you.
Thank you, Northzone, for this opportunity. Can I have my presentation, please? Thank you. So we are debating today about a relatively young male with non-responsive LUTs with Eurolift as an option, treatment option. So as a disclaimer, first of all, there is no conflict of interest, and resemblance to any person in the following presentation is purely coincidental. The narrative is fictional for the purpose of debate with no intention to hurt any person or a group of people. So the index case is a 55-year-old male with IPSS of 18, 32-gram prostate with no median lobe. And he is on alfuzosin. The fact that he is on alfuzosin means his urologist has kept him on alfuzosin because he is sexually active and he desires ejaculation. So let us see, who can it be? Maybe it can be a bhaijan from the Bollywood industry, or maybe somebody, relatively older actor who recently got divorced, looking forward to marry again. It can be a very popular, I would say, diplomat turned politician called Mr. Jarur, or he can be an aging urologist, because we tend to be, we like empathy. So we always think what we would do on ourselves or on our family. So it can be aging urologist who is worried about his sperm and ejaculation, of course. So now we will take one of these as an index case. So our Mr. Jarur is Heran Pareshan. Why so? Because he has been advised HOLEP. Of course, there will be an ejaculation with that by Dr. Manish, and Dr. Avreen also advised TORP, bound to have an ejaculation despite everything. And of course, Dr. Dharminder has promised ejaculation with the resume, but there is a 3 to 6% an ejaculation with that as well. So being a diplomat, he has a lot of connections. He calls up his friends in US, UK, everywhere, and he learns about this new technique called Urolift. And he comes to this doctor who does some Eurolifts. He shows and he sees how his bladder neck can be opened and he can have a relatively better flow, but much better quality of life, equivalent to other procedures, and with a 100% guarantee of preserving the ejaculation. So now he is happy because he has BPH relief inside. So, of course, his doctor has told him the benefits of Eurolift. It can be performed under local anesthesia as a daycare procedure. Patients preserve the existing sexual function. It has a strong safety profile. Patient can discontinue the medical therapy afterwards. Of course, it's a catheter-free procedure, so he can go home same day without a catheter, and there's a good improvement in the IPSS and a good improvement in the quality of life. So Eurolift is a mechanical solution for a mechanical problem. When the drugs stop acting means the dynamic component is lesser and the mechanical component of obstruction is more. So Eurolift is a mechanical solution for that, wherein we place the implants and they open up the passage, as we have seen in the case in morning also. So there's the capsular tab which goes outside. There's a urethral end piece which is in the urethra, and they tend to open up the urethral passage. So typically, anything between 2 to 6 implants are used in a small to medium sized prostate. I will just, for the want of time, I will skip this. We have already seen this in morning. So what does the patient want? First thing patient wants, Indian patient also, is that there should be no post-op catheter. He wants a rapid relief. He wants a rapid recovery. He wants a minimal downtime. He wants a minimal procedure discomfort. And he wants to preserve sexual function. It should be an office procedure and preferably done under local anesthesia. All these are served by Eurolift. What does the urologist want for his patient? There should be a rapid relief with minimal side effects. So most side effects with Eurolift are resolved within 2 to 4 weeks. It preserves the sexual function, and there is no or reduced need for post-op catheter. It is performed in an ambulatory and outpatient setting. That's what the urologist wants. It is done routinely. It should be a straightforward procedure. Yes, it is reliable, and most importantly, it is reproducible. And it should be durable. So there is a 2 to 3% procedural treatment rate per year. Yes, it goes up to 13.4% up to 5 years. There has been extensive clinical evidence that supports the Eurolift system, which has been there over the years, and even more studies in 2023. and the results are consistent, be it the LIFT study, which was a RCT, be it the real RWR study, which was a real world retrospective study studying 3,226 patients. All the healthcare claims and utilization analysis of 35,000 patients all have proven the safety, efficacy, durability of Eurolift system. Now, if we talk about the LIFT study, this was the basis for FDA approval, and we can see a good symptom relief and a persistent symptom relief till 5 years. There was a 10.6% reduction in the IPSS at 12 months and 36% improvement at 5 years. Eurolift system patients show quick and quick recovery compared to TURP patients. If you look at the graphs, the patients flow improves further, the symptoms come down earlier, and the TURP matches the graph at the end of 6 to 12 months. In the real world study, again 3,226 real world cases at 22 international sites, it was found irrespective of the patient prostate size less than 30 cc or more than 80 cc, retention patient, patients with prostate cancer, and patients with diabetes all showed good results and persistent results. And it also leads to tissue remodeling. It causes compression, which leads to decreased blood flow, causes lobular atrophy and scarring. So it does causes some remodeling of the tissue. And the biggest advantage is that it has been shown to cause not to cause new and it causes lasting sexual dysfunction. So there is 0% incidence of ejaculatory dysfunction or erectile dysfunction with Eurolift. This is the only treatment with which you can guarantee the patient that. Even if we compare it with drugs, you can see in the table on right side, even with alpha blockers and 5-ARI, there is an incidence of ejaculatory as well as erectile dysfunction, which is not there with Eurolift. And the resume is there at the end of the table. You can see a 3% ejaculatory dysfunction with resume. Overall complication rate are also much less when compared to TURP or resume or green light. So now our Mr. Jarur is happy. He can go about his life further. He will have relief in the symptoms of his LUTs as well as a good and active life ahead. So thank you very much for this opportunity again.
Okay, thank you, Dr. Tanuj. I would like to invite all the 4 speakers to the stage. And it's really, they have done justice to what the topic has been given to do. And now it is the role of audience. Audience, please. The index patient, you all know, it's 55-year-old patient, 32-gram prostate. And what percentage of, kindly raise your hands. A for HOLEP. B for bipolar TURP. Okay. Now for rhizome and for Eurolift. So friends, it's a bipolar TURP is the clear winner as far as the audience poll goes. But I think there is a question that if you all are young and if you were the patient, what would you like? Would you like bipolar TURP or any of the other modalities? I think this. So I think that answers the whole debate. And I was asked by Dr. Sanjay Kulkarni once that how many urologists would like to get any of these modalities. And I think that answers the question that none of them wants until and unless forced to. So friends, I think this was interesting debate. And last word from Dr. N.P. Gupta.
So there are 2-3 things also to be considered in mind. One is that sexual and ejaculatory, basically is the ejaculatory function. Sexual functions are not going to be much different in any of these procedures. The second thing is too much stress has been given to local anesthesia. All these patients are young, fit. Why not to give a short GA to them instead of giving a local anesthesia and giving him a discomfort? Somebody may go back and say, it was a horrible experience for me. So I think so that should be stressed only when patient is not fit for anesthesia. The resume is basically has come for the patients who are high risk cardiac problems, who are cardiac reserve, anesthesia cannot be given, then only you can do under LA or sedation. Otherwise, the company also recommends to do it under anesthesia actually, And ejaculation, Eurolift is the way which has come now. And I think so that may have some future because it has got a long-term data is available, 5 to 10 years now. So thank you very much. All of you have.
We had prepared 2
did
minutes
justice to
rebuttal
your
also.
topic.
So we had prepared 2 minutes rebuttal also. Can we present that, sir?
Rebuttal is not required actually in this topic. And one thing more, the last thing which I want to tell you, what I will do, I will tell all the 4 procedures to my patient, explain to them everything, and let him choose what he wants.
Thank you.
Now we come to the second side of debate. That is the LUT score system. Are they needed? And we have very good presenters, Dr. Samir Trivedi and Siddharth Yadav. I invite Dr. Samir Trivedi in the favor of the LUT scoring system.
Good evening, respected chairpersons. Thanks to Nordzone, Dr. Rishi, Dr. Swapan for the opportunity. And coming to the topic, so what we are considering is thinking of doing away entirely with scoring system for LUTs. Now, really, we are thinking of a word where we do not want to have scoring systems at all for LUTs evaluation and management. Let's look at the advantages of scoring systems in LUTs. There are many and all of us are aware of them. I just want to briefly recapitulate what all of us already know. These scoring systems give you a standardized method of assessment and which helps in a consistent evaluation, diagnosis, and which can be passed on across different urologists in different settings. It gives you an objective criteria of quantifying the patient's symptoms and which can be more reliable, which is more accurate than just relying on your memory of what the patient had told you. Even the patient doesn't remember what he had told you last time, and the doctors definitely don't remember. Then scoring systems are very good for monitoring the patient's disease progression. If you have prescribed him some therapy, be it lifestyle measures, be it medical treatment, and when the patient comes back, comparing the baseline with the subsequent scoring system gives you a fair idea of how your therapy is working. Then for treatment planning, we all know that according to the mild, moderate, severe category of IPSS, recommendations can be given regarding the proper treatment, which is suitable for that particular patients. And of course, the scoring systems are invaluable when it comes to clinical trials. Since morning, whatever trials or whatever studies you have heard on this platform, almost all of them had mentioned IPSS at some point or the other. So scoring systems lay the foundation on which all the clinical trials are based. All our evidence regarding efficacy of surgical options, efficacy of medical treatment, they have all been based on improvements in scoring systems. And of course, we can communicate much better with our patients with scoring systems. We can explain to them about their condition and what are the treatments that can be offered. Most of the scoring systems include a quality of life question, which of course helps in because that is the main thing that we are trying to address. And in some countries, insurance reimbursement is based on documented severity of symptoms as assessed by these scoring systems. There are thousands of studies which have focused on the utility of scoring systems. I'll just rush through a few of these. What are the benefits of scoring systems beyond the obvious ones? So this study showed that there is a significant positive correlation between IPSS and the objective parameters like prostate volume, detrusor wall thickness, PVR, Qmax, and so on. This study showed that patients who had higher IPSS as presentation were more likely to develop complications of BPH. So you can think of planning your treatment in a better way. This study showed that the correlation of prostate volume was much better with IPSS as compared to other things. And therefore, they recommended that management of BPH should be based on patient symptoms, scoring systems, and not on the size of the prostate. And this BMJ Open Systematic Review looked at all the ways in which LUTs are evaluated. And I've just taken the portion concerning the various scoring systems. And they found a decent level of evidence to support the validity as well as reliability of scoring systems in evaluation of LUTs. And this study showed a direct correlation between IPSS and the quality of life. And this study showed that patients' IPSS scoring had a direct correlation with the prostate volume. So there are so many studies which have looked at other aspects of these scoring systems. And this international consultation on male LUTs, which included names like Paul Abrams, Christopher Chappell, and Klaus Rohrbond, and they gave a very strong grade A recommendation to both IPSS as well as the ICS male questionnaire. And looking at the current guidelines, 2024, EAU, strong recommendation, AUA, again, strongly recommended. Our own USI guidelines, strong recommendation for use of IPSS for evaluation and management of these patients. But as in life, nothing is perfect. These scoring systems do have their limitations, and I'm sure Siddharth is going to tell you in great detail about those limitations. So what we need is to focus on what these limitations are, what are the drawbacks, the way this critical review did, and they also suggested some modifications which can be done to improve these scoring systems. And that is probably the need of the hour. Rather than doing away entirely with scoring systems, we need to find out the flaws, we need to improve upon them and continue using them. So to summarize, despite their limitations, scoring systems play a very, very important role in assessment, follow-up, treatment monitoring of the patient. And rather than using them in isolation or relying only on them, they should be used to complement other methods. And of course, they are an invaluable research tool and they should be continued to use. Thank you.
Now I invite Dr. Siddharth Yadav for their motion against.
Can I have my slides, please? Yeah.
It will be interesting to know. अभी तक हम सब लोग it was a traditional teaching for getting the IPSS. Now we will get the how it is not important.
Good evening, respected chairpersons, teachers, and my dear friends. I will be speaking on the topic, LUT scoring system. No, they are not needed. So all the advantages of LUT scoring system, objectivity, standardized, reliable, valid, reproducible, are actually important and relevant in the research setting. In the clinical setting, when a doctor interacts with the patient, he's thinking about what is the diagnosis, what investigations should I order, and how should I plan the management of this particular patient. However, none of these scoring systems are diagnostic. They casually omit the diagnostic questions which could have found out the cause of these symptoms. Besides, at best, they only perform marginally better than single directed questions and thus cannot replace the proper history taking. Besides, different diseases will have similar scores. Thus, to conclude, these scores do not have any differentiating potential in finding out the reason of the LUTs. Secondly, these scores do not correlate well with objective parameters like Qmax, voided volume, and PVR, and they cannot replace or suggest the further investigation, and further evaluation would be required irrespective of the score obtained. Finally, they are quite likely called as scoring systems and tend to categorize patients into mild, moderate, and severe. However, the current guidelines suggest that they have no role in the management of the patients. The guidelines ask us to qualify whether the symptoms are bothersome or not. And if the symptoms are bothersome, treatment is advised irrespective of the score. And the kind of treatment is given depends upon the symptoms and not the score itself. Besides, there are 28 low-interact symptoms defined by the ICS Standardization Committee, and there is no scoring system that captures all of the symptoms. There are a plethora of scoring systems available, and choosing the right score for the right patient is actually a tedious task. These questionnaires are self-administered. A variety of questionnaires are available in vernacular languages. But can these questionnaires bring out really what they are supposed to? Look at this Indian study. Patients tend to overestimate their own scores. Thus, the reliability of these scores in accurately classifying the patients is actually doubtful. And if you think illiteracy of Indian population was the cause, look at this Dutch study, which just included literate patients and divided them into patients with adequate and inadequate health literacy. They found out that 80% of patients who were literate but had inadequate health literacy could not answer the IPSS. This significantly undermines the importance of scoring systems in the management of the patients. Designers of these questionnaires overestimate the responders' knowledge and skill, leading to these findings. They are also marked by various problems such as recall bias, cognitive abilities, willingness to report, cross-cultural differences in perception about questionnaires. We Indians don't believe in written directions. We tend to stop our cars and ask where we need to go. Finally, all the recommended scoring systems by ICS are narrative in nature. They do not give a total final score. They are primarily aimed at collecting the data by the paramedical staff who lack in-depth knowledge of the subject. In clinical practice, it is more efficient and less time-consuming to ask the patient. If one is supposed to evaluate these scores, he will have to spend a lot of time in evaluating that booklet and converting the data into a usable information. That is why we use them clinically. And also, there is a patient's perspective. A lot happens in those 5 minutes of OPD besides the general transfer of information. The patient wants to be heard. He wants to express his pain and emotions. He expects empathy from the doctor. And this results in building of trust, which finally forms the doctor's-patient relationship. And trust can't be built with sheets of paper. So to summarize, these scores are non-diagnostic, do not help in selecting the next line of investigation. There is no role of management. They are marred by reliability issues. Thus, they are not needed in the current clinical practice. Thank you.
Thank you, Dr. Siddharth. I am sure that the debate has been very interesting and audience has the key. What percentage of urologists sitting here are using this IPSS scoring system? In practice, yes. Okay.
Sir, Dr. Samir.
So what is the reliability? Why the others are not using? Anybody can answer. The people who have not raised their hands, anybody would like to answer?
The issue with using IPS scores or any other scores is there are 2 or 3 issues. Even a urologist will find it very difficult to fill it up. So when an average patient comes in, he has to be tutored what to be filled up. So it's very cumbersome, time consuming. All of us actually, without using the IPS score, use our own criteria where we ask similar questions and we basically have to look whether he's having voiding or storage LUTs and treat accordingly. So not using the IPS score per se is, or any of the other scores, is because it is cumbersome and not easy to fill. And secondly, in IPS score, there is no scoring on the degree of bother. He might say he's having nocturia, for example, but the degree of bother is not mentioned there. So the degree of bother is also a very important criteria, which is
the 8th question is also there.
So, yes, Dr. Rishi would like to say, yeah.
So while it is true that any IPSS or for that matter, any other scoring system may not be as that reliable, but there is no doing away with these scoring systems if one is academically oriented. And this is the only way that you can, this provides actually a way to weigh in the subjectivity of the patient. Otherwise, there is no other way that we can quantify the subjectivity that the patient is presenting to us.
How Dr. Samir follow this? How you follow in your institute? Do you give the paper before coming to the OPD? Patient has to fill this, or you ask your resident fill it? Or how you follow it?
No, the ideal way is for the patient to fill it. So once he comes, he is given a.
Which
printed-
language you have got the questionnaire?
Both, sir, Hindi and English, both.
Hindi and English both.
And the visual, nowadays we are using a visual IPSS quite often.
Picturometer.
Yeah.
Point I just like to highlight, like if it is filled by patient, then definitely there is a lot of confusion. As it is proved by studies also, if a medical personnel or clinician is helping, then it is more reliable, this symptom score.
Then it becomes like
So what I am doing in my practice, I am routinely asking these questions, but I'm not asking patient to. It simply takes 2 minutes. It is systematized. I'm asking to the patient and I simply write down on my prescription pad only 7 symptoms, and so that I can compare. So this is very crucial. Exactly. So in each and every patient, it hardly takes 2 minutes.
So thank you very much. Again, for the research purpose, the scoring system is very important to compare the efficacy of the drugs which you are using or any modality of treatment. But in clinical practice, I think so history taking and significant questions, whatsoever is there, that you have to write down on your prescription, so that next time when he comes, you can follow him up with that, whether he's improved in these symptoms or not. I personally do cross questioning of the patient. Last time you said this time you are saying this, is that right or wrong? So I think so personalized questionnaire is much better than using IPSS score in clinical practice. Thank you very much. Thank you very much.
Thank you, Chairperson, sir, and all the speakers for making this session a very lively one. We move on to our clinical case discussion session. For this, may I invite the chairpersons and the panelists, Dr. Anand Sehgal, Dr. Subhash Yadav, Dr. Mayank Mohan Agarwal, and Dr. H.S. Pava, and Dr. Anil Helens to please moderate the session.
Good evening, everyone. We have got some routine cases which are seen in the OPD and nothing very hi-fi about these cases. The original set of 6 panelists has now been reduced to 3, and we have 3 of the originals, and Dr. Pava has stepped in and will be representing Samit, Salim, and Pampos. So you are 3 in 1, Dr. Pava. So we'll get moving without wasting much time. The first patient is a 76-year male who presents with inability to void for 12 hours. 12 hours ago, he had an in-out catheterization for retention, and ever since that catheterization, he's not been able to void. He gave history in the emergency of voiding storage LUTs for 3 months, and he was being advised an alpha blocker, tamsulosin, for this time. There was nothing very significant in his history and examination. At that point of time, he underwent an ultrasound, and so that's the ultrasound. I hope you were able to see it. There was some overlay. I'll just play it again. The upper tracts was fine. This was the ultrasound of the bladder, and this is what you see. And there's a static image of that same. So we'll start with some quick questions. So, Dr. Pava, what do you feel the patient has?
So the exact size of this, if it is a small multiple small diverticulum, then definitely one can give a trial for voiding trial. But if it is sizable exactly, if it is a large diverticulum, so that patient may need definitive care for diverticulum.
I can't hear you very properly. Can you speak a bit louder?
If it is like, I would like to know the number of diverticulum, volume, and location. So sometime if there is a small diverticulum, multiple small diverticulum, in that scenario, definitely I will like to.
Anyway, this patient was in retention, so he was catheterized, 1250 ml urine drained, and he was sent home. Was that the right thing to do? Dr. Mayank?
1215 ml.
To start with, yes, because such a over-distended bladder, we will need time. And in the ultrasound, I could see that bilateral lower ureters are dilated. So
Yes.
he's likely to have had bilateral hydroureter.
The upper tracts were the lower, the upper tracts were not. The kidney PCS was fine.
Yeah. And I am assuming that there was no constipation and neurological examination was normal. He doesn't
Yes,
have any
it
neurological
was.
problems, all those things. So I think to start with, catheterization is a good thing to do. And then we can put him on CIC and go for.
So he was sent home. He comes back, Anand, next morning with hematuria. Why did it happen, and could you have prevented that hematuria?
Yeah, hematuria most probably must be because of sudden decompression of the bladder. Retention volume was high, and that could have been prevented by slow decompression.
So this was, which has been a traditional teaching, that when you're decompressing a over-distended bladder, we have to do it slow, staged. Otherwise, the patient would have tendency to have hematuria or hypertension. But we have had many of these, even a meta-analysis here. So this is more of a myth rather than the truth.
Yes.
So there is no way that a slow decompression is going to prevent hematuria. So that's the point I was trying to highlight. So this is more of a myth that a slow decompression would prevent either hematuria or hypotension also, which are two possibilities. The only thing which you could have done is rather than sending the patient home,
Yes.
keep him in your facility rather than sending him home.
Yes.
And tell him that there is a possibility that he
And-
might have hematuria.
And another thing which I think I missed that sent home part, because such a patient, one is hematuria, second is we don't know his creatinine, maybe he will go into post-obstructive
Correct,
diuresis
correct.
and that needs to be managed.
Yes, correct. So that there was a mistake that he should not have been sent home. That was the point which was I will. So obviously over a period of time with some fluid intake, he was only on a tamsulosin. A 5-ARI was added. His urine cleared. Now, Subhash, what investigations? The routine lab urine CS was done. They were all within limits. Anything specific you would like to see in this patient?
First of all, I would like to say, sir, urine cleared with fluid intake and 5-ARI is anybody's guess, because and 5-ARI overnight in a small prostate, will it?
No, this was not overnight. He came with hematuria. He was prescribed.
Yeah.
While he was being
urine cleared with
investigated,
time.
the urine cleared with time, not immediately. Obviously, not immediately.
I think we have to do the urodynamic study now to see.
Prior to urodynamic, he had hematuria. Would that hematuria will just
after hematuria is over now.
So my question to you is, if a patient who has been catheterized has hematuria, would you presume it to be decompression, or would you like to investigate the patient further?
No, I did not understand your question.
A patient who had clear urine, you catheterized, and we just had a talk that we just discussed that at the speed at which you decompress would not prevent hematuria. So would you presume the patient's hematuria was only because of decompression, or would you like, and he had diverticular, Mayank noticed dilated lower ureters. Would you like some other investigation?
I would like to get CT also, because there was on ultrasound there was a at the neck of the diverticulum there was some echogenic shadow. So I just want to rule out any other cause of.
Okay, the CT was done, had the diffuse thickening because of a long-standing obstruction, moderate prostatomegaly, a diverticulum as was seen, and type 1 cyst. Nothing else was seen. Any role of cystoscopy, Dr. Pava?
Definitely, as I earlier pointed out, for assessment of this diverticulum, sometimes we may need.
So what are you looking for in a cystoscopy? Diverticulum we have seen on ultrasound. So what exactly you're trying to look for in the diverticulum?
With CT scan and with this.
You had a CT which also didn't show.
I couldn't pay attention to that. So what I'm telling you, after change, again, shifting from PGI to Fortis, if the process size is more than 100 gram, I do motivate the patient for transvaginal prostatectomy with the robotic assistance. Because you see that everything nuclear, because I don't want to work in the urethra. I'm not expert for homium, like maybe Tanuj may be having different thought, and I think that will generate good question for you. So it's more than 100, it's 110. We have virtually seen that patient has no cancer in the prostate. So I will offer him the transvaginal prostatectomy without any androgen. So now this is the scenario. So now if you want to intervene later on, the patient has no compelling reason for surgery at the moment. Okay, you can buy time, maybe 1 month, 2 months, depending on, again, Eurobarometer is bothersome. And a residual that he has no UTI, maybe you can give anti-androgen in the form of dutasteride, which had not been tried earlier. People have tried even LHRH and agonist also for doing the thing. So you can practice this, but you have to tell the patient, this is not a standard of care. This, because you know the science, you can practice for the benefit of the patient. Ultimately, patient had to choose. New things generate like that because if you have idea. So you can, if you want transvaginal resection of prostate to be done after 3 months, I will give one injection to him, maybe pamorolene or maybe leuprolide, whatever. And then you do surgery later on. We have done in PGI also. The patient prostate, his staff member, came to me, again, a stenographer of, again, Professor S.K. Sharma, wife, Dr. Meera Sharma, and he requested transvaginal resection of prostate. So he tell you, no, I don't want to get open 180 gram prostate. So one injection was given, and I did resection of one lobe. And then second sitting, I did second, because he didn't want any surgery. So ultimately, depend what you intend to do for the patient, what you intend to do for the patient, and then how you can help the patient applying all medical science or your knowledge for the benefit of the patient. So I think I have told so many things, maybe audience maybe get confused. What I'm trying to say, you apply your mind, you apply your knowledge for the benefit of the patient. Ultimately, between you and the patient, the decision should take.
Yeah. So message is clear that
there are plenty of studies which have shown
postpone or delay the surgery, then anti-androgen is good. So literature also shows that the anti-androgen therapy with 5-alpha reductase inhibitor causes reduction in prostate size, and it reduces the hematuria episode by decreasing the vascular angiogenesis episodes. So we all know that the action of dihydrotestosterone, it's a key androgen in the prostate, and it binds strongly to the androgen receptors, promotes the prostatic growth, and it affects the cell function also. And these 5-alpha reductase inhibitors, they inhibit the action of dihydrotestosterones, and they reduces the prostate by 90%, this dihydrotestosterone level. They reduces the prostatic DHT level significantly by decreasing the serum PSA level also. And majority of the PSA reduction occurs in the first 3 months of treatment. So only if you are planning pre-operative, then only the hematuria part it can take care of. If you want that it reduces the size, then minimum 3 to 6 months of treatment is required to have a 20% reduction in the prostatic size. So these are the studies which can support. So references. So going to the next slide, because this has
those two are different aspects. See,
Yes,
when you want to reduce the size of the prostate to help you do surgery, is you will have to give for a longer time.
Yes.
If you want to reduce only the episodes of bleeding, then 2 weeks is much more is sufficient.
Yes, that's what I am saying.
Yeah, actually, at that point of time, I would like to tell, don't be assured that the prostate will shrink inside the palpable. This efficacy may be only presently 70%. Some patients I have seen taking dutasteride for 10 years, their prostate had gone from 35 to 101 grams. So this never be, again, assured by prescribing the medicine. All of these patients and see whether the size is decreasing or not. Usually it's common description that 30% the prostate reduction will be there in 3 months if the dutasteride or finasteride is started. But this doesn't happen in every patient. So that's why it is your, again, duty to see whether it's happening, the aim is being fulfilled or not by follow-up. So that's also important.
They have their side effects, which have to be spoken about to the patient. There can be gynecomastia, painful gynecomastia, and of course, decreased libido and erectile and issues. So these have to be discussed with the patient. Otherwise, they come back with a surprise. Doctor, what is this? I did not expect this to.
At the same time, I don't know how many of the audience They are again aware of finasteride syndrome, finasteride related syndrome. Sometimes it can cause suicidal tendency. So again, dutasteride has not got that side effect, but finasteride has got side effect. It has been studied later on. Yes, around 5% people can have that sometimes depression, or maybe having suicidal tendency. So that's I wanted to make you know that.
So due to lack of time, I moved to case 2. So this is a 60-year-old patient with complaints of voiding LUTs. For last 1 year, he had history of taking the alpha blocker for 1 year, but patient did not report improvement in the symptoms. History of coronary artery disease diagnosed 6 months back, and he had history of drug-eluting stent for single vessel disease 3 months back, and he is on dual antiplatelets. Examination is normal, and there is a grade 3 prostate, non-nodular, non-tender. Patient is not responding to alpha blocker treatment, and he is on antiplatelets. So workup was done, and workups are almost normal. Serum PSA is 3. Euroflow, the Qmax is 6.5, and average flow is 3.4 with a volume of 230 ml and PVR of 80, showing a restrictive pattern. Film is not available, and ultrasound shows a mild bilateral hydrouretronephrosis and a thickening of bladder wall with no calculus and prostate of 90 cc. So what will be the management plan? Dr. Tanuj?
See, first of all, I'll repeat ultrasound of upper tract with the empty bladder. Because this bilateral hydronephrosis might be because of over-distended bladder.
That can be one possibility.
Yeah, because
definitely.
PVR is not very high.
Yes.
So that is one thing. He has undergone angioplasty and a drug-eluting stent 3 months ago. So at least for 6 months, he needs to continue dual antiplatelets.
So in each and every drug-eluting agents, you have to wait for 3 to 6 months, or you can have, depending on the type of agent we are using, means 1 month or 1 year, or it is fixed that 6 months you have to wait for
Our
that.
cardiologist generally prefers to wait for 6 months. And in his case, even if we are opting for surgery, it's an elective surgery. So patient can wait for 3 more months. We can stop one of the antiplatelets and then plan.
Yes.
Of course, he'll be a case for HOLEP.
So definitely, there
That's
is no
correct.
emergency.
You will have
so
to
can
look
wait.
at the risk. And if it's a newly put stent, if the patient can wait for some more time, it's better to postpone surgery for some more time than offer him immediate surgery.
So, sir, does these patients who are antiplatelet, you stop the treatment, you stop them, then do the surgery, they have some effect during the surgery that they encounter more bleeding, or they have some side effects when we compare with a normal
Depends
patient?
on the drug which he is taking. There are different category of drugs which are given to these patients. So you have to look at each of those drugs, because if he's on warfarin, it takes a longer time. If he's on drugs like aspirin and clopidogrel, at least 5 to 7 days, you will have to stop. There are newer anticoagulants which are 2 to 4 days, 2 to 5 days, which act. So you have to look at whether he's on newer direct anticoagulants, whether he's on warfarin, whether he's on aspirin. You have to look at these drugs and then ask them to withdraw according to that half-life.
And the newer agents are very dangerous. You don't have any antidote for them. For example, if a patient is on warfarin, you can still, do it. But with the newer agents, and they come in so many different names and so
Yes.
many different brands. So we should see the medication chart of the patient. We should, if required, Google it and see what are the drugs he's on, and discuss with the cardiologist whether they can be stopped or not. On EcoSprin 75 and 150, we have operated many times, not an issue. On 2-3 occasions, I have had to do surgery on clopidogrel also, but those are the cases who had recurrent hematuria, clot retention, and we had to do it. Enucleation, laser enucleation we could do, but we do not prefer as a routine to operate on clopidogrel. The newer agents have to be stopped. If at all we have to do a surgery, then we have to do bridging in order to do it by stopping the antiplatelets.
SK Singh, sir, if the patient is, so which type of treatment you offer in these patients? You stop the antiplatelets. So whether you opt for laser surgery or bipolar TURP?
I think
These mode of treatment after
90 grams.
90 grams.
The laser surgery will be better in this case. So laser enucleation, the prostate will be better. So the patient is on ecosprin, he can continue up to 75 milligram. Sometimes the cardiologist say, no, you can't do surgery. and the creatinine is going high. And the creatinine in this case is only 1.2. So no, you are not worried. But patient has bilateral hydronephrosis. You have started the patient on medication, means you have given alpha blocker as well as dutasteride. So now we'll follow him up because residually in 88, he has already ruled out that patient has no concomitant stone or anything else as the cause of hydronephrosis. That need to be assured because patient has not significant residual urine. But patient bladder wall is thickened. That can be due to poor compliant bladder also, the hydronephrosis, but we don't know. So it is your onus falls on you that there should not be any other cause of hydronephrosis.
Okay.
But same time, explanation is that patient has got this. Now, this patient is on anticoagulant. Sometimes cardiologist says, oh, you can't stop anticoagulant. So you can switch over to small molecular heparin.
Warfarin.
Yes.
type.
Yeah. Yeah.
Low
Now,
molecular
yeah,
weight.
Low
heparin.
molecular
low
weight.
molecular weight
Short
of
actings.
heparin. Yes.
Yes.
Low molecular weight of heparin. And then you stop it 24 against 12 hours on the day of surgery. And then you can restart after 24 hours.
Okay.
So after surgery.
So
But only that
yes.
you have to be very meticulous during surgery. That there should not be any bleeding. You try to prevent it, but it can happen.
So definitely literature supports what our panelists have said, that current guidelines recommend a 1 month of dual antiplatelet therapy for bare metal stents and 1 year for drug-eluting stents. So you have to talk to the cardiologist which type of stents they have put. An elective surgical procedure should be postponed. In this case, as you see, this is an elective surgical procedure until after initial treatment requirement for DAPT is completed. And it can be postponed according to the type of stents which are being placed. So these are the recommendations of perioperative antiplatelet managements. Depending on the type of procedure, you have to categorize the patient on the low, moderate, and high risk. And on the basis of that, on the type of procedures, preoperative modifications of these antiplatelet drugs can be done. And in this, TURP comes under moderate risk. And you have to discontinue both aspirin and clopidogrel for 5 to 7 days before procedure and restart within 7 days if there is no concern of post-operative bleeding. So this is what is recommended. And this is what I have talked. If there is a life-threatening situation, as Dr. Sir, S.K. Singh sir said, that you have to switch to some fast-acting, short-acting heparin so that you can bridge the time and do the procedure safely. And Cochrane review has said that the laser treatment methods with TURP is definitely beneficial and reduces the overall risk of the transfusion. But should I go for the third case, sir?
Even in lasers, if you can have the option of a KTP laser, it's much better than the other lasers.
Yes. Yeah. So case 3 is a 65-year-old patient with complaint of voiding LUTs for 1 year. And he had history of recurrent AUR in the last 6 months and history of CAD diagnosed 2 years back. And history of angioplasty for double vessel disease 1.5 years back. And he is again similar to the earlier patient, dual antiplatelets. But this time he is an episode of recurrent hematuria, AUR in the last 6 months. So this is definitely a case of emergency because if you leave the patient, he may again get into the retention. So prostate is similar, 100 cc. And so definitely what type of, actually this case has been discussed that you have to do some bridge therapy and then treat the patient.
And
Any other opinion?
He is a patient who is 1.5 years post angioplasty. So we can actually safely stop one of the anticoagulant and we can operate on Ecosprin 75 or 150 as well. Choice of treatment will be laser prostatectomy because of 100 cc prostate as well as anticoagulants.
So you want that you can operate the patient on aspirin?
Yes, definitely.
And you stop clopidogrel. But if it is
Clopidogrel has to be stopped.
okay. And what about the role of low molecular weight heparin, short acting? You can thank all my panelists. Thank you very much.
Thank you, Dr. Umesh. So with this, we complete the sessions for the day. Give us a few minutes before we set up the stage for our inaugural function, which is we will be starting in 5 to 10 minutes or so. So please bear with us, stay in the hall. And meanwhile, may I take this opportunity to invite you for our next physical meeting, which is going to be our annual North Zone UCCon. It is going to be held at Gurgaon. Dr. S.P. Yadav as the organizing chairman and Dr. Santosh Kumar as the organizing secretary are also here. If you want to register for the conference, you can use the QR codes or maybe just contact either one of them. Thank you. So we'll just set up the stage.
Dr. Atul Mittal and Dr. Sapan Sood. May I request Dr. Sapan Sood, the organizing chairman, to kindly come and give the welcome address to the audience.
Good evening, everybody. I welcome you all to BPH 360 degrees, a conference held to increase the awareness regarding the newer technologies in one of the oldest maladies of the male kingdom. I welcome all the faculty who have come from as far away as Vijayawada, from Jaipur, from Kota, from Bangalore, from so far away places, not to mention all those who have come from as near as Chandigarh. Half of the Department of PGI is here. And I welcome all the senior dignitaries, Dr. Kim, Dr. Yadav. They are here, Dr. Arvind. They are all here. And many of my friends have also come on, Anshuman, Malik Arjun. They are all here to help me grace the occasion, not to mention past presidents, Dr. Bora and other important dignitaries in the audience. I welcome you all to BPH 360 degrees held in honor of the 50th year of the Patel Hospital, which I've been working all this time. Thank you so much.
Thank you, sir. Even though we had a Microsoft shutdown yesterday and many flights got cancelled, but still on behalf of the organizing team, I would like to welcome everybody to this thing. They traveled all different, they had some difficulties, but they made it to us. Thank you, everybody. Now, may I request Dr. Rishi Nair, the Honorary Secretary, NZUSI, to kindly give the secretarial address.
Good evening, everybody. Today is actually quite a moment for me in Punjab. As you may or may not be knowing, I also belong to Punjab and this is my ancestral land. There is a Noor Mahal pinned nearby Jalandhar to which I belong. So this is kind of a homecoming for me here. And this occasion also happens to be Dr. N.P. Gupta being the chief guest, who is my teacher and guide and mentor, whatever you may call it. Whatever I have learned urology is under him only. And then when I first started my practice in urology at an institute other than AIMS, it was under Dr. Rajiv Sood. So again, he also happens to be one of the person who has a great role in my mentoring in my earlier days. So thank you so much, sir, for accepting our invitation today, Dr. N.P. Gupta, sir, and Dr. Rajiv Sood, sir. Thank you so much. So I would like to actually thank the organizing committee, especially Dr. Sapan Sood and Dr. Atul Mittal, who actually made my task much easier. You see, the Punjabis are known for their hard-working attitude and being actually active, really very enthusiastic workers. So my task was really made easy by both of them. Whenever I contacted them, they made sure that whatever was needed was made to happen. So thank you once again. As regard the scientific program, it was again the seed for it came from Dr. Sapan Sood only, that we should cover the entire spectrum of BPH. This is something which is not usually covered in most of the conferences. And there are many new modalities which are now available. So therefore, this was something which we needed to update ourselves on. So we tried to cover all aspects of BPH. Today you saw all the surgical modalities that are available, and these surgical modalities have gone to the extent of actually competing with the medical treatment itself. Now there is a role of patients who what we thought was a candidate only for the medical therapy. Now we have modalities where we can think of offering some of these surgical modalities to these kind of patients as well. And so to fulfill our goal, we were fortunate that we had the faculties from not only the North Zone, but also from the entire country, Dr. Malikarjun, Dr. Dheeraj, Dr. Pankaj Maheshwari, Dr. Shreyas. They have traveled far and wide. Unfortunately, Dr. T. Manohar could not join us today. But he was gracious enough to join us online and do his part of presentation for the resume procedure. So thank you, the faculty which have come outside the zone. And I am totally indebted to our own North Zone faculty who have been so actively involved in this program to have made this such a successful one. Thank you so much. Tomorrow we have again faculty from outside as well as India coming. Dr. Arun Chawla and ISU course is planned tomorrow for both the ultrasound as well as the urodynamics role in the management of BPH. And we are also going to cover some of the aspects of overlapping aspects of CA prostate and BPH. So all in all, we would be covering the BPH 360 degrees in its true sense. Such was the actually enthusiasm and activity in the organizing team that we actually ended up creating a program which went beyond our time limits. And we actually had a program lined up till 5 p.m. tomorrow, but we had to curtail it down to bring it to the limits of what we could do. So anyhow, I think we have been overall able to manage and cater to your needs and desires for the day, and hopefully we will be continuing to do so for tomorrow as well. As of now, organizing team has also made sure that our stay is comfortable enough in the city, and we are enjoying your hospitality, sir. Thank you so much once again. As I said at the beginning, also it's a homecoming to me, and I welcome you all to this midterm workshop of NZUSI. So, and as it is said in Punjabi, Ji Ayanu. Thank you so much.
Thank you, Dr. Rishi. Indeed, this was a 360 program which has been crafted very well by the NZUSI Council and the Secretary. I would request the hall to give a loud round of applause for the organizing team as well as the NZUSI Secretary. May I request Professor N.P. Gupta, sir, to kindly come and give us some words of wisdom to the audience, please.
Dr. Rajiv Sood, Dr. Pritpal Singh, Swapan Sood, Dr. Rishi, Dr. Atul, and Dr. Goyal. At the outset, I'd like to thank Dr. Swapan Sood for inviting me for this program. It's a matter of great pleasure and proud for me that my all students are sitting here and each one of them has done wonderfully well in their career. And you can see to what height they have reached. When I got the brochure and I read BPH 360 degree, so I was really very much excited to see this topic. The region is where we started. I started my surgical career in Jabalpur Medical College in 1970 when I joined MS post-graduation. The prostate surgery was only open prostatectomy, maybe 1 stage or 2 stage. After that, when I joined All India Institute in 75, it was again open prostatectomy and TUR prostate was just started by Dr. Mansingh. At that time, I have seen him doing TUR prostate with that brush bulb and like that. then came fiber optic, and then came the lasers, then came all this minimal invasive surgery. Now, why there are so many things? It is very important that our knowledge, the pathophysiology of the LUTs, we have understood well. So the most important thing, the message which I want to give you all is when to operate and when not to operate. So this is very important that every patient does not need operation. When you have to properly evaluate the patient and decide who really is going to be benefited by the surgical procedure. After the decision that yes, patient needs a operation, you have to see what is the patient factor, what is the disease factor. According to that, you choose your technology. Now, one technology doesn't fit for all. So, unfortunately, because of the industry pressure, if somebody spend money and buy one particular instrument, they start using that instrument for every patient, which is not correct. So, according to the patient, according to his other comorbidities, according to the size of the prostate, then you choose which technique you want to do and do it well. First, you become master of that technique. So again, the same thing, man behind machine is more important than how you do it. Whether you use TUR or laser or HOLAP or green light or now these new technologies, you have to be perfect in doing that. Unless you do a good job, outcome is going to be very poor. So this is the two message which I want to give. Select out a patient who needs surgery and how you do it what best you can do for the patient. You should keep patient factor in your mind, not the all other aspects. With these words, I like to congratulate Dr. Swapan Sood and his team for the hard work. And Dr. Swapan Sood has really made his career in such a way academically, professionally, as well as administratively. And today he's becoming like an icon actually for the success in the urology. So thank you, Swapan, for all. And I'm very happy to see, I know you since last 25 years now and how you have progressed in urology. All the best to you and your family forever. Thank you very much.
Thank you, Gupta sir. May I request Dr. P.P. Singh to kindly come step forward and deliver the presidential address.
Good evening, Chief Guest, Dr. Rajiv Sood, Guest of Honor, our dear teacher, Professor N.B. Gupta, my council members, Dr. Swapan Sood, other dignitaries on and off the dais. Now, I welcome you all to this second CME of this year, which is being conducted at Jalandhar. And it is so heartening to see that despite of so many problems, so many people have come into this meeting. And such mid-term meetings provide the conference with scientific excellence and great attendance, apart from the social and the cultural atmosphere. And I'm sure this conference is no way less in that. The aim of this conference, BPH 360, is to focus on the new modalities in the treatment of BPH, which I feel is required, especially because of the complications which are associated with the gold standard treatment, surgical management of TURP. And I'm sure these various modalities are going to find their space. And they have been so well executed by the experts during today's meeting. We have all the experts who have been teaching various modalities of management of BPH. And I really congratulate Dr. Swapan Sood and Dr. Atul Mittal and his team. They, throughout the day, 4 theaters were running. Total number of 16 cases were operated in a flawless manner. There was not a single stoppage in between. There was no wastage of time. And I'm made to understand just now that all these patients were done complimentary without any cost. So Patel Hospital has done a wonderful job in helping us conduct such a wonderful conference, and which has led to learning from each other. Apart from meeting, we there are so many good lectures in the conference, and friends, there is much more to come tomorrow. Apart from this, there is a workshop on neurodynamics. We have learned about the perineal biopsies, the fusion biopsies. There are so many good lectures and interactions are there. I cannot name each and every one, but it is such an effort. I thank you all for coming to this conference. Friends, apart from this, we had a North Zone Care activity in which Dr. Shailendra has taken a lead, of course, with the help of Dr. Rishi Nayyar, and it was done at Agra only last month. Again, in that NZ Care, we did almost 23 cases, absolutely free of cost. And I think this is a step forward towards helping the community and making our presence felt in the whole of world. And I am announcing that we are trying to do one more North Zone Care within this year before the annual conference. Friends, the annual conference is not far away. It is being organized in the city of Gurgaon under the able leadership of Dr. S.P. Yadav and Dr. Santosh. And I assure you, this conference will again be one of the best conferences of the North Zone. It will be well attended. So I welcome you all to the next conference also. Thank you very much. Long live North Zone USI.
Thank you. Thank you, PP Singh, sir. But PP Singh, sir, forgot to mention there is a one extracurricular activities which is planned for Baku from 28th September to 2nd October, which I think so all the members should actively participate into it. Prior to this, we had gone to Vietnam, and this is a very good bonding between the members that happens, and it's a family too. May I request the chief guest, sir, Professor Rajiv Sood, who's the Vice Chancellor at Baba Farid University, to kindly give the address to the audience.
Thank you, Dr. Kamal. Respected, revered Professor N.P. Gupta, my teacher, President of North Zone, Dr. P.P. Singh, and Secretary Dr. Rishi Nayyar, the organizers, Swapan Sood and Atul, Shailendra, the treasurer, and all the respected past presidents who are sitting here, Dr. Kim, Dr. Yadav, Dr. Ashok Sharma, Dr. Anil Vashney Alliance, Dr. Bora. I think in front I can see all these past presidents. I'm so happy today that in North Zone, this UE activity, I'm welcoming you to my Punjab. Now it is my Punjab. I bring greetings from Baba Farid University of Health Sciences, and which has 168 institutions under it. And the education transformation is going on very fast. Those who are from Punjab, they must be appreciating that what are the changes which are coming. I joined in July last year, and this is again July when I am addressing all of you. North Zone has a history of very strong and very eminent journey amongst all the zones of India, Urological Society. And in this journey, I am happy that right from it was going on before me also, but in this journey, right from the registration of the society, it as society, and also running it from Delhi at that time, and after successful Silver Jubilee, and after that so many conferences happened, and one after another milestone has been achieved. Prostate is the buzzing word today in the conference, in this theme-based conference. And I remember those days in 2007 when Dr. N.P. Gupta was spearheading the prostate disease awareness program, and I was appointed as the national convener. And that time we were telling even doctors that they should be aware about the prostatic diseases. Otherwise, it was the debate. I remember when Dr. Madhu organized the debate, bullet versus knife, that is tablets or knife. And from there, we have graduated and we have reached to a situation where there are so many therapies. And prostate is one gland. If cancer of prostate is there, then you have hormonal therapy, you have surgery, you have minimal invasive techniques, you have so many tablets, you have polytherapy for that. You have now mist and Eurolift, which we are discussing here. And also, we have for prostate cancer, hormone, chemotherapy, radiotherapy. Chemotherapy also was not there before 2004. And these all are added. And then it was in our campaign, which we launched all over India, it was said this is a small gland, but big problem. This was the slogan. And ultimately, we have reached today, this day. I'll just touch on one more aspect, that education and training and research and technology, they are changing so fast. I am representing here in Punjab in the National Medical Commission. As Vice Chancellor, I am nominated to the Governing Council. And from Delhi also, Delhi Medical Council, I am the nominated member in National Medical Council. And what is happening there? 2019, we started competency-based education. In 2020, National Education Policy has been declared, and I am happy that whatever are the components of National Education Policy 2020, where we are targeting 2047 as education to become the global leader, the India to become the global leader. In that direction, the education policy has certain components which are very successfully implemented by Urological Society of India. The components which are there, they range from education. Now it is not education, it is competency-based education. Right from the didactic lectures to the show how, and also to create experts through the skill training. And that those all components which the nation has realized and integrated into the education system, various this MCI and then National Medical Commission has integrated. We were doing that all even before that. And we were on the right track. Like after education is the research. Research is totally revolutionized, and now it is integrated in the MCH and other programs of urology, that unless you complete these trainings and exposure to these programs, you cannot get promoted now. And this will be integrated in the National Board of Examination also. So research has also become very important. In addition to, you have touched in your program on epidemiology, data collection, data processing, innovations, technology integration cannot be any better other than urology, what is happening. And latest additions are artificial intelligence, robotics, computers, these programs, they all are based on that. So in 1 or 2 years, anybody who is not concentrating in their on this, whether you are the trainee or you are the trainer, you have to concentrate and revolve around your lectures, your presentations, integrating your artificial intelligence, virtual reality, and also telepresence. And tele-surgery has also started. Dr. Sudhir Rawal has recently operated sitting in a remote office, and he has operated in the, it was all in the books. It was that I remember when we were students in All India Institute, one of the symposium was on telepresence and robotics and operations, but that has become reality a couple of months back. And I also inform you that in addition to these conferences, after the struggle of 75 years and after failing twice, we are able to bring Society International Urology Conference in India. And I think in our lifetime, this is going to happen, and it will not be happening in our lifetime again, because there are so many countries, 130 countries are there. Everybody is struggling to host this conference. This is 23rd to 27th of October. One good thing is that anybody above the age of 65 can become free membership, and for them there is a special prize. And whether you attend the conference or not, free membership should be taken immediately. And also all the residents, whether MCH or DNB residents, they can also become the member. And in collaboration with Urological Society of India, North Zone and Delhi Urology Society is hosting it. Dr. N.P. Gupta is again patron there in that, and all the stalwarts here are here who are going to work for this conference success, and this will give another name and another level presence of urologists amongst the world leaders in urology. So, having said all this, I'll only remind you that now whatever you are doing, it is for employable education, training, research, and execution by creating the human resources. This is in one statement, I have said many things. So it is very important to understand that human resources, India was considered as population explosion like atom bomb and all, but this has been converted into the asset. The population is asset. We have to create and inculcate the skill in the all the trainees, and then skill refinements who are already skilled, upskilling, which you are doing all here. That is the another buzzword, and ultimately outcome-based education and training and research is our ultimate goal. And with this, when I say that you are educating, you are making MBBS, you are making MD, MS and all, and then you search for a job or the thing that should not be the goal. We should not be driving to the direction that unorganized teaching training is done. We should, instead of teaching training for employment, no, it should be employable education, employable training, employable research. And if we can create our human resources, they will be utilized in the domestic market in India, and then our country will become the hub, the skill hub of the world. And this is what is happening at center. Government of India has opened the skill industry where Mr. Jant is the minister, and Skill Council of India is also working in that direction. Punjab University has become the hub on hub and spoke model. And I'll suggest that all the branches, USI, the zones, the state level, we should work as hub and spoke model, that one center training and then in outreach you reach as spokes all over the state, all over the zone, all over the country. So these are the few words which I wanted to share with you, because these are the latest trends in teaching, training and research for plus integration of technology. I'm repeating, to create the usable workforce and where we become the skill leaders, global leaders in the world. With these words, I thank all of you for bringing this topic again into focus, the prostate. And it is very important, and so many aspects can be discussed here, and you are discussing and you will continue discussing tomorrow. All the best to Punjab Urology Society, Jalandhar Urology Society, and also North Zone and the urology in the country. Thank you very much. All the best for the continuing program. Thank you.
Thank you, Professor Rajiv Sood. Sir, we welcome you in Punjab, and sir is doing a commendable job as Vice Chancellor at Baba Farid University. Now, may I request Dr. Atul Mittal to kindly come forward and deliver a vote of thanks.
Chief Guest, Dr. Rajiv Sood, Guest of Honor, Dr. N.P. Gupta, President, Dr. P.P. Singh, Secretary, Dr. Rishi, my friends, Sopan, Shailendra, my teachers in the hall, my seniors, and my dear friends. On behalf of Jalandhar Urology Society and on behalf of organizing committee, I humbly introduce the vote of thanks. First of all, I thank the President, Dr. P.P. Singh, Dr. Rishi, and the entire Angel USI Council to giving us the opportunity to host this conference, the midterm CME. Actually, we were the bidders for the annual conference, but due to Dr. S.P. Yadav's emotional statement at Bikaner, we lost by a few votes. But we are happy to arrange the midterm CME in Jalandhar. Then I thank our chief guest, Dr. Rajiv Sood, who has accepted our invitation and graced the occasion and enriched us with his wordings. And next is Dr. N.P. Gupta, sir, who again agreed to be the guest of honor and graced this occasion. Then I thank all the faculty, the international faculty, Dr. Nikhil Vasudev, and next one is Dr. Dean Alterman, who will be presenting the lecture tomorrow. I thank all the operative faculty who have come all the way to demonstrate excellent cases, either on laser, mist, everything. I also thank the online speakers, Dr. Sanjay Sinha, Dr. Sudhir Rawal, Dr. T. Manor, who could not make to the conference, but they demonstrated the semi-live procedures during this conference. Then I thank all the faculty who were as the speakers or as the chairpersons. I thank on behalf of the Urology Society and organizing committee to every one of them. Success of the conference is not complete only with the faculty, but it is also with the delegates. So I thank all the delegates who have come all the way in big, large number. And there are more than 125 or 150 registrations in this conference. So I thank every one of them from the core of my heart. Then I thank all the faculty who missed. Yesterday there was a glitch and the many faculty who started from their homes, went to the airport, and then they came to know that the tickets are cancelled. Then they tried to arrange the train tickets, but they could not make it. So it was a sorry affair, but I thank from the organizing committee for their efforts. Then I thank the Patel Hospital to allow us to organize this conference. Dr. Sharma, Dr. Chopra are there in the hall, and the entire anesthesia team, OT staff, ancillary staff, nursing staff, every one of them for conducting the suppletive session flawlessly in this day. Then I thank all the industry, all the vendors, because with their help, we were able to organize all these cases free of cost today. And then I thank the pharma industry because without their financial help, this conference could not have been possible. Then I thank again the NZ USI, Dr. Rishi, for this excellent scientific program and during the day for conducting this conference exactly on time. It is the efforts of Dr. Rishi. A big clap to him. Then I would like to say about the General Urology Society. This is the 10th program which we are holding in the last 10 or 12 years. So it's an effort from our side to hold one meeting during a year. And now we are at about 25 to 30 members, and SOPAN being the forefront. And I thank every member because with their active cooperation, we are able to hold this conference. So I may have missed somebody, but I am sorry for that. But I thank everybody, even if I have missed somebody. So in any conference, there are some shortcomings. And if there are any shortcoming in this conference, I fully take the responsibility. But there is always a scope for improvement, and we will try to rectify these shortcomings and hold a better meeting or an exact perfect meeting next time. That is our goal. Thank you. Thanks a lot.
Today, we started at 8 a.m. in the morning, and the program, if you read the scientific program, the dot, it was supposed to finish at 8 o'clock. It's 10 minutes to 8. May I request all the gentlemen to kindly rise for the national anthem? Thank you. Thank you, everybody. The dinner and the hot drinks are waiting for you. Thank you.